Good morning, everyone. At the outset, I would like to thank
Present aims New Delhi, aiming to provide an update on current aspects related to patient blood management. Patient blood management. It is an evidence based, patient centered, systematic approach aimed at optimizing patient outcomes by managing and conserving the patient's own blood. And this works in tight collaboration with various special aiming to provide an update on current aspects related to patient blood management. Our next speaker is Dr. Rajendra Chaudhary, sir. Sir will not be able to join us due to some previous commitment. So, sir will be joining us online.
Sir has actually sent a recorded video because there was some urgency at home. So we'll play that video. He has joined online. So if any questions are there, he'll take them online. Just
Yeah, I think
Yes, yes, sir.
okay. Yeah, thank you. I think thank you, Dr. Richard. It was a wonderful talk. Yeah, I think you very well
Copy.
said that we need to identify the champions and then create the culture. So yeah, good morning, everyone. I think I welcome Dr. Krishna Kumar. I think amongst us who has just arrived, and he is the key officer in charge in Ministry of Health and Family Welfare, looking after transfusion services in the country. Welcome, sir. Now I hand over mic to my co-chair, Dr. Ravneet Kaur, to introduce the next speaker.
So, I think all of us know the next speaker, but it's my privilege to introduce him. He is none other but Dr. Rajendra Chaudhary. He's chairman of Technical Resource Group, DGHS Government of India, chairman of Project on Blood Irradiation by Ministry of Electronics and IT India. He's recipient of Lifetime Achievement Award and J.R. Jolly Award by ISBTI. He's a course coordinator for IHBT National Board of Examination, New Delhi. He's founding secretary of Indian Society of Transfusion Medicine. Sir, I welcome you. I think we need to start his recorded version, and
Yes,
he's there online with us.
yes.
Okay, so welcome, sir. Good morning, sir.
Yes, good morning. Thank you.
So I think we'll be just having the recorded version of sir's presentation.
Yes, ma'am. I'm putting it on.
Good morning, everyone. At the outset, I would like to thank Dr. Hemchandra Pandey and Dr. Gopal New Delhi. The topic which is allotted to me is to identification of the barriers to screening of preoperative anemia and iron deficiency, and we will discuss what are the strategies to implement. Now, if you look at the WHO definition of anemia, that is hemoglobin less than 13 gram per dl in males and less than 12 gram per dl in females. So considering this definition of anemia, the global prevalence of anemia is extremely high. This data is from WHO in 2016 that there are about 3 billion people all over the world with anemia. And the commonest cause of anemia in the general population is iron deficiency and other micronutrient deficiencies. So you can see that almost 40% of the world population is suffering from anemia. And at the same time, there are about 600 million people who are suffering from some bleeding disorder, acute or chronic bleeding disorders, like obstetrical hemorrhages or coagulopathies or trauma, hemoglobinopathies, and the bleeding will also lead to anemia. So you can see the magnitude of the problem that the anemia is very, very common in general population. Now, coming to the preoperative anemia, that is the anemia before in the patient undergoing surgery. So this article is published in Blood Transfusion in the year 2015, and you can see they have included various kinds of surgeries like colon surgery, gynecologic, cardiac surgeries, vascular surgeries, urologic, and orthopedic. The prevalence of anemia ranges from about 30% to 50%. So the average prevalence of preoperative anemia in various kinds of surgeries is about 30 to 40%. This is a very beautiful study which is published in the journal Anesthetist. And here it's a huge number of patients, more than 65,000 patients over a period of 20 years. And they have evaluated preoperative anemia. And the WHO definition of anemia was included in this study. So you can see that the incidence of anemia, preoperative anemia, increases as the age advances. So, and in the female, it is more as compared to male. So the patients who are elderly, like about more than 80 years of age, in both male and female, the incidence of preoperative anemia is very high, to the tune of 20 to 25%, and and above 90 it's about 30%. So you can understand the incidence of preoperative anemia is very high. This is yet another study. There are some 7 studies, and they have evaluated the prevalence of anemia in surgical patients. So in elective surgery, in preoperative anemia, the prevalence ranges from about 20 to 75%, as high as 75%. In cardiac surgery patient, 24 to 26%. In non-cardiac surgeries, about 30 to 40%. In orthopedic surgeries, about 19 to 38%. And colorectal surgeries, it's about 70%. So this is well understood because the patients with colorectal surgeries, they have bleeding problems and that can lead to anemia. So again, this highlights the prevalence of anemia is very high in the patients who are undergoing some major procedures. Now, what are the causes of this preoperative anemia? So basically, you can divide them into 4 categories. The anemia may be because of the blood loss, anemia due to inflammation, anemia could be due to nutritional deficiencies, or anemia due to medication. Like blood loss could be iatrogenic, repeated blood sampling, or bleeding, or patients undergoing hemodialysis. So there is a loss of RBC and that leads to anemia. Inflammation, the patients who are having chronic disorders, morbidities, so there is a secretion of interferon and the TNF alpha, and there is acute kidney injury, and therefore there is a decreased production of the erythropoietin, which suppresses the bone marrow, and that leads to anemia. Nutritional deficiency, it's well understood that the deficiency of iron, vitamin B12, and the folic acids, that will lead to anemia. And certain medications like metformin, which is used for diabetes, as well as the proton pump inhibitor. This is one drug which is used for treatment of gastric ulcers. Is known to cause anemia and patients who are undergoing chemotherapy. So you can see that there are major 4 causes of anemia before surgery or the preoperative anemia. Now, why we are worried about anemia? Because anemia is a disease in itself, and it has been established that there is a triad of risk factors for adverse outcome post-surgery. So that triad consists of anemia, blood transfusion, and the blood loss and bleeding. And they are all dependent on each other. Like anemia will need blood transfusion, and blood transfusion itself leads to adverse outcome. And the blood loss will lead to anemia. So this is a kind of cycle. So this is a triad of risk factors for adverse outcome after surgery. So there are various studies published in the literature where they have found that the outcome after post-operative outcome is poor if there is a existing preoperative anemia. So preoperative anemia is associated with 22% longer hospital stay as compared to those where there was no preoperative anemia. 1.9 times higher risk of infections, post-operative infections, is very high if there is a preoperative anemia. 3.7 times higher risk of renal damage, kidney injury. So that is associated with preoperative anemia. 2.9 times higher risk of mortality in the patients who have preoperative anemia. And 2.9 times more risk, or you can say more need for blood transfusion if there is a preoperative anemia. So you can see that, and blood transfusion is associated with again adverse outcome. So you can see that there are various serious complications which are associated with preoperative anemia. So this is one very beautiful meta-analysis which is published in the British Journal of Surgery in the year 2015, where they have tried to find association between preoperative anemia and the mortality after surgery. So almost 1 million patients were studied. They were included. 24 studies were analyzed in this meta-analysis. And as per the WHO definition of anemia, 39% of these patients, 1 million patients, were anemic. And the anemia was associated with mortality, increase in the number of acute kidney injury, increase post-operative infections, increase in the stroke in after cardiac surgery, and increased need for RBC transfusion. And the RBC transfusion is associated with again adverse outcome. So this again established the fact that preoperative anemia is associated with adverse outcome. So now the theme of this CME is the patient blood management. So all of you are aware that the concept of three pillars of bone marrow, PBM, and pillar number one basically is concerned with optimizing the hematopoiesis and the red cell mass. And in the preoperative phase, the most important thing one has to do is to screen for anemia, detection, what is the cause of anemia, management of underlying disorder causing anemia, treatment of iron deficiency, treatment of anemia of chronic disease. So this is the major component of patient blood management preoperatively, and it is important to note that anemia is a contraindication for elective surgery. So if the patient is undergoing elective surgery, which is not urgent, then it is better to postpone the surgery or reschedule the surgery after the anemia is corrected. So this is the first pillar of the PBM, which deals with anemia detection and the management. Now, how do you manage the preoperative anemia? So basically, there are three things. Oral iron. Oral iron is given when the hemoglobin is less than 13 gram in males and less than 12 in females. Ferritin level is between 30 to 100 microgram, and it is a non-urgent surgery. That means it's a planned surgery. Then you can give oral iron. So for obvious reason, because this will take time to make its effect, to increase the hemoglobin, the oral iron will take time. So it is only given for the non-urgent surgeries. IV iron is given when there is a hemoglobin less than 13 in male, less than 12 in females. Ferritin level is less than 30 microgram, and urgent surgery. So it's an emergency surgery. Then IV iron is preferred. And blood is given only when the hemoglobin is less than 7 gram per dl. Along with there are signs of respiratory and the hemodynamic decompensation. So this is how you manage the preoperative anemia. Now here I would like to point out one thing, that unfortunately in India, majority of our patients, they come under this category. The preoperative hemoglobin is many a time less than 7 gram. So unfortunately, our anesthetists and the surgeons, they have to ultimately decide to give blood transfusion. Very few patients, they have more than 7 gram of hemoglobin in our country. So this is the thing we have to discuss, or we have to ponder upon, that blood transfusion is very difficult to avoid in our Indian population. Use of erythropoietin in preoperative anemia. So there are few studies in the literature, like this study where they have done the systematic review and the meta-analysis about the use of erythropoietin in cardiac surgery. And they recommend that they found that there was a significant reduction in the use of allogenic blood transfusion in cardiac surgery if the erythropoietin was given preoperatively. NATA guidelines also recommend that erythropoietin should be used for anemic patient in whom nutritional deficiencies have been ruled out. So, or it has been corrected, because iron supplementation should be provided along with EPO to optimize the response. So if there is a iron deficiency, then erythropoietin alone will not work. So along with erythropoietin, you have to provide iron supplementation also. However, you have to use this erythropoietin with some caution, because there are concerns regarding harmful effects such as hypertension, thrombosis, ischemic attacks, and this is because of increase in the hemoglobin, and that will increase the viscosity of the blood, and that can cause all these complications. So erythropoietin is, though it is helpful, it is associated with some harmful effect. Now, the second part of my talk is there are some common misconceptions with regard to diagnosis and the management of preoperative anemia. The commonest misconception is that the prevalence of anemia in surgical patients is similar to the general population. So why we should worry about this? The general population as well as the surgical patient, they are same and the prevalence is same. However, this is a myth or this is a misconception. Regardless of cause, the global anemia prevalence in the year 2010 was about 32% or 33%. So this was the WHO figure. About 33% of global population is suffering from anemia. However, in the patients who are undergoing major surgery, the prevalence of anemia can reach up to 75%, depending upon the comorbidities, the gender of the patient, the age of the patient, underlying pathology, which is needing the surgery. So depending on all these factors, the prevalence of preoperative anemia can go up to 75%, while in general population it is 33%. So this is one misconception with regard to preoperative anemia. The second misconception is that, particularly among the clinicians, like surgeon and anesthetist, that preoperative anemia poses no risk to the patient, and the scheduled procedure should not be delayed because of its presence. So this is again a misconception or the myth. We have already seen in the previous slides. I have shown you very beautiful studies, meta-analysis, that preoperative anemia is independently associated with worse clinical outcome. And they recommend that whenever feasible, the surgery should be, the anemia should be corrected before the surgery is planned. And this would require rescheduling the major surgical procedure wherever possible. So this is the second myth, that preoperative anemia does not cause any harm to the patient. The third misconception regarding preoperative anemia is that management and like detection of anemia, diagnosis of anemia, then management, it negatively impacts the workload. That means it increases the workload of our already busy clinician and the anesthesia people, and it is not cost effective. So this is a misconception with regard to preoperative anemia. However, detection of preoperative anemia before surgery can be accomplished using very simple routine laboratory parameters. It does not require any big equipment, or it does not require a lot of expenses. And so without increasing the healthcare workload of the healthcare people and the hospital budget, anemia can be diagnosed and can be corrected. And remember that autologous blood transfusion is not free of charge. So autologous blood transfusion, which is the second option, if somebody doesn't want to give iron and correct the anemia by giving transfusion. So autologous blood transfusion is not free. So it is also not cost effective. So this is a misconception that preoperative anemia management will increase the workload. So that is, and it is not cost effective. So this is a misconception. Then this is a very important thing to understand. The fifth misconception, that WHO definition of anemia, that is hemoglobin less than 13 gram in males and less than 12 gram in females. So this is valid for both male and female who are undergoing surgery. So the definition is same for patients who are undergoing surgery for male and female. However, you must understand that the females have lower blood volumes than males. However, the same procedure performed on either gender often result in comparable amounts of blood loss. Therefore, when measured as a percentage of circulating blood volume, the blood losses are higher in women and may result in higher transfusion rate. So, for example, so the patients presenting with pre-op hemoglobin less than 13 gram, irrespective of gender, should be considered as anemic. So the definition of WHO that in females the anemia is less than 12 is not applicable in patients who are undergoing surgery. So here you can see in this second bar chart the hemoglobin was preoperative hemoglobin was 11 in female and in male, but you can see the transfusion rate was higher in females, was up to 49 or 50, almost 50%. In males, it was less than 40%. If the preoperative hemoglobin was 12 in both the genders, but still the transfusion need was higher in females and as compared to males. So this is because the females have a lower circulating blood volume, and in for the particular surgery, like for example cardiac surgery, both the genders, patients of both the gender will lose the same amount of blood. But since the circulating blood volume in the female is lower, it will result into more anemia and will need more blood transfusion. So this is very important to understand that patients who are undergoing surgery, the definition of anemia should be less than 13 gram per dl, and the WHO definition may not be applicable. And this is the last misconception, that given that ID, that is the iron deficiency, is the most common cause of preoperative anemia, so it is not a big deal. Simply you can give the preoperative oral iron and will always be effective. But this is not always true. Though iron deficiency is the commonest cause, anemia of chronic inflammation is also common in old patients with comorbidities. And you know that the mechanism of anemia in chronic inflammation or chronic is different. In this patient, it is due to inhibition of iron absorption and reduction of iron metabolism. So these patients will not benefit with oral iron. So it is important to understand the diagnosis of anemia, what is the cause of anemia, and oral iron may not be effective always, because the patients with chronic disease will have different mechanism, and this will not be cured by oral iron. And another misconception is IV iron is hazardous and should only be used for treating severe preoperative anemia. So, though there is some truth to this statement, because the earlier preparations of IV iron were associated with some serious adverse effect, like severe anaphylaxis or the necrosis or infection or inflammation at the venipuncture site. And sometimes even necrosis of that skin was observed near the venipuncture site and resulting into thrombophlebitis. So, but with the newer preparations of IV iron, the adverse effects of this treatment is less. So it is no more that hazardous as it was earlier. So IV iron is also safe for management of preoperative anemia. Now coming to the third part of the talk, what are the barriers for screening of preoperative anemia and iron deficiency, and what are the strategies to implement the change? So here in the literature, I did a Google search, and I found that there were 4 or 5 very beautiful articles published in the literature on the same or similar topic. So for example, this is one publication, Preoperative Anemia Iron Deficiency Screening, Evaluation, Management, Barrier Identification and Implementation Strategy. This is published in Journal of Multidisciplinary Healthcare in the year 2020. Another article from the same author, it is published in Journal of, again the same journal, and it is also dealing with the management of preoperative anemia and what are the approaches. The third article is published in British Journal of Anesthesia in the year 2015. Again, here they tried to find out the barriers and how to overcome those barriers with regard to preoperative hemoglobin optimization in surgical patients. And the fourth publication which I saw in the literature is overcoming the barriers to evidence-based patient blood management. So this is a review, systematic review. So these are 4 basic publications on which my future slides are based. That is identification of some barriers and how to overcome these barriers for optimization of hemoglobin in the surgical patients. So you should now understand that the preoperative anemia management in surgical patients is a teamwork. So it is not just one person responsible for this. So there are many stakeholders in the team. This team, it is also called as perioperative medicine. So in perioperative medicine, there are anesthetist, there is surgeon, there is a nursing staff, administrative staff, that is the executive staff of the hospital, and patient himself. So this is very important. The patient himself is also a part of this management of preoperative anemia. So this the first stakeholder in the as a barrier for pre-op screening is the patient himself. So what do we expect from the patient? That he should comply with request to repeated blood test for detection of anemia. And once the anemia is detected, then what is the cause of anemia? So we need to do repeated testing. So patient should comply with this request. But what is the barrier in this? There is no knowledge about anemia or screening of anemia before surgery in the patient. They don't have any access to the knowledge about anemia screening before surgery, and they are very reluctant to come back for blood testing. For example, if you do the hemoglobin and it is less than 13 gram, then next step will be to find out the serum ferritin and the other markers of iron deficiency. So for that you will have to do the repeat testing or repeat sampling. So the patients are reluctant to come back again and again for blood testing. So these are the barriers. Now, what are the strategies to overcome these barriers? So we have to conduct educational meetings involving patients and their family members. We have to develop some educational material for the patients and distribute them among the patients who are undergoing surgery. You can prepare a patient information sheet with regard to iron deficiency that I'll show you in the next few slides, some examples of patient information sheet. You have to provide education during pre-admission phase. So here the role of nurses is very important. When the patient first comes to the outpatient department, the management of or the preoperative anemia screening starts there itself. So in the first visit, when the patient comes to the OPD, the nurses who are posted in that OPD, they should start providing education to the patient with regard to the screening, importance of screening, and the management of preoperative anemia. And we should also involve the family members of the patient in this management, and periodically you should obtain the feedback of the patient. So these are certain strategies to overcome these barriers for preoperative screening and management of anemia. So the patient is the first stakeholder. Now, second important stakeholder in the perioperative management of anemia is anesthetist. Now, what is the action we anticipate from the anesthetist? That they should initiate treatment for anemia using either oral iron or IV iron, depending upon the urgency of the case. Like if it is a planned surgery, then can be given oral iron, or if it is urgent surgery, then IV iron can be given. And the blood transfusion should be withheld as far as possible. And second, if blood transfusion has to be given, then restrictive transfusion threshold should be used. So these are the action we anticipate from the anesthetist. Now, what are the barriers for this? So again, the knowledge and the personal belief of about the intervention. This is very important. Personal belief, I'll show you in the next slide. The personal belief of the anesthetist with regard to intervention. The intervention here is management of anemia using oral iron, IV iron, and detection or the diagnosis of anemia. And then there is a wide variation in the best practice of anemia management among the anesthetists. So these are the two main barriers for preoperative anemia screening for anesthetists. So what are the strategies to overcome this problem? The conduct again educational meetings, develop evidence-based guideline for anemia management, including use of IV iron. Then the PBM coordinator should ensure that all perioperative medicine teams are educated about the intervention. The intervention which I mentioned already, that detection of anemia, diagnosis of anemia, and the management. And the regular audit should also be conducted with regard to practices, transplant practices of the anesthesia people. So these are two studies with regard to variation in the peri-op transplant practices of the anesthesia people. So in this study, the anesthesia people were asked a question that with respect to the indication of a red blood transfusion, what is their attitude? So about 0.2% said that they are very generous in giving blood transfusion. So they don't mind giving blood transfusion to the patient, even if it is can be managed with oral iron. So just 0.2%. 16.6% were rather generous. So they would not mind in giving blood transfusion. But good thing is that about 65% of them, they said that they are rather restricted in giving or restrained giving blood transfusion. And 18% said that they're very cautious before giving blood transfusion. So you can see that there is variation in the practice, variation in the belief, their personal belief with regard to blood transfusion. And this is another study here in the same hospital and same type of surgery. There is a variation in the transfusion rate. So there were 7 anesthesia people in the same hospital, and they were operating. The surgery patient was undergoing cardiac surgery. So you can see that there is a variation in the transfusion rate. So like this anesthetist number 4 has the lowest transfusion rate of about 30%, and this one had about 50%. So you can see that there is so much of variation in the transfusion rate for the in the same hospital and for the same kind of surgery. So this is because of the personal beliefs of the anesthesia people with regard to blood transfusion and their knowledge about blood transfusion and the preoperative anemia. So these are the very serious barriers, and we need to overcome these barriers using the strategies. The third stakeholder in the perioperative management of anemia is the transfusion specialist or the pathologist. So the pathologist or the specialist should perform the laboratory test in a timely manner. So that means once the anemia is detected, the second is to do the ferritin and then other markers of iron deficiency. Streamlining the process to enable add-on screening. Add-on screening means once the anemia is detected, then additional test like you might need transferrin saturation, you might need ferritin, you might need to do serum iron. So these are add-on screening. So the pathology should ensure that the processes are streamlined. Once the anemia is detected, automatically the sample should go for additional testing. And then communication with the clinician about the results. So the pathologist or the transplant medicine person should communicate with the clinician to provide them support with regard to the clinical decision making. So these are the 3 actions we expect from the transplant specialist or pathologist. So the main barrier which has been found in the various studies is the resources, the crunch of resources. The pathologists, they don't have resources with regard to add-on screening. So it is this is the main barrier, and obviously the strategy to overcome this barrier is to provide new funding, additional funding. Now, nursing staff also plays a very important role in the preoperative anemia screening. So what is their action we expect from them is the check the test result. So they should check the results of the lab test and facilitate the treatment or referral to the hematologist or for further treatment. Educate the patient about anemia and the importance of correcting the anemia before surgery, and liaison with the physician when blood may not be needed. So they should liaise with the physician. So when the blood is needed or when it is not needed. So these are the main actions of the nursing staff. And again, what are the barriers? They have no access to the knowledge and information. Many of our nursing staff, they are not knowledgeable about this, and networking and communication. So this is again a very serious hazard. There is a blockade in the networking. Like nursing staff, they would be reluctant to talk to a senior physician or senior anesthetist if he prescribes a blood transfusion, and nursing staff thinks that blood transfusion is not needed in that particular patient, but she would be very reluctant to talk to the senior person. So blockade of networking and communication is a major barrier. So what are the strategies? Again, provide education and training to the nursing staff in the pre-admission phase only, that is at the time of admission of the patient, when the patient comes to the OPD. So they should educate the patient with regard to anemia screening, importance of anemia screening. Nursing staff nursing staff to inform the patient of the reasons for screening, that is again education of the patient, and promotion of the network viewing. So this is the overcoming the strategies. And lastly, the role of executive staff or the administrative staff. So what we expect from them, they should endorse the policy procedures, they should provide funding, they should encourage engagement between the various stakeholders of the team, and they should monitor and report progress. So that is the regular audit they should be doing. So what are the barriers? Again, the access to the knowledge and information is not available, resources are not available. And very interestingly, in one of the studies, they found that the structural characteristic of the hospital, that is whether the hospital is a public hospital or a private hospital, that also affects the outcome. And when they say that the implementation of this program of preoperative anemia screening is easier in private hospital as compared to public hospital. So structure of the hospital also affects the success of this pre-anemia screening program. And for this, you have to conduct the educational meetings, promote network viewing, organize the meeting of the stakeholders. So here you can take the help of STCs, and new funding has to be you can obtain from the CSR or other areas. So access new fundings. So this slide summarizes various barriers like access to the knowledge and information for patient, nurses, anesthesia people, and the executive staff. There is less knowledge and information about the preoperative anemia. Then misconception and belief about the intervention, which we have seen already in the last slides. Resources are not available. Networking and communication is not good. So these are the major barrier for successful implementation of preoperative anemia screening. So implemented strategies to overcome these barriers. So we have to conduct the meetings, educational meeting, develop some educational material, and that should be distributed among various stakeholders. Preparation of patient information sheet. So patient information sheet, there is one example, but unfortunately this icon is not working. And involvement of the patient as well as their family members, obtain the patient feedback with regard to this program, new funding, promotion of the network viewing, and organization of the meeting of the various stakeholders. So these are the implementation strategies. So key factors for implementation of preoperative management. You need dedicated interdisciplinary patient bed management committee. You need support from senior hospital management, commitment from surgical and medical disciplines. There should be an access to the knowledge with regard to anemia management, transfusion indications, what are the alternatives to transfusion, and knowledge of clinical and the pre-clinical management. So these are the various key factors of for the successful implementation of preoperative program, anemia management program. So I would like to conclude my talk that preoperative anemia is prevalent among surgical patient, varies from 30 to 40%. In very elderly patient, it can even go up to 75%. And this preoperative anemia is associated with postoperative morbidity, mortality, prolonged hospital stay. Preoperative anemia is one of the most important predictors of red cell transfusion, and which in turn is also another risk factor for poor outcome. So the patients who are anemic, they will need red cell transfusion, and red cell transfusion is another risk factor for poor outcome after surgery. Iron deficiency is the main cause of preoperative anemia. So, but other causes like surgery associated blood loss, inflammation can also cause preoperative anemia. Then it should be detected, classified, that is what is the cause of anemia, and it should be treated prior to major surgery. And this may even result into postponement of non-urgent surgery. So the surgeon or the anesthesia people should not mind in postponement of the non-urgent surgeries. So they should give time for the management of preoperative anemia. So, however, there are barriers to all this, mainly due to lack of knowledge and information among the various stakeholders. The stakeholders are patient himself, anesthetist, surgeon, transfusion medicine specialist, nursing staff, and the administrative staff. So, the main reason they have discussed in those 4 or 5 articles is lack of knowledge and lack of information. And finally, the involvement of the patient is of paramount importance. So, unfortunately, in our country, a patient is sidelined patient is not given any importance in the management of preoperative anemia or for anything with related to patient himself, like about surgery. We don't inform our patients in detail. So involvement of the patient is also very important for successful management of preoperative anemia.
Uh, Thank you, sir, for an informative talk. And I think you very rightly said that for the management of this preoperative anemia, communication and education of all the stakeholders is very important, and especially the patient who is our primary stakeholder in the situation. I think we can open the question.
Yes,
Yeah, do we have time for questions right now or
there is one more talk.
one more after this? So we'll have after the,
Yes,
so you have after the next talk, sir.
we have one more.
One more
This.
talk. After
I
this,
think
we
we have
have,
on the
Yeah.
so we can continue, sir.
Yeah, so I think before we move to the next talk, we would like to welcome esteemed Professor Shiv Chaudhary, who is Chief of the Transfusion Cardiothoracic and Vascular Surgery at CM Center on Nature Medical Sciences. We thank you, sir, for your presence here. And as you know, this is a patient blood management. So I think his presence today makes, adds more to this conference because clinical colleagues are an equal important element in this as far as well as a transfusion medicine specialist. Thank you and welcome you, sir. So the next speaker in this session is Dr. Surya Kumar Bodo. He's additional professor in neuroanesthesiology and critical care at All India Institute of Medical Sciences. And he has more than 100 publications, 6 chapters, and reviewer of many index journals, and editorial board member of various journals. And he is a very instructor for various courses in physiology. So we welcome you, Dr. Bobo, and we would love to hear you the next talk.
Just take a second. Yes, pointer तो नीचे नहीं sorry. Good morning, everyone. Before I start, I would like to thank the organizing team, Dr. Hem, Dr. Gopal, and my dear friend Rahul for making me a part of this interesting and CME. I have nothing to disclose to start with, and starting with introduction to this topic, that we need to screen the patients for blood loss in the perioperative period. Assessment of bleeding risk is a key component of patient blood management strategies to minimize blood loss. And having said that, what are the common reasons for increased risk of bleeding in perioperative setting? One is advanced age. Second is decreased preoperative red cell volume. That means small body size and or preoperative anemia, as nicely highlighted by my previous two speakers. Medications affecting hemostasis, including complementary medicines. Medical conditions causing hemostatic defects, including both hereditary bleeding disorders and acquired medical conditions such as chronic kidney disease or liver failure. And lastly, and one of the most important, is type of surgery. We just cannot consider all the factor keeping aside the type of surgery when we are discussing about the risk of preoperative or perioperative blood loss. When I was searching these contents, I came across these two articles which were most often discussed and cited. One is from British Journal of Hematology, and second is practice guideline from American Society of Anesthesiologists. So my presentation is basically, I have taken major chunk of my discussion and presentation from these two articles.
Whenever we are discussing about screening for preoperative blood loss, we start with review of previous medical records and conducting a patient and family interview. We have to review the available lab reports that includes hemoglobin, hematocrits, and coagulation profile reports. We have to order additional tests based on the patient's condition, if at all, if it's needed. Then we have to conduct a physical examination of the patient to ascertain the current status of the patient before the surgery. So starting with the first component, that is reviewing of previous medical records and interview with patients and family. It includes previous blood transfusion. What was the need? Is there any complication associated during the blood transfusion? History of drug-induced coagulopathy. Is that the patient is receiving any kind of medication that can hamper either blood coagulation or platelet functions? Presence of congenital coagulopathy. History of thrombotic events like deep vein thrombosis, pulmonary thromboembolism, and is there any risk factor for organ ischemia? Because if it is a case of, suppose a case of coronary artery disease or ischemic heart disease, then these patients, if the hemoglobin levels or blood levels are down, then it can adversely affect the patient outcome, irrespective of the kind of surgery. So both the British Committee of Standards of Hematology and American Society of Anesthesiology, they have both recommended that there is a need for both clinical and family history of bleeding, details of medication which may impact on bleeding wherever we are screening a patient for perioperative blood loss. So we have to collect initial bleeding history, including personal and family history of bleeding disorders, excessive bleeding, and comorbidities which may increase the risk of bleeding. And if the history is positive, then we have to assess the bleeding scores with bleeding assessment tool, or what we commonly call as a BAT. Now, in short, what exactly do we mean by a bleeding assessment tool or BAT? And why at all, if at all, we need a BAT? The evaluation of bleeding symptoms is well recognized challenge for the physician because the reporting and interpretation of bleeding symptoms is subjective. Whatever seems to be a minor for you, the patient or the family may report it as a major. Second, mild bleeding events commonly reported by patients both with and without inherited bleeding disorders. There are certain problems of the current diagnostic tests for testing minor bleeding disorders. As a result, bleeding assessment tool has been developed and studied in variety of clinical settings in an attempt to standardize and quantifying bleeding symptoms. And the goals of BAT is to improve diagnostic accuracy, thereby avoiding unwarranted level, predict the risk of bleeding in the individual patients, describe the symptoms and severity, and inform the treatment. The components of BAT includes a clinician-administered questionnaire, standardized bleeding history, and incorporation of a bleeding score. That is, bleeding score is based on grading of each symptoms episodes utilizing a bleeding score table, and the total score indicates the likelihood of a disorder. There are variety of BAT scores available there, but most commonly practiced and used are the International Society of Thrombosis and Hemostasis BAT score. It is an exhaustive scoring system, including lot of parameters that includes spontaneous bleeding events and bleeding after hemostatic challenges. And the worst event in each of these clinical category is taken as a to calculate the bleeding scores. And the cutoff limit for adult male is 4 or more. For adult female is 6 or more, and in case of children is 3 or more. But there are certain limitations of using a BAT because BATs are predominantly used and validated in research tool to identify patients with von Willebrand's disorders, and platelet function disorders present a particular challenge due to lack of a standardized approach to interpret platelet function testing. And we should not forget that BATs have never been intended for use in severe bleeding disorders such as hemophilia. The instruments are designed to be administered by trained clinicians. Further study would require to assess the acceptability of self-reporting of symptoms by the patients. And the exact cutoff of abnormal score has not been established for many of the conditions, and it depends upon the patient's age, gender, and clinical settings. So after we took a history of the bleeding risk factors and the comorbidities of the patients, one of the important things that often we come across is medication affecting homeostasis. The common medication that that affects the hemostasis are antiplatelet agents like aspirin, clopidogrel, and NSAIDs. Sometimes they are started in individually or in combination. Anticoagulants like warfarin, heparin, and NOACs, that is novel or newer oral anticoagulants. I'll discuss briefly about those agents also, because these are the agents that are now very commonly used, and we often encounter patients receiving NOACs. Let's not forget complementary and alternative medicines. They also hamper your hemostasis, and the most common reported agents are garlic, ginseng, ginkgo biloba, and danshin. And there are certain compounds in many of the complementary alternative medicines like coumarins, jansons, and flavonoids that have been reported to affect the platelet aggregation. So having a knowledge about the ongoing medication which may hamper the hemostatic patient process in the patients is also important. These are certain recommendations. I don't want to go into details because my next speakers will be probably discussing how they go about in managing the hemorrhage or blood loss in the perioperative setting. Now, this is a slide in a very concise form. What are the NOACs that commonly we use? Dabigatran, rivaroxaban, apixaban, and endoxaban. And the primary aim of this table is to make you aware that we often encounter these patients receiving these drugs. There are antidotes available, but the antidotes are expensive and availability is an issue. So what we land up in a situation that we have to pharmacokinetics and pharmacodynamics of these agents. So if we are aware of that, the patient is receiving these kind of drugs, we can formulate our management plan if at all a patient is scheduled for an urgent or an emergent surgery. And what we can note that in dabigatran, the half-life is around 12 to 7, and for rest of them is around 7 to 14 hours. And it is mentioned that if we don't have an antidote for a drug, then we simply have to wait for 4 to 5 half-life of a drug. That means around 48 to 56 hours for the NOACs. If we can wait, then the drugs can be eliminated. And another important factor is that among these agents, dabigatran is one of the drugs that I have mentioned in the first column. It is less protein bound and it is dilatable. So if you have a patient received dabigatran and you don't have an antidote and you don't have a time to reverse that, so you can rely on dialysis as well. There are certain specific antidotes. I don't want to go into details, but the important aspect of these are expensive and availability is definitely an issue. We have drugs, they are rampantly used, but the antidote availability of the antidotes of these drugs and the cost is a major factor. Now coming to the laboratory test, the third in line to discuss about, the guidelines or the recommendations are pretty clear. Indiscriminate coagulation screening prior to surgery or other invasive procedure to predict post-operative bleeding in unselected patient is not recommended. A bleeding history, including detail of family history, previous excessive post-traumatic or post-surgical bleeding, use of antithrombotic drug should be taken into consideration. And if the bleeding history is negative, no further coagulation study is indicated. However, I take this statement with a pinch of salt because I'll be discussing about what exactly is the problem if we firmly stick on these guidelines. And if bleeding history is positive and there is a clear clinical condition like liver disease or chronic kidney disease, a comprehensive assessment guided by a clinical feature is required. What are the routine laboratory tests we do for knowing the risk of coagulation abnormality? That is PT-INR, APTT, and platelet levels. And if we are encountering a patient with specific conditions, then we have to assess the von Willebrand factor or different clotting factor in case of hemophilia or hypofibrinogenemia. And there is a growing body of evidence. No, I cannot say it's evidence, but it's commonly now used point of care testing for coagulation. But what is the status of using a point of care test to predict the post-operative blood loss or bleeding? Well, there are certain point of care tests available that includes PEG or ROTEM, which enable rapid intraoperative diagnosis, but it is not practical for preoperative bleeding risk assessment because why? They can suggest that there is increased bleeding risk, but they cannot predict the intraoperative and postoperative blood loss. because intraoperative and postoperative blood loss doesn't only depend upon your coagulation factors. There are certain external factors like type of surgery, your expertise available. Do you have you ambulanced the patient in case of highly vascular tumors? So that factor also we need to take into consideration. And point of care testings are expensive testings, and the reagents are quite expensive. So indiscriminate use is unlikely to be cost effective. However, we need to give consideration in combination of this test with standard lab testing for specific bleeding disorders such as von Willebrand factor deficiency, factor 12 deficiency, hemophilia, and dysfibrinogenemia. In case of NOACs, what I mentioned that conventional coagulation parameters, they cannot assess the anticoagulant effects of NOACs. There are certain group of tests that are for specific for dabigatran or rivaroxaban or apixaban or tandem mass spectroscopy that can be used for assessing the anticoagulant effects of these agents, but these tests are not always available everywhere. To make things simpler, it's not absolute, but to make things simpler, if you encounter a patient with NOACs with prolonged APTT, that indicates the effects of dabigatran. If you are encountering a patient on NOACs and PT is prolonged, then probably the patient is receiving a direct factor 10 inhibitor like rivaroxaban, apixaban, or endoxaban. And normal levels are most likely, if not absolutely, most likely exclude the significant of NOAC levels in the blood, and the chances of blood loss due to the ongoing NOACs is less. And let's not forget one of the important aspects whenever we are screening a patient for perioperative blood loss, that is physical examination. It should focus on signs of bleeding and disease, while in patients with hemostatic failure like liver disease or chronic kidney disease, we need to know the gender of the patient and body mass index of the patient, because ultimately your amount of blood inside your body depends upon the body mass and your weight of the patients. And certain comorbidities like hypertension, diabetes mellitus, and renal dysfunctions, which are independent risk factor for bleeding and transfusion, we need to take into consideration of these comorbidities as well whenever we are screening the patients. Evidence of bleeding or anemia, including size and location and distribution of ecchymosis, hematomas, and petechiae, should be short. And evidence of risk of increased or spider angioma or splenomegaly, arthropathy, or joint or skin diseases that are a part of multisystemic disease that can hamper your coagulation process, we need to ascertain through physical examination. And one of the important aspect what my first speaker has highlighted, that one of the important of physical examination comes here, because suppose the patient is having a coronary artery disease, your transfusion thresholds are slightly different from the patients without coronary artery disease. You need to have a higher transfusion threshold. Suppose for 7 for a healthy adult, you have to take a transfusion trigger of around 9 when we are dealing with a patient of coronary artery disease. So you need to know about your comorbidities of the patients as well. And one of the important things that we cannot just consider all the factors in isolation. We have to take into consideration the type of surgery, because there are a group of surgeries which are known to be major surgeries and which are known to be associated with blood loss, like thoracic surgery, abdominal aneurysm surgeries, intracranial or spine surgeries, cardiovascular surgeries, gynecological and cancer surgeries, and obstetric surgeries. These are surgeries which are associated with increased blood loss. So even if the patient doesn't fit into the criteria of not doing a laboratory test, but because the patient is scheduled to undergo these kind of surgeries, the patient has to undergo a screening for coagulation defect. And though this table I have taken in a out of context, this table was mostly discussed when we were discussing about the cardiovascular risk factor for non-cardiac disease. They have stratified different low risk, intermediate, and high risk surgeries, and it holds good for other situations as well. We have certain low risk surgeries like superficial surgeries like eye surgeries, breast biopsies, or gynecological minor surgeries or orthopedic surgeries. Intermediate risk surgeries are intraperitoneal surgeries, head and neck surgeries, urological surgeries, and renal transplant. However, there are certain very high risk surgeries. They have a high chance of blood loss, major intraoperative fluid shift and adverse outcome. So these are aortic and major vascular surgeries, esophagectomy and total cystectomy, pneumonectomy and lung surgeries. So these are surgeries which have high risk. So we need to take in whenever we are dealing with patients scheduled for these kind of surgeries, even if they don't fit into any kind of even if they fit into a normal criteria of coagulation. We need to assess the coagulation other and do other tests as required as a part of surgical planning. To sum up, I have been asked how do I proceed? I proceed in a way that is already mentioned in text. That is, I take it into consideration about the medication history, and if it's positive, then I need to take. Then I need to ask myself what kind of medication the patient is receiving and what kind of surgery the patient is undergoing. If it is a only aspirin, NSAIDs, or complementary medicine, and it is a minor surgery, we need to manage as per the guidelines available. However, if the warfarin, clopidogrel, and newer anticoagulants and the patient is scheduled for a major surgery, then we have to have a multidisciplinary approach. I should not be taking a decision on my account, because I need to take into consideration a cardiologist, a hematologist, the surgical team, and the transfusion specialist as well to take a call if I am dealing with a patient receiving this kind of medication and scheduled for major surgeries. Now, coming to the bleeding history, I have already highlighted, or physical examination. If either or both are positive, then you have to have a bleeding assessment tool. And if it is positive, then again, you have to switch to a multidisciplinary approach, other than you deciding on your own that whether the patient will be having a blood loss or maybe requiring transfusion. If all are negative, then no further evaluation required. However, we have to take into consideration advanced age and type of surgery. And my last slide is I cannot discuss my topic in isolation without discussing about anemia, because anemia is a problem in India, definitely. And as my previous speaker has already highlighted, the magnitude of the incidence of anemia varies between 30 to 40% in Indian context. And there is an association between preoperative anemia and adverse postoperative outcome, including the length of stay, infection, and risk of blood transfusion. And even if anemia per se is not a factor that determines the perioperative blood loss, but presence of anemia definitely dictates the need of transfusion in the perioperative period, made with preoperatively, intraoperatively, and postoperatively, because anemia anemia affects multi-system, and we need to address anemia whenever we are discussing about perioperative blood loss and transfusion. And the different recommended test, I don't want to go into detail, as it has been highlighted already. You have to do a full blood count, iron study, and C-reactive protein. And screening should occur at least 6 weeks prior to your elective procedure to allow time for treatment to be provided. And all patients detected with having anemia should undergo a physician review, at which point the cause of anemia should be ascertained and any underlying comorbidities has to be identified. So with this, I come to the end of my presentation, and thank you very much for your patient listening. A few drops of our blood can help the life to bloom. So we have to use blood rationally. Thank you very much for your patient listening.
Thank you, Dr. Dubey. I think you covered it for that lucid talk. I think you very rightly highlighted various aspects and updated us regarding the newer anticoagulants and their antidotes and the mechanisms they act. So it was really, I think it goes without saying that the transfusion specialists, laboratory specialists, and the anesthetist, and of course the clinical colleagues. I mean, for a successful patient blood management program, we require support of all these stakeholders. So thank you very much for being with us and sparing your valuable time. I think, yeah, now we can have few questions. Maybe I think I saw Dr. Makru raising his hand.
Good morning. I think all the three presentations were very excellent. Well, we have to see the presentation in context of our national scenario. And for example, coming to the anemia, Well, anemia, if we take the definition of anemia, anything less than 13, then you will have majority of the donors who are donating blood to be rejected because our blood donation criteria cutoff is 12.5. I think we have to see in that context, number one. Number two, we have to have, because basically once we have having a presentations like this program, we should try to, I have all young colleagues, now we have the transfusion medicine departments. I think we should present our national data, we should present over these things, because all what has been presented is a Western literature. Well, this has a different connotation as regards to our concern. I was talking to Dr. Jim while she was having a cup of tea. Well, when I was asking in Florida, well, they have a population of 26 million and they have 6 blood centers. Delhi, 23 million, 80 blood centers. See the vast difference. And so I was asking him another thing, how you implement the patient blood management in that setup. It is practically slightly easier in a setup where there are 6 blood centers and there are so many hospitals. But once we have I'm telling only 80 blood centers, 23 millions, well, you can understand how difficult it is. We have Dr. Krishna Kumar with us, where we are contemplating. Think about the centralized blood collection and testing, which we are talking almost from years now, 1 decade. But I think there are some barriers to this effect. I think this needs to be looked into on an emergency basis, and this will have an impact. Now, coming to our clinical plague, Dr. Surya. Well, basically, I have also seen that all Institute of Medical Sciences are premier research institutions. I think we should come in the coming days, because basically I'm very happy that you have been involved in this meeting. The collaboration of the All Institute of the Medical Transfusion Medicine Department and your neurosciences department should do collaborative studies to come out with, for example, in our setting where we have seen at Apollo Hospital, majority of the patients of the cardiovascular is had hemoglobin up around 11 and above. Well, we have hardly used the blood in them. And nowadays, it is the beating heart surgeries or a single unit of blood transfusion, because basically that again was a misnomer at one time. But there will be a lot of questions. I would like to take the time, but I think this was a really important session, and I think has exposed to us all that, and we need to do more in this regard. Thank you.
Thanks for your comments, Dr. Makru. I think that's perfectly fine. I think this is a primer, basically. Yes, of course, you may be seeing because some posters, I understand there must be some poster or, I mean, in coming time, basically, this is to understand how it is being done and how we can move forward in this direction. So, yeah, with this, I think, are there any comments or questions? Yes, sir.
Good morning, friends, and good morning, all the organizers. Thank you very much. But now I am on the mic as an anesthetist. Whatever I may be, I am an anesthetist. So, few comments, not from the ministry point of view. It's from the first is I fully agree with Dr. Richards. The best unit of blood is which is never transfused. One. The next best is which is judiciously used. I agree with this, sir. Now, let me come to Dr. Chaudhary, sir. So,
Yes, sir, I'm here.
Sir, very good morning, sir. I think all is good there.
Yeah, good.
I wanted to meet you here, but okay, it's good. Even talking you on the mobile. Sir, you have said that you have shown me a graph where you have compared the 6 different anesthetists having different threshold for the transfusion of blood. I have
Yes.
seen that. Sir, you have missed many things there. One is the surgeon. Who was the surgeon? There is not mentioned. That is the most critical thing. So that was not part of that graph. So as an anesthetist, sir, we first look at the patient. How is the patient? Then we see what is the type of the surgery. Two. Third is who is the surgeon. And fourth is uh, how is the person who is issuing the blood to us. All these things need to be there because at that time, sir, we are at the head end of the patient and we have to take care of the patient during that precious time. So, sir, here I will say that I will thank the organizers that they have come up with this first kind of meeting where the persons who are testing the blood, who are taking the blood, who are processing the blood, who are storing the blood, and who are transfusing the bloods are at a single platform. This is the best beginning which could have been. So thank you for that.
Thank you.
I firmly believe that, sir, blood in a test tube and blood in a body behaves differently. They are not the same things.
Yes.
So, yes, but it is yes, there should be a common ground. I see one day, I dream that one day the persons who are testing the blood in the laboratory will be part of the team who is next to the patient. Then we will be coming up with the decisions which will be actually helpful to the patient. Thank you. Thank you very much.
Yeah. Can I add one comment here?
Yes, sir. Carry on. Yes,
Yeah.
please.
This was regarding why the surgeons were not included in that graph. Uh, I agree that the surgeons they definitely have a great impact on the transfusion need of the patient, particularly those who are undergoing like cardiac surgery. But if you see that graph, the difference between the transfusion rates among the anesthetists was very significant. One anesthetist, the transfusion rate was just 30%, while there was another anesthetist, the transfusion rate was 50%. And they were all same patient, like undergoing cardiac surgery in the same institute, and they were all adult patient. So they have removed most of the biases. So the difference between 30 and 50 is very significant. So I understand the importance of surgeons here, but we also look into the personal beliefs of the people regarding blood transfusion.
Yeah, thank you, sir. I just wanted to add to it that, like sir said, yeah, I'll take your comment. Because in our institute also, we frequently, when we do rounds, there is a lot of blood stacking in the bedside and it is not used and we bring it back. So the residents say कि सर ये एनेस्थीसिया वाले जो कहते हैं कि पीएससी से पहले आप यूनिट दिखाओ तभी हम सर्जरी करेंगे मतलब सो प्राइमरली दे से दैट एनेस्थेटिस्ट इंप्रेस अपॉन देम कि ब्लड होना चाहिए बट नाउ वी आर ब्रेकिंग दिस बिलीफ एंड वी हैव टेकन इनटू लाइक सर सेड that collective efforts basically we have taken the chief of anesthesia in our hospital transfusion committee. He said, Dr. Sahab, I will ensure that blood will only cross match in captain blood bank if required then it will be issued. So I think gradually we are moving in directions where to minimize these kind of issues and problems. Yeah. Dr.
So I think it is more important to have communications among all the stakeholders. This is what is highlighted. Yes.
Thank you, sir.
Definitely.
Yeah.
The role of the nursing staff is very important in this blood management, with particularly the preoperative anemia. The nursing staff in our country, they don't play much role in education of the patients. So I think we need to have this kind of cadre of the nurses or like PBM nurses. So this kind of cadre we have to create, and they will be educated with regard to the importance of preoperative anemia and the patient education. This is the thing which we are missing in our country. We don't inform our patient. Just we take the informed consent, and that is blindly taken informed consent, but they are not educated even in those articles which I have studied for this presentation. they say that the family members should also be included in the management. So family members should also be educated about the importance of preoperative anemia. So this is the point I think we need to discuss, and we need to have this kind of cadre, special cadres in our country.
Good morning.
Excuse me, mic two, please.
It was quite informative and it was really very systematic also. And so, with the transfusion medicine fraternity, they start counseling the patients and they follow the pre-operative anemia area. So how does it? It would be really, it is really possible that if we have 30 to 40% patients who are admitted in an elective surgery and they are anemic, so why can't we open such OPDs in our blood banks where we can educate the attendants, the patients, and we can solve these areas? It's simple, like 2, 3 treatments are required for the preoperative anemias.
Yes.
Good morning, sir. This question is directed for Dr. Gammon. Sir, I'm Akshay Batra. I'm working in a cancer hospital. Yeah, so my question is directed towards that particular guideline that you have shown in 20 that by ABB for PRBC transfusion. Now, my focus point is on the recommendations for the hematological and oncological patients, whereby the recommendation are not so strongly recommended. They are general recommendations. So could you shed more light on the various issues which are when these are being guidelines are being decided upon, like say for sometimes we feel that a hemoglobin cutoff of 7 for a hemat patient, let's say for a patient who is on ALL or some kind of chemotherapeutic drugs are being running over him, so it is difficult for us to convince the clinician to go with the cutoff of 7. So we have to have sometimes give to sometimes 8 also. And similar for solid organ cancers also. Say for colon cancer or a patient who is undergoing some kind of liver resection or some major surgery, along with the who had received some kind of neoadjuvant therapy also, we usually keep a cutoff of at least 8, 7.5 to 8. In this situation, we find it very difficult to convince our surgical team and anesthetics team to keep the cutoff at 7. So comments on that, sir?
So that's an excellent point. And so a few comments on that excellent question. So first of all, the ABB, when they looked at all types of hematology oncology patients, and the evidence was it was a conditional recommendation with weak evidence based. So there was not that much literature review for it. So you have leeway. It's a recommendation, not a mandate. Secondly, there are patients that are on specific, protocols. Chemotherapy do require higher hemoglobin levels, and so use the ABB guidelines. My recommendation is as a starting point. And then if you've got specific patients, specific categories, like the GI patients that you mentioned, then those ones you could put in additional hemoglobin levels that are higher that suit your patients. And then one final comment is, as with anything, the recommendations are just that. So even if your hemoglobin recommendation is 7 or 8, if the patient has symptomatic anemia, it's certainly reasonable to transfuse at a higher hemoglobin level. You're welcome.
Thank you.
So with this, I think we conclude this session. All the 3 talks are excellent. Now we hand over it to the organizers, please. Thank you.
Thank you so much. That was very beautiful, and the audience have made it more lively, I should say. And let Kishan sir's dream come true one day. We all support for that and we pray for that, sir. And I request Sharma sir and ma'am to please stay on the stage. I request Dr. Richard Gaman sir to please come on the stage. Sharma sir and ma'am, please give a token of appreciation from our side to Richard sir. Thank you, sir. For Chaudhary sir, we will be sending it to Lucknow. Thank you, sir, for joining.
Thank you, thank you.
Now I request Dr. Surya sir to please come onto the stage. A small token of appreciation from our side, sir. Now we request Dr. Poonam Kaushik ma'am, CME Blood Center Main Hospital, AIIMS New Delhi, to give our token of gratitude to Dr. R.R. Sharma sir and Ravnit Kaur ma'am. Yes, sir, we will do it at the same time.
To save the time.
Yes, sir. Thank you so much, ma'am and sir. Now moving on to the official inaugural ceremony of today's CME. We have with us our chief guest, Dr. Kishan Kumar sir, CMO SAG, DGHS, Ministry of Health and Family Welfare. The guest of honor, Dr. R.R. Sharma sir, HOD, Department of Transfusion Medicine, PGI Chandigarh, and Dr. Shiv Chaudhary sir, Head CTVS AIIMS New Delhi. We request the dignitaries to please come onto the dais. Please have a seat, sir. Now I request Dr. Hemchandra Pandey sir, the organizing chairperson of today's CME and Head Department of Transfusion Medicine, AIIMS New Delhi, to welcome the dignitaries with a pot of plant. To Shiv Chaudhary sir. To Kishan sir, please. To Sharma sir, please. As we know, Goddess Saraswati is the goddess of knowledge and wisdom. Let's start the program by evoking the goddess with a prayer. We welcome Dr. Shruti and Dr. Anupriya, junior residents in Department of Transfusion Medicine, to chant the Saraswati Vandana. Requesting Dr. Richard Gammon sir, the keynote speaker of the day, Dr. Poonam Kaushik ma'am, CME Blood Center Main Hospital, Dr. Anjali Hazarika ma'am, and the esteemed dignitaries on the dais to inaugurate the ceremony by lighting the lamp.
या कुन्देन्दु तुषार हार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
What an uplifting way to kindle the proceedings of this day. Inviting Dr. Poonam Kaushik Ma'am, CMO, Blood Center Main Hospital, AIIMS, New Delhi, to deliver the welcome address.
Dr. Richard Gammon, the guests on the dais, Dr. Krishan Kumar, Dr. R. R. Sharma sir, Dr. Shiv Kumar sir, and my dear colleagues. On behalf of Department of Transfusion Medicine, AIIMS, New Delhi, I extend a very warm welcome to all of you. So we started with the objective of blood safety and quality. This is the third CME in that series, which is the primer on the patient blood management. Now, how important this topic today is, we have all seen in the morning session, because all the speakers, they talked about the various issues which presently also exist. And as blood bankers, we have seen these issues coming up on daily basis. The clinicians have their own issues regarding requirement of blood for the patients, and blood bankers have their own issue. As was very nicely shown by the emoticons in Dr. Richard's presentation, where blood bankers are mostly the emoji of the policeman, that you are asking, the patient doesn't require this, so maybe it requires some other component. So these kind of discussions are almost happening on daily basis in our hospitals, and we all experience. So today, with this CME, we are starting the Samudra Manthan of, I should say, Gyan Manthan, where we should come out with all the issues. And later on, when we go back from there with all the knowledge which we gather from here, I think we should go back and make our own guidelines and policies. It's very heartening to have on stage a transfusion expert, a cardiothoracic surgeon, and an anesthetist, the best combination who should formulate the policies and guidelines for our nation. So India is a very unique country, and we have a very unique blood transfusion system in our country. But having said that, with our own problems, I think we should come up with our own policies and guidelines. And this is the beginning for our programs, which we will continue, and we should replicate in other centers, so that a national policy can be made and followed in the hospitals for the benefit of the patient. Because we always believe that no transfusion is a zero-risk transfusion, despite the best screening program, best screening tests which we employ in our departments. So if we can minimize or reduce the transfusion of a patient, we do a favor to the patient. So with the feast of talks, which we are going to have in the later half also, so I offer my best wishes to all the speakers, and happy learning to all. Thank you.
Thank you so much, ma'am. Now, I request Dr. Shiv Chaudhary sir to share the innumerable experiences and thoughts throughout his journey in PBM. Please, sir. Yes. Or
Sabha Namaskar. I will use bilingual way of communicating. तो सबसे बड़ी चीज ये है कि मैं सर्जन हूँ, फूड चेन में मैं सबसे ऊपर हूँ. आप लोग जो कुछ भी करते हैं सब कुछ मैं कंज्यूम कर लेता हूँ. तो फ्रॉम कंज्यूमर पॉइंट ऑफ व्यू सर्टेन थिंग्स आर इन माय माइंड. नंबर वन, I would say that in the list of iatrogenic complications which can happen to a patient, transfusion-related mishaps tops the list. It is one of the very common complications which can happen to our patient. And if we see what are the problems, if I have to group them, I would say the factor responsible would fall in two categories. One, I would say, no means that means we know the causes of it, and even then it happens. So that is purely negligence or act of commission or omission. So that can be prevented. That is preventable. Another group of factors is known unknown. We know that there are certain facts, but the person who is executing may not be knowing it. So we can call it ignorance. So these two group of factors can be tackled by way of education and by way of laying down SOPs. Certain things which come to my mind, I would not waste or take much of time, is mandatory training or orientation of any medical person who joins services about transfusion practices, starting from how to collect sample, how to dispatch, how to process, how to call for blood, how to transfuse, before transfusion, what is the checklist. That should be applicable to each and every person, whether it's a nursing personnel, whether it's a OT tech, whether an anesthetist, whether it's a resident, whether it's a surgeon. So if we can implement those things, I think a good number of mishaps can be prevented. Second thing, I was hearing about the discussion, the guidelines when to start transfusion, what should be done for preoperative anemia. There, I would suggest that we are looking just like blind people are looking to an elephant. Each one is holding one organ, one part of the elephant, and they are going for that. Nobody is having the complete picture of the elephant. One person may be holding the trunk, for him, elephant means something different. One person is holding the leg, it's a different thing. So, what is the need of the hour is a wider communication, more frequent communication. Exactly. And that communication and discussion may evolve certain guidelines and practices which may not conform with the international guideline or national guideline, but they will be good enough for our setup. And that is what it means. When it comes to use of blood product, nobody remember guidelines. It is the individual practice in that particular arena which is being followed, and that can be improved upon. You cannot immediately change. You can improve upon by frequent interaction and communication. In our OT also, some surgeon, they keep the hemoglobin at 13. Somebody is good at 10. Somebody would say, okay, no need after 8. But that thing varies individually. If we can bring them on the same platform and by persuasion, discussion, knowledge transmission, the rationalization, all these things can happen, but it can happen in a way of cooperation. So I just want to emphasize these two things only. Knowledge, the orientation regarding the transfusion practices is a very important aspect, starting from the first year MBBS student till one become professor or anything. Everybody should have the freshers courses also recurrent in between. So that will reduce so many of our complications, and it will reduce the usage of blood products also and rationalize also. I will not say reduction, I will say rationalization. With that, I wish all the best for this activity, this CME, and I hope more of such CMEs we see in the future. And I would, before I close, I would say that we have the best blood bank in the world with us. Our transfusion services are fantastic, and we never have to suffer because of lack of services on part of blood bank. A very cooperative, very dedicated service. Thank you.
I now request Dr. Yatiram Sharma sir, Head Department of Transfusion Medicine, PGI Chandigarh, the largest blood center in the country, to walk us through his thoughts in implementing PBM in blood centers.
Thank you and good morning. I think Professor Chaudhary, Dr. Krishan Kumar, esteemed faculty in the audience, Dr. Richard, Dr. Bharat Singh, Dr. Makru, Asim, I think a lot of people, Ravneet, Madam Poonam, Rashmi, and Professor Geeta Negi, as I see. So I think first of all, I would like to congratulate the Department of Transfusion Medicine, All India Institute Medical Sciences to start this endeavor towards patient blood management. They called it as a primer, basically, and roping in their clinical colleagues, like Professor Chaudhary is here with us. I think we had a colleague from Department of Anesthesia, and as you go down during the day, we have clinical colleagues from all specialties. So this is how, because the first and foremost step is, as Dr. Richard had highlighted, to identify the champions. First, we need to identify the stakeholders in this process. So once we identify the champions, then we go ahead. And yes, Dr. Chaudhary rightly pointed out, we have to institutionalize the guidelines. Like we have AABB guidelines, those cannot directly apply to our setup. We have to see the modalities, we have to work out how best we can adapt them or how best we can develop our own guidelines in our institute. And the next would be like previously, I think so far in transfusion, we have been like, I call it as a three-dimensional approach in transfusion services. Like we have a community interface. We go into the community, motivate people, educate them, create awareness, collect blood, then do testing. Second interface is our laboratory interface, where we do testing of all blood and blood components, separate them in a quality assured manner under the full GMP or GLP guidelines. And third is our clinical interface, where we interact with clinical colleagues, we fight day in, day out, I mean, whatever it is, we call it. So that's the clinical interface, where we have to deal with the patient directly or indirectly. Directly, as you all know that with therapeutic therapy, I mean, apheresis therapy, we are giving them therapeutic plasma exchanges, red cell exchange, and platelet site reduction in various oncological emergencies. So, and then of course, blood testing, compatibility testing, whether red cell or platelet cross match. So this is how this specialty has evolved into this kind of what you can say from laboratory to a clinical full dimension. But then you as transfusion specialists, especially for the young colleagues, that you need not to settle down to your laboratories. You have to raise your voice. You raise, I mean, clinical discussions with clinical colleagues on regular basis, because one or two interactions will not suffice. It has to be a regular clinical, maybe in their rounds or clinical meetings. You need to show your presence and discuss how best you can implement such kind of strategies. So for this, I think I must, at the end, I just want to say that thank you very much and congratulate you again for organizing this. And as from the transfusion community, we have to come out of our shells and get in active and interact with our clinical colleagues if we want to progress further and create awareness regarding this area, or we want to actually implement patient blood management. Thank you very much.
Thank you so much, sir, for the kind words. As all the speakers were telling, communication is the most important key for PBM. And with that words, now I request Dr. Kishan Kumar, sir, to enlighten us with his ideas of implementing PBM nationwide. Please.
Good morning, friends. Dr. Shiv Kumar Chaudhary, sir. Dr. Ratiram Sharma, sir. Dr. Shiv Kumar, sir, it's a pleasant occasion for me. For last, I think from 2002 to 2012, continuously every day, I was hearing about him. He is the all-rounder. आज ये ऑपरेशन कर रहे हैं तो शिव कुमार जी क्या करते, चौधरी सर क्या करते, तो आज आपसे मिलने का मौका मिला. थैंक यू वेरी मच फॉर कमिंग. शुरू करूंगा कि आदमी ड्रीम से भरा हुआ, हजारों ख्वाहिशें ऐसी कि हर ख्वाहिश को दम निकले. सो बहुत सारे ड्रीम लेके आया हूं. आप सब स्टालवार्ड्स बैठे हो। सबसे पहले आई वुड लाइक टू कॉन्ग्रेचुलेट द ट्रांसफ्यूजन मेडिसिन टीम और ब्लड बैंक टीम ऑफ एम्स फॉर ऑर्गेनाइजिंग दिस CME meet. So I think this is the most important step, as Dr. Shivkumar has said, that if I look at the present scenario, it's like blind people looking at an elephant, palpating it and coming up with their own pictures, that the shape is like this and the shape is like this and the shape is like this. But yes, this is the beginning. Now, medicine is a team approach. It can't be happen in silos. Earlier were the days, if we look at our MBBS syllabus, we read each and every subject. Sometimes we think that is it necessary? We read gynae, we read love and value of surgery, then medicine, Harrison, and all those things. At the end of the day, we just finished as a specialist of a particular field. A ophthalmologist just look at the eye of a patient. A cardiac surgeon look at the cardiovascular system, cardiologist. So, but human is not just the sum total of organs, systems, and the structures. It's much more than that. We need a holistic approach. We need to look at the patient as a one. And that will only happen when we work. I am not saying that specialization should not be there. Specialization has its own role. But at the same time, when we are working, we need to keep the patient at the center as a whole. And that will only happen when we work as a team. So this is the first beginning. Thank you. Thank you very much, Team AIMS, for organizing this. Secondly, Dr. Makru came up with that. He was emphasizing that there should be a hub and spoke model approach. As Dr. Sharma was also telling that there are too many blood banks and there should be some standardization, some integrated approach. So we are working on it. I hope that in the next year, our first metro blood bank or capital blood bank, whatever you say it, may be functional. First in a makeshift building, machines are already there and they are asking for the consumables. Our team has already visited. I think we have requested Dr. Sharma and Dr. Chaudhary to visit there, but somehow time given was very less, so they could not go. But I will request them to go there so that we can at least start that. That will be the one. And my second thing is that right now, whatever we are looking are at the international guidelines. Friends, India is a country of countries. As Dr. Makru was comparing that a country and a Delhi city, and there was still a city was comparable to a country. And whatever studies was quoted in all the presentations, most of them were from outside the country. Can't we 140 crore people, now we can't say that we are not having infrastructure. We are having quite reasonable infrastructure now. Second is we are full of patients. We are, I will say, blessed with number of patients we have. We have the clinical material, we have the resources, we have the knowledge. If I look at the Western world, India is one of the most preferred destination when it comes to from where the doctor should come. So we have the knowledge, we have the infrastructure, we have the patients with us. Why can't we come up with our own studies? If you tell me that hemoglobin of 13, less than 13 will be anemia, then I am afraid that you will be getting blood from anywhere. Secondly, I was listening to the presentation in which that blood transfusion threshold should be 7. And then there were the things when anemia is dangerous. Anemia can kill. Anemia has many drawbacks. We know that. But at the same time, we look at our scenario also. If anemia kills, more of the RBCs also kills. There should be a central point where there is a balance. And I feel that balance in each community, depending upon the nutrition, depending upon the environment, depending upon the race, depending upon the genetic setup, will be different. So I request you all, I am standing in the dais of a premier institute of this great nation. I request you all to come up with studies which tell us where we are, what need to be done, what should be our guidelines. So thank you for inviting me and giving me the opportunity to interact with you all. And you have invited all the stakeholders concerned with the blood usage and blood products. But I will request you, I am not able to see the emergency medicine people here. Please involve them also, because they are the one who are using it also. And if they will be there, our team will be complete. So thank you very much. Wish you all the very best. I hope that this CME will take us to a different level. Thank you very much.
Thank you, sir. We want to request Dr. Anjali Hazarika ma'am, CMO, Blood Center, Cardio Neuro, AIMS New Delhi, to give gratitude to Dr. Kishan Kumar sir. Dr. Gopal Patibar sir to confer a token of gratitude to Dr. Rachiram Sharma sir. We may now request Dr. Rahul Chaurasia sir to present a token of gratitude to Dr. Shiv Chaudhary sir. Now I request all the dignitaries to present the token of appreciation to Dr. Richard Gammon sir, Medical Director, One Blood Florida. I will request Dr. Vipul Patibar sir to present a token of appreciation to our keynote speaker, Dr. Richard Gammon sir. Dr. Pujan Kaushik ma'am, come on stage. Thank you, dignitaries. Thank you so much. In this moment, I should say we have a strong foundation at AIMS made by our CMOs, Poonam ma'am, Anjali ma'am, Sulekha ma'am, and Vedanand Arya sir. And over that, the strong pillars, Dr. Hemchandra Pandey sir, Dr. Rahul sir, and Dr. Fatidar sir. And we are blessed to be their students. And I think before taking a break, we can go for the next session. To chair this session, I request Dr. Asim sir and Dr. Makru sir to please come to the stage. That was a surprise for Makru sir, it seems. Say about Asim Tiwari sir. I should say sir is the director, transfusion medicine, Medanta, the Medicity, Gurugram, with over 140 publications in both national and international journals, reviewer to several journals, currently vice president of ISTM, recipient of H.D. Shorey Award and J.R. Jolie Award. And about Makru sir, I should say, sir doesn't need any introduction, but still, I should add, sir is the first DMD of TM specialist in India and ex-director of BTS Apollo Hospital, as well as ex-president of ISTM. Over to the chairpersons, please.
Thank you very much, firstly, to all the program. Well, hello. I'm audible, I think, without even mic. This is audible. Okay, working, right. Well, as has been already debated, patient blood management is a multifaceted, and all the previous speakers have said that, it involves almost all the disciplines from clinicians, whether it's a physician, surgeon, anesthesia, gynae, obstetrics, patient, social workers, and everything. And in that context, now in this session, we have anesthetist and we have a surgeon. Well, these are the pivots actually for the patient blood management, looking after the patient when the patient is in the operation theater. And to begin with, the first speaker is Dr. Nitin J. Kumar. He is an associate professor at the All Institute of Medical Sciences, has 65 publication and book chapters, around 30. He is the examiner for the MD, DA, LSAS, BSc Anesthesia and OT technicians, editorial board, Indian Anesthesia Forum, and the national expert for the NHSRC and Ministry of Health, Family Welfare, Government of India, LAS, EMOC, and Emergency Care Services at the district hospitals. And he is also training the BLS and ACLS faculty and instructor. The areas of interest are pediatrics, transplant anesthesia, and the critical care. I have the honor to present you the Dr. Nitin J. Kumar. Over to you.
Thank you, sir, for the introduction. Good morning, everyone. I'm Dr. Mrityunjay. I'm Dr. Hemchand Pandey's colleague from All India Institute of Medical Science from the anesthesiology department. And we have gone a long way, and thank you to the organizers for inviting me here. So I'm going to talk about this, how we are going to reduce the blood loss in the intraoperative period, and what is the ideal approach to go about it. So why we have to address this problem? This is a very big problem because about 313 million surgical procedures are performed worldwide every year, and out of that, 4.2 million people die within 30 days of surgery. So mortality rate is around 7.7%. And there are lots of things, as pointed out by the previous speakers, that there are other things also that carries on to the morbidity uh, because of the surgery and the blood loss. So, perioperative bleeding remains a major challenge for all of us working in the perioperative care of the patients, anesthesiologists, surgeons, transfusion specialists, and other team members. And it's associated with a high rate of death, complications, and carries a major cost to the health to the patient and patient attendants also. So these are the things that we have to look for when we have to optimize any patient in the preoperative period. As far as blood loss goes, we have to optimize the erythropoiesis. We have to look for the we have to screen the patients in the preoperative period, and we should know if there is an anemia, what is the cause of anemia, whether it is because of some deficiency, some disease, or some malignancy, or whatever could be the cause. We have to find the correct cause of it, and then you have to take time to correct it before going for it. And if any further referral is requirement, you should be doing that. And to minimize blood loss in the preoperative period, we have to look for the bleeding tendency in the patients. If there is any history of bleeding tendency, we have to find out what is the cause of it, and we have to optimize that. If the patient is on some medications, anticoagulants, antiplatelet agents, so stopping it before surgery, the proper timing of that. And if that is also important, if it is an emergency surgery, there are modality to work on that. I'm going to talk about it in the later slides. And we have to plan it very meticulously. Multidisciplinary team should be involved in that, taking a decision for the patient along with the patient. And for managing anemia, it's already been talked about. Other thing that we can do is we can have if we can stratify the surgery, which surgery will require blood transfusion, which will not. And according to that, we can properly type cross patch, and we plan it. And if preoperative autologous donation has to be done, though it is not much in practice these days, that can also be done. Then supplemented with the erythropoietin, and iron supplements can be given. One thing that is so if there is a potential for transfusion in the patient, we should take the transfusion consent. That is missing from the most part of the consent form in the perioperative, be it surgeon consent form or anesthesia consent form. And compliance to the WHO surgical safety checklist by 100% is also required in the preoperative period. Why it is important? Because we know that if if patient is carrying the risk of blood loss, we should have it available in the and all the equipment should be kept ready for in the preoperative period. So this is the consent form which is devised in our department and All India Institute of Medical Science, New Delhi, and we do have a part in it which explains what blood and blood products requirement in the perioperative period. So this was about the algorithm for the detection and management of preoperative anemia. So looking for the iron deficiency, ferritin, serum ferritin, transferrin saturation level, and accordingly we can work it out and find out the exact cause, whether to go for oral iron therapy, whether to go for IV iron therapy, whether to supplement with the erythropoietin, if there is some CKD, chronic kidney disease, or some malignancy involved, we should find out and we should work on it. So what are the factors coming to my actual topic of lecture is like what are the intraoperative factors that can be there? But so to work on it, first you have to optimize the erythropoiesis, the timing of the surgery. That is important. Once you have started the correction of the anemia, we should, at least if it is an elective surgery, we should wait for it to happen. Okay. So you should let it get optimized and then go for the surgery. There should not be any hurry. If it is an emergency surgery, there is other thing where there are ways to work on that also. And you have to minimize intraoperative blood loss. How to minimize intraoperative blood loss? The measures to do. There's surgical part that my colleague is going to talk next. And there's some anesthetic component that we have to take care of that. We have to have a meticulous hemostasis, and surgical technique like laparoscopic and robotic surgery can help in less blood loss. And blood sparing surgery, like anesthetic blood conserving strategies, that also I'm going to tell you about. Acute normobolic hemodilution is another way. Cell salvage of the excessive blood loss that happens in the perioperative period, that can be done. And we have antifibrillatory agents and other pharmacological agents which will act on decreasing the blood loss. For managing the optimizing the fluid status of the body, patient in the intraoperative period, and correct mode of ventilation and oxygenation is also involved in that. So controlling hypotension, some surgery controlled hypotension, like some surgery which is going to bleed more. So keeping a threshold of 65 to mean arterial pressure of 65 to 70, and decreasing the blood pressure will also decrease the blood loss. And hypothermia prevention becomes a paramount important in the perioperative period, especially for the surgery which is going to last long and which is going in which we are expecting blood loss. And in position of the body, making it a bit head up or surgical part to in the right side up, that also plays a role. So coming to the timing of surgery, once you have started the correction of anemia, so we should wait for 4 to 6 weeks before major surgery, before this sets in and patient gets optimized. We have to take the history of patient also, like if there is a bleeding history, we have to work on that. Risk stratification as per the surgery, as per the chances of bleeding, that those things should also be done. And if patient has got some like comorbid conditions like hypertension and say renal disease, liver disease, those should be optimized before the surgery, because the chances of bleeding will be associated with that. So optimization will be very prudent. And interruption of the anticoagulants and antiplatelets, that also plays a major part. So this slides tell us about stoppage of the warfarin before the surgery. Warfarin should be stopped at least 5 to 7 days before surgery. Low molecular weight heparin at least 24 hours. It can be stopped more than duration to more than that, and it can be stopped after surgery also. Talking of the antiplatelet drug, if it is a low like aspirin at the low dose is going, and patient is carrying some cardiac comorbidity that aspirin needs to be continued, it can be continued very well. And other antiplatelet agents should be stopped. So this is clopidogrel should be stopped 5 to 7 days prior to the surgery, and this is cantrolil, which can be given up to 6 hours prior to surgery, and it can be started immediately after the surgery also, if there is a taking surgeons into the confidence that there is no risk for the further bleeding. We can start it immediately in the post-operative period. Dr. Surya talked about the direct oral anticoagulants. These are the oral anticoagulants, and most of these oral anticoagulants should be stopped 48 to 72 hours, and it can be resumed post-op day 1 or day 2 also. So this is about the emergency anticoagulation reversal. We face this scenario day in and day out. when we are dealing with the surgeries, lots of patients will come for the emergency surgery. They'll be on anticoagulant and antiplatelet. So we are in dilemma of how to go about it. So we are not getting proper time to stop it. So for anticoagulants, we have FFP and this PPCs, that platelet prothrombin complex concentrates to our rescue. So this study has shown that most of us, actually it is the reflecting the truth what we practice. Most of us use FFP to reverse the anticoagulant in the emergency scenario, and PCCs are the other ways to reverse it. And some antidotes are also available, as pointed out by the Dr. Surya in the previous um, talk. So, how surgical approach can contribute to the reducing intraoperative blood loss? We should have a multidisciplinary meeting before the surgery if we are expecting major blood loss in the surgery in the intraoperative period. And feasibility of the less invasive procedures, laparoscopic or robotic procedures should be developed, should be discussed in the preoperative period. And if there is some major vessels that is feeding, suppose some tumor is there that is feeding the tumor, we can go preoperative, we can block that, and we can have less chances of bleeding. And there are some procedures like aneurysm can be operated in the radiological intracranial aneurysm can be, surgery can be done by the radiological approach also. So if it is feasible to go that way, we should try to approach those things in the pediatric period. And surgery, suppose there is a very major surgery and we have to go for that, it can be done in the stages also. Like we can have one stage, we can do one part of the surgery, and then another stage, we can do another part of the surgery. So this also will have a major impact on the intraoperative bleeding. And suppose we have some surgery and we need some expert from other discipline of the surgeons. So we can invite them for this coming and helping out in the surgery. Like the vascular surgeons will be ideal for the vascular anastomosis happening in transplants and other things, that they can come forward and help. Use of electrocardiac harmonic scalpel. I think Dr. Piyush is here. He is going to talk about all these things. And use of surgical adhesives and tissue sealants can be used. Tourniquet, I consider it, though some evidence are available that it is not going to help much. But yes, still it is in some surgeries, especially the limb surgeries and all. It definitely helps in reducing the blood loss that happens in the intraoperative period. And use of vasoconstrictors like adrenaline, phenylephrine, all these things are very popular with the ENT surgeons. They are very fond of doing using vasoconstrictor to decrease the blood loss. Talking of my pet topic, this is acute normovolumic hemodilation. This is one thing that can be practiced in the pediatric period if you are expecting a major blood loss. It's a surgical procedure then it's performed before the surgical bleeding phase. What we do is we are removing blood from a patient and storing it with the anticoagulant in a bag, and we are replacing this blood volume with the hysteroid and colloid. So basically, there is some hemodilation happening in the patient, and when the blood loss happens, this hemodilation blood is getting lost. And once the surgery is over, we can give it back to the patient, and then the patient's hemoglobin will be in between these two. So this is one way of carrying on if you are expecting major blood loss in the intraoperative period. So this is how we do it. I personally have done in more than 100 cases in ANH. ANH is have been done. So we take a blood from the blood bank. They'll provide this anticoagulant containing blood bag. We take it from the patients, store it here, and then that can be used for the later surgery. So there are some prerequisites for doing acute normovolumic hemodilation. We have to have a hematocrit of more than 12 or at least 11 has to be there. and target hematocrit should be 30. And this is the formula to calculate how much blood volume we can calculate. We can take from the patient, taking a hematocrit target of 30, and we should be careful in patient with who has got CAD or renal dysfunction. So what are the benefits? It reduces the risk of allogenic transfusion. We know all the risk, that the infective risk, hemolytic risk, immunological risk, and that carries the blood bank blood carries so much of risk to the patient. And there is a nil to minimal risk of alloimmunization, sensitization, and immunomodulation. And obviously, what the blood we are giving is a blood which is coming from the patient. It has got all the coagulation factors and platelets, and it's not only packed RBC cells. So, and we are giving immediately, so it's within 3-4 hours. So it will have the same blood clotting factors and platelets. It goes back to the patients, and it's a simple and low cost procedure. We had done a study, and we found that one blood we were able to save around 1,950 rupees. And if you carry in the 100 patients, we are going to save more money to the patient and to the institute. And there's it's very useful in the rare blood group and Jehovah's Witness. And it is mostly kept in the room temperature or low, slightly lower temperature, and so it decreases hypothermia. And studies have shown that it has got no effect on anastomosis, flap viability, or oxygen delivery. So ANS does not lead to increased surgical bleeding or higher rates of transfusion, provided you are doing it within the guidelines that is there. So a recent meta-analysis of 2,439 patients from 29 RCTs showed that ANS in cardiac surgery had resulted in fewer Paxil transfusion and fewer post-operative blood loss in the drains and decreased risk for allogenic transfusion. And how anesthetic techniques are going to continue to minimize the blood loss. There's a epidural and central urexal blockade in form of spinal and epidural blockade. They are helpful. And then there is what we can do is practice, especially in the surgery which involves loss of vascularity, pulmonary hypertension, maintenance of intravascular volume, and avoidance of hypothermia. And position, if we are careful about that, these things are going to help us. Coming to central urexal blockade, spinal and epidural anesthesia leads to reduction in blood loss during surgery by 25 to 30%, and in the post-operative period too. There's many studies to prove that. And mechanism proposed that causes a systemic hypotension by sympathetic blockade, and there is a decreased venous tone also that leads to decreased venous bleeding and decrease in the stress response. Stress response leads to the increased concentration of epinephrine and other stress hormones in the body. That also leads to the increased bleeding. So, and this stress response is also decreased in peripheral nerve blocks also along with the central urexal blockade. This study, this meta-analysis published in American Journal of Rhinology Allergy, it says that even TIVA, the total intravenous anesthesia with the help of propofol and other anesthetic agents, were contributed to the decrease in the intraoperative bleed in the endoscopic sinus surgery compared to the inhalational anesthesia that was used. Permissive or controlled hypotension, it is a reduction of MAP while maintaining the perfusion. So it should not be very low. It should be enough to give the perfusion to the vital organs like kidney and brain. So 65 to 70 mean arterial pressure, and we can use different agents like inhalational agent, propofol, vasoactive agents, and that in the titrated dose. We should have an hemodynamic monitor, invasive monitor to available that, so that we know that we are not going too much into the decreasing the blood pressure. And some patients where we cannot use our coronary artery disease is patient with uncontrolled hypertension and cerebrovascular disease and preoperative anemia. Maintenance of intravascular volume while doing all these things is also important. So we should have a goal-directed fluid therapy for each and every patient that we are doing, and along with the hemodynamic monitors. So fluid should the total fluid should include the preoperative deficits, basic metabolic rate of the patient during the surgery, and replacement of the losses which are happening. We can use crystalloid, colloid, blood components, and supplement prudently with the vasopressors. We don't have to give too much of fluid. There should not be any hemodilation, because hemodilation leads to a vicious cycle. So whenever required, give fluids according to the goal directed. That means the targeting the blood pressure and filling pressure, urine output, etc., lactate levels. So, and yes, and you should supplement it with the blood products, and if required, and as indicated, and along with the vasopressors. Hypothermia is a very big killer in the intraoperative period. If the surgery lasts for more than half an hour, we should have a monitor placed for the temperature. And hypothermia leads to the alteration in the platelet function, and various coagulation factors also get affected. Along with the increased rate of infection that is very well documented, and all the temperature dependent enzymes gets affected because of this, and patient becomes hypocoagulable. So it is known that mild hypothermia, even less than 1 degree fall in the temperature, increases blood loss by 16%, and the relative risk of transfusion is increased by 22%. So use temperature monitors whenever the major surgery or long surgery are planned, and warming devices and warm fluid should be used. This this studies published in anesthesia and analgesia, the Lancet. Lancet, it says that if you can see that there's a patient with the normothermia and patient with the hypothermia. You can see the difference with the blood loss that is happening. Ventilation mode, we have to minimize the mean intrathoracic pressure by giving a low tidal volume and minimal peak, and you should avoid hypoxia or hyperoxia both, because both can have an adverse effect on the patient ventilation. Though the evidence is contradictory, but yes, this is the ideal way of approaching if you want to minimize the blood loss. So this article published in Medicine is about the impact of the modality of mechanical ventilation on bleeding during pituitary surgery. They did 86 patients received either VC, volume control mode, or pressure control mode ventilation, and what they found that ventilation does not have any effect on the amount of bleeding in the pituitary surgeries there. So there is a contradictory result, but still increase intrathoracic pressure, especially in the thoracic surgery and all, we have to be careful about that. So metabolic acidosis, then this as hypothermia and dilution coagulopathy. These are the three killer during the major surgery, likewise in trauma also. So these three things should be we should be very careful about. We should be very conscious about tackling these things. So in the perioperative period, positioning, incorrect positioning leads to the venous engorgement and bleeding. If we have to, ideally we should elevate the operative site above the level of right atrium to facilitate venous drainage and decrease local venous pressure. Twisting the neck will also lead to jugular venous drainage obstruction. So that also leads to increased bleeding in the head and neck surgery. Prone position, we should be careful about the pressure on the abdomen, because that will lead to the, especially for the spine surgery and all. So that leads to the increased epidural venous pressure, and collateral vertebral venous flexus gets more pressure, so bleeding will also increase. We have many agents to help us out to deal with the intraoperative bleeding. That systemic hemostatic agents. We have tranexamic acid, we have epsilon aminocaproic acid, aprotinin, and there are different other agents like desmopressin, tamsulet that are available. Tranexamic acid is the one major weapon that we have to against the intraoperative bleeding. That it's a synthetic lysine analog. It's an antifibrillary agent. It inhibits the activation of plasminogen to plasmin. Tranexamic acid is 6 to 10 times more effective than ICA, which is epsilon amino acid, caproic acid, and has a longer elimination half-life. So it's a preferred agent. There was this aprotinin which was earlier being used, but it has been withdrawn from the market in 2008. And tranexamic acid is being used successfully in all the kind of surgeries and all the places where bleeding is happening in cardiac surgery, non-cardiac surgery, in gynecology and obstetrics, trauma. Many studies in trauma like CRASH2, CRASH3 trial has suggested that it is useful in trauma patients. In gynecological and obstetric surgery, women trial has also suggested that it was useful to reduce the bleeding in the during delivery and during cesarean section. And it also can be used in the bleeding anticoagulants like dabigatran, divarexon, napixaban. Loading dose is 2.5 milligram to 100 milligram per kg. There is a very wide dose range. Ideally, we use around 10 milligram, 10 to 20 milligram per kg in the perioperative period. Maintenance dose is around 0.25 to 4 milligram per kg per hour, delivered over 1 to 12 hours. It can be given in the infusion also. And on pump surgery, we give 10 milligram per kg given 3 times before, on, or after weaning from CPP. And trauma 1 gram or 10 to 15 milligram per kg 8 hourly. There is evidence against it also, but that's a very this is a past trial which was done where they found that pre-hospital administration of tranexamic acid followed by infusion over 8 hours did not result in a greater number of patients surviving. They looked for the six months survival, and that was not affected. But yeah, for immediate results, it works wonder. Desmopressin is another agent. It's a synthetic analog of vasopressin, which is antidiuretic hormone. It causes transient rise in plasma level of factor 8 and von Willebrand factor. It has been used since ages for the hemophilia A and von Willebrand disease, but it can also be used. It has been suggested in the acquired platelet dysfunction secondary to many drugs, uremia, and cardiopulmonary bypass. It carries some risk of developing arterial and venous thrombosis, and results are not very convincing, but it is a promising agent. More studies are required on this drug. Procoagulant factors. We can use fibrinogen concentrate precipitate in documented hypofibrinogemia. These are documented problems are there, then we can use this. Laboratory reports should be supported. Then only we can use these agents. Factor 13 concentrate at the dose of 13 international units per kg in factor 13 deficiency if there is a less than 60% activity. Vitamin K and prothrombin complex can be used at the dose of 20 to 30 international units per kg on patient on oral anticoagulant therapy. Or factor 7A has also been used in many studies in the obstetrics bleeding trauma, but we have to have because these are costly agents, so we have to have a proper indication to use these drugs. Viscoelastic assays or point of care coagulation function should also be used to guide the agent that we are going to use in the perioperative period. We should know which blood product has to be given, which agent has to be given, and this monitor is going to help us in knowing. I think Poonam ma'am is going to talk about it, so I'm not giving much detail of it here. So there are some monitors like ROTEM, TEG, and sonoclaw that are available. For platelet function also we have platelet function assays, and activated clotting time is a very commonly used monitor in the perioperative period. So this is how it looks, ROTEM or TEG parameters, depending on if there is the problem in the initiation of clotting, or there is a problem in the strength of the clotting, and whether there is a problem in the lysis of the clot. Depending on that, we take a call, and we can accordingly we decide which blood product or which drug can be given. Another mode in the intraoperative period is autologous blood salvage and reinfusion. If there is a lots of blood that we are losing in the intraoperative period, so those blood, if that blood can be collected, cleaned, given filtered, given washed with the saline, given, and it can be given back to the patient. So. But it is then safe and effective in reducing allogenic blood transfusion, like we did for ANH. And washing results in loss of platelets and plasma, but it's a good source of autologous packed cells. And it is doubtful in or it is debated in patients with the cancer and obstetrics and valve contamination surgery. They say that it might lead to the increase in the risk of infection or metastatic lodgement of the cancer cells, but still it has been proven to be safe. This study published in urology, where they used the intraoperative cell salvage in urological oncology, and they didn't find any increased risk of cancer spread with the use of the intraoperative cell salvage. What all things we can do it post-operatively? We can optimize erythropoiesis by managing. We can patients who lost blood, we can put them on iron and folic acid therapy, erythropoietin therapy if required, and drugs which can help, which can cause anemia or which can increase blood loss, that can be carefully titrated. We can monitor for the further blood loss and iatrogenic blood loss, but even repeated sampling can be reduced. And drugs which are interfering, again, we can take care of that. So appropriate food resuscitation to maintain the perfusion pressure, avoiding dehydration and post-operative nausea, vomiting. These are other ways of preventing post-operative blood loss in that one. So this is a recommendation published in the European Journal of Anesthesiology about the management of severe perioperative bleeding. I'm just going to talk about 1A recommendation. There were other recommendations also. 1A recommendations that they suggested were restrictive transfusion strategy, routine use of red cell salvage, consideration for tranexamic acid or ICA, and restricting use of. They said that this should not be used at the drop of hat. We should be guarded about the use of it. And if there is a huge upper GI bleed, early use of vasoconstrictor should be used. And severe bleeding associated with IV unvaccinated heparin should be immediately treated with the IV protamine. So when to transfuse, this is the last thing that I'm going to talk about. So there are different threshold by different society of suggesting that different study has suggested that there's a TIC study, focus and TRIS and TIC3. In different study, they have suggested a threshold of 7 gram to 10 gram, and it varies. So mostly this Cochrane analysis published recently, they did a systemic review of 48 trials involving 21,433 patients. So they compare restricted transfusion threshold of 7 gram to 8 gram and liberal transfusion threshold of 9 to 10 gram. What they found was there was 41% reduction in the overall transfusion, and there was no difference in the 30 days mortality and morbidity. This is the most important thing. No difference in the pneumonia, wound infection, and bacteremia. So this is quite encouraging finding. Although they were non-conclusive about incidence of acute coronary syndrome, brain injury, stroke, thrombocytopenia, cancer, heme malignancy, and bone marrow failure. Society guidelines, there are different society guidelines available. So what we practice, Again, there is a variation in the individual practice also, but the guideline says 7 to 8 gram per deciliter unless there is a coronary artery disease or some major respiratory problem, then we can go to 9 to 10 gram per deciliter to that. So that should be the consensus is on all the places. So this is there is one Papworth Hospital perioperative transfusion algorithm where I think you should know about all this thing because this gives us clear indication that at what point what blood products should be given. So we should also be very well aware about the potential risk of blood transfusion. So as Dr. Richard had already pointed out with us, best blood is the safest blood of transfusion which is not given. Okay, why give to when one can do? Yeah. So this was this study was published in Nature, and what they found that just simply by reminding a doctor whether asking them whether are you sure you want to give this blood product to the patient, they were able to reduce the blood use by 24%, and mortality also went down from 5.5% to 3.3%. So talking about the individual practice, this was from my earlier institute in Jodhpur, what we practice in the cardiac surgery. So preoperative measures that we took was we took a detailed evaluation of anemia and correction of underlying cause. Oral iron therapy we started in the first visit itself in the OPD. In CABG patient, eco-experience is continued till surgery, and dual antiplatelet clopidogrel was stopped 5 days before surgery. And we did a coagulation profile of patients with past history of bleeding. Otherwise, also we used to do in cardiac surgeries. Intraoperative, we practice acute normovolemic hemodilation in and after induction of anesthesia, and 60% of around about 60% of patient cardiac surgery which we did in our center, that we did it without a blood from blood bank. So it was patient's own blood that was used in the perioperative period. That we considered it to be very this is and meticulous surgical technique during sternotomy to prevent any vascular injury. And we had a controlled bleeding within one bleeding time so that coagulation factors are not consumed. We used a cell saver device in selective cases which required which had blood loss, and retrograde priming was used to prevent hemodilation. And we also had a salvage of pump. We also did salvage of pump blood and ACT guided heparin dosing during prolonged cardiopulmonary bypass to prevent platelets and protein consumption. Protamine to reverse heparin effect after coming off cardiopulmonary bypass. And tranexamic acid and epsilon aminocapturic acid were used in selective cases to promote clot formation. Postoperative measures that we took was the sudden rise in blood pressure was prevented by vasoactive agents to avoid vascular suture line bleeding. Postoperative blood transfusion was done only if hemoglobin was less than 7 gram per deciliter. And we also had a correlation with the clinical condition. In some patients, we need to give at the even at 8. We took a call on that, but this was our practice thing that we did. Close monitoring of drain output and low threshold for surgical explosion to avoid excessive blood transfusion. And at time of discharge, oral iron and folic acid was added to treat the anemia to the patients. So to conclude my talk, intraoperative blood loss is an important cause of mortality and morbidity. We know that. And there are perioperative measures to prevent or minimize it at least. And anesthetic and surgical factors should be taken care to do that. And evidence-based preventive and transfusion strategies are available, and it should be very well. We should learn about it and we should implement it at our institute. And it's a team effort. It's a team effort for anesthesiologists, surgeons, transfusion specialists, and obviously staff nurse which are involved in that. Thank you so much.
Thank you, Dr. Mrityunjay Kumar, for an excellent overview of the various tools which are being adopted in preventing blood loss from the anesthetist's point of view.
Yes, sir.
Well, it was an excellent. I think we'll go to the second speaker.
So you can see this. This was again what we did in ANH cases. So acute normal volume. This was the perioperative hemoglobin. This was after the surgery. There was not much difference in the 13. We started with the 13.68 and it went down to 11.11. We didn't take a blood from the blood bank, and patients were having a good hemoglobin even after the cardiac surgery. So that was it. Thank you.
Thank you very much, Dr. Mrityunjay. I would like to call Dr. Piyush Ranjan, Additional Professor AIMS. His career highlights are that he has had travel grant Europe SMO twice, travel grant of UGC, Next Gen Oncologist Award, Best of SABCS, 7 funded projects as PI, extramural and intramural, 6 projects as co-investigator, co-investigator of a squeeze trial, member of task force for venous thromboembolism, member expert committee for critical care curriculum development, Ministry of Health and Family Welfare, again member expert committee, trauma and emergency care at district level, and member of Delphi consensus for evaluation of national requirement of blood by CDC and CMC. So welcome, Dr. Piyush. F5 compare. So we already had an anesthetist perspective. Now we are going to have a surgeon's perspective. So he's going to talk about tools to minimize blood loss in the operating room. I think it will take just a minute or two for some glitch in the system. Yeah, good. Thank you. Over to you, Dr. Piyush.
Yeah, thank you, sir. And very good afternoon. Yes. And at the outset, I would like to thank the organizing team for this opportunity. And I'll start with a very famous quote from the Greek philosopher Aristotle, that knowing yourself is the beginning of all wisdom. That's one. Second is, one should be awake enough to know our surrounding. So I'll be hovering around these two philosophical statements, right? And it will be a surgeon's perspective how to minimize blood loss in the OR. So that we are well prepared pre-operatively, we do all correctly in the intraoperative room with the help of anesthesiologists, and in the post-operative period also, we should follow the guidelines and try to minimize further loss. So we all know that pre-operative bleeding and transfusion both are associated with increased mortality and complications. And healthcare cost is increased because resource mobilization is there and more hospital stay is there. So we should all strive hard to minimize this loss so that we can improve the outcome. And the biggest nightmare for a surgeon is bleeding followed by infection, right? And over these years, we have evolved so that we can perform safe surgeries. And this is possible only because of 3 things. One is good anesthesia technique. Second is good hemostatic agents, energy sources. Third is asepsis. So in crux, these 3 things allow us to do safe surgery. Now, what is the significance of blood management in a patient who is undergoing surgery or planned for surgery? So 1/3 of these patients, particularly in developing countries, have anemia posted for major surgery. And of all these patients, 10% require blood transfusion. So as discussed, it increases the mortality 2 to 3 times, and infection rate also increases along with the cost. So what we do?
There are some special categories which I like to mention, that in some malignancies like colorectal cancer, we were quite skeptical in giving blood even if the patient was anemic, because these patients are anemic because of chronic blood loss, because there is an ulceroproliferative growth in the lumen. But some studies, they refute this finding. But even then, we keep our finger crossed when we give blood, because chances of dissemination of these cells can occur. So these are the special groups wherein we are a bit restrictive. Otherwise, we follow the transfusion triggers as discussed by Dr. Mrityunjay. Right. So going back to our philosophical statement, knowing ourselves, knowing the patient, and knowing the OT. So this is the three things that we should be doing while managing a patient. So knowing your patient. So for that, we need to, whether we want to operate in an elective setting, because things are much different, even in the tertiary care setup. And if you want to operate in an emergency setting, again, it's different, because you are very less likely to get a very good energy source late in the evening or in the night. Then you have less manpower. Even help, if you want to need someone, if you want someone for your help, you'll need you have less number of people, trained people in the night during emergency. So in elective setting, it's imperative that you post a patient with indication for routine surgery in an elective setting. Optimize the patient. Like we are planning, say, Whipple's procedure. It's a major surgery, and synthetic function of the liver is impaired. That means liver is not producing adequate clotting factors. So we look at the PT-INR. If the INR is more than 1.5, we try to optimize the patient. How? We give fresh frozen plasma and vitamin K at least up to 4 days, because after that there is tachyphylaxis. So this is how we optimize the patient. Then treating anemia beforehand by increasing the nutrition, and if necessary to give blood. Then medications which have an effect on the hemostasis or the clotting mechanism, as discussed by Dr. Mrityunjay. So once we have done with these things, then only we should post a patient, right? In emergency setting, it's a bit different. With limited resources, you need to act. And at times you don't have the machines also, even at our center during the emergency surgery. And in the daytime, we have good machines, high-fi energy sources, but in the evening, we have only quaternary, monopolar, bipolar setting, right? Now, how we should know ourselves. So as a surgeon, we should be thorough with the anatomy of the area where we are planning the surgery. For example, I am doing more of thyroid surgery, but I'm not aware of the pancreatic vascular anatomy, and I'm doing a pancreatic surgery. Most likely, I can injure a vessel, right? So we should try to work in the domain of yours, right? And we should always respect tissue plane. If we do that properly, there are less chances that we'll injure a vessel. Even if you are using energy sources and if you're not using them safely, there can be collateral damage to the vessels nearby. Then team, you should know your team as well. So it should be discussed during the team preoperatively during the rounds that we need to optimize the patient. And these are the areas where we need energy source, which energy source to be used, topical hemostatic agents. We should be prepared with all these things. And we always discuss with the anesthesiologist, yes, this is the case when there can be blood loss. At times, we can have a patient when there is unexpected loss. For example, doing a simple lymph node biopsy, I have seen carotid artery injury. So those are unexpected events. We are not prepared for that. But as far as possible, we should be prepared. And we should not panic. First is to apply pressure. So most of the venous bleed, veins are high capacitance and low pressure system. If we apply pressure for adequate time, most likely the smaller veins, bleeding from smaller veins will stop. But the problem with veins is they don't have an elastin layer in the media of the wall, right? Unlike arteries, arterial bleeding, once artery contracts, the muscle contracts, the bleeding will stop. But veins, they will just bleed for a longer period of time. But once you apply pressure, you can stop those bleedings and you can repair it, right? And call for help. Ego should not come into this, right? Many times we have seen there is a lot of blood loss. Our anesthesiologist suggests that if possible, we should stop. So we try to achieve the hemostasis and we stop then and there, only to pose the patient again after the patient is optimized again, right? So it's not necessary that you go on continuing the surgery and there is then massive blood loss. So we should call our seniors, maybe juniors, because they'll give you a fresh perspective with fresh idea, fresh energy. They'll come in and help you out. So this is how to know yourself. Now coming to the surroundings, what is available in your OT. So we should not post a case, a major case in OT where there is no energy source, you don't have the blood bank facility, you don't have a colleague or a junior to help you out or proper assistance, and you don't have the instruments and equipments in form of energy sources. So we should not post a case. So interoperatively, if we have these type of forceps which can hold the vessels without damaging them, the great vessels like IVC or they can hold properly and they will not damage because they are sophisticated instruments, right? You can have some microvascular instruments, you can have some clamps called Bulldog clamp, Tisky clamps, all those things. If these things are not there, you should always be prepared with the slings so that you can catch out of them. So the dictum is anywhere you're performing a surgery, you need to take a proximal control, right? And as discussed by Dr. Mrityunjay, we should have a proper radio conference, radiological meeting with the radiologist, wherein we should look for the vascularity of the area of the tumor where you're operating or vascular involvement. So these two things are very, very important. Internal vascularity as well as the vascular involvement, right? And if the tumor is big enough, we can always embolize the patient, the tumor pre-operatively. So these are some of the things that we can do. What we say, predict and preempt, right? So we need to see what instruments we have. Then coming to the armamentarium of the energy sources. So we have monopolar cautery. You can see two buttons there, blue and yellow. Yellow is for cutting one, blue is for coagulation, right? In coagulation, there is more lateral spread. Then if you don't want lateral spread because you have vessels and nerves nearby, we go for this bipolar. The energy goes from one tip to the other, right? So this is bipolar. In vital areas like neck, face, we use this instrument. Then we have good energy sources. What they do, some use high frequency, that is 3 to 30 megahertz, which doesn't cause any cellular motion, but ionic motion is there. They create heat, a lot of heat generation is there without any collateral damage. They will coagulate the vessel. Up to 7 millimeter vessels can be coagulated with instruments. But at times we are not that, you can say, we are quite very skeptical. So we use one tie along with it. But usually we do most of the surgeries with these energy sources, good energy sources. Some use ultrasonic principle, some have radio frequency, right? Then we have topical hemostatic agents. Usually it is used when there is ooze, not a bleeder. See, if there is a bleeder, we can see that it is quite easy to control. But this ooze is quite worrisome, particularly in the post-operative period. We have done a very good surgery, but we see in the drains so say 500, 800 sanguineous fluid is coming out. So what to do? Then there is a dilemma. Patient is dipping, whether to re-explore or not. We discuss with an SCR colleague. So it's dicey, and most of the time, whenever we go back, we don't see a bleeder. It's a diffuse ooze. Then we realize that we should have used topical hemostatic agents. So what are those? There are so many. Basically, one acts as direct, indirect contact, right? And other acts externally. So the first one is ORC, oxidized regenerated cellulose. That is the picture. It is malleable. You can fold it. You can use it in laparoscopy. You fold it, roll it. It can go into the inaccessible areas as well. So what it does is it promotes clotting, right? But it is associated with infection also. Ideally, it should get absorbed within 14 days, but residual ORC can be there, and it is a major source of infection. And one practical thing that we have noted, if you're doing a biliary surgery, if you put, say, even after say laparoscopic cholecystectomy, there is bleeding from the liver bed, there is oozing. We used to keep these surgery cells, but they become blackish before they get absorbed, and the drain fluid in the next day, it looked like venous fluid. That's a problem. But now we know that it is because of this ORC.
Now we have gelatin matrix, the white Surgicel, Abgel, all those are gelatin matrix. So they are partially absorbed bovine collagen, right? Now they are used, they're foam-like, so it can be used as powder form or foams. You can cut these, but these are not as malleable as ORCs. So you just put that. The property, a good property about it is it can absorb 40 times fluid, and it can expand around 200 times in dimension. So if you have ensured hemostasis, only oozing is there, keep there, it will absorb everything and it gets dissolved after a few weeks, right? Then we have microfibrillar collagen, same thing, but added properties, it activates platelets for thrombosis. Then in our hospital, we have fibrin sealants. What is that? This is a mixture. We have two solutions. We mix it immediately before surgery. We have concentrated fibrinogen along with factor 12 and thrombin source with calcium. So we mix it. We use a syringe to put that. It's a liquid. You can put it over any anastomosis if it's bleeding, over the surface of any solid organ. You can keep this. We have topical thrombins and cyanoacrylate, which is nothing but a glue, right? And one product where we have also worked in, it is chitosan. For example, cockroaches, the outer layer is made of chitin. So this product, chitosan, it is a very good adhesive as well as a hemostat. And a lot of commercial products are now available based on. So where we use these products, if there is a diffuse bleeding, as discussed, maybe the peritoneal surface, solid organs, around the anastomosis, cut edges of the bone. Earlier, we used to use the bone wax, but there is a lot of infection associated with the bone wax. Now, we don't prefer bone wax. If there is bleeding near nerve, you cannot go and use your electrocautery because the nerve will damage. Either we apply pressure or you can apply these hemostatic agents. Now, if you do more, if your learning curve is over, you can say, so you can use minimal access techniques, right? Why? Technique is same, but there is a lot of magnification. So you can see even the smaller vessels very bigger, right? And you can always use your energy sources to ablate or destroy the vessel, to coagulate the vessel. Only problem is if there is bleeding from a small vessel during laparoscopic surgery, the red blood, it absorbs light and the entire area you don't see actually. Because the absorption of light, there is very less light inside. So unless you achieve the hemostasis, you cannot proceed further. So bleeding during laparoscopic surgery is the major cause of converting, right? We convert to open surgery, right? And conversion is not failure. You are doing this to save the life of a patient. So try to do more of minimal invasive surgeries. And as discussed by Dr. Mrityunjay, cell saver, it's there. You use the blood of the patient, use heparin as an anticoagulant. It goes there and you wash it. Although loss of platelet is there, but you have washed RBCs, you can retransfuse. This auto transfusion. And there are different types of machines available. But what it does is it gives you washed platelets around 225 ml together, and with it maintains a hematocrit. In that fluid, the hematocrit is usually around 55 to 60%, which helps. So whenever you are contemplating a major surgery, wherein there will be, say, aorta bifemoral, so use of these type of devices is prudent. In post-operative care, again, first is to look at the drains if you are placed. What is the content? What is the volume? What are the vitals? Right? If volume is high, it is pure blood. Tachycardia, this is soft sign. Many times we tend to rely more on the blood pressure rather than tachycardia. It's the tachycardia which appears first. So if there is tachycardia and blood loss is evident, maybe you need to re-explore. Else, if you have the facility, you can go for a CT angio so that you can embolize if there is a blush. Then you have done a major surgery. The patient is high risk. Patient was taking some anticoagulant earlier or has some bleeding disorder. Again, they should be monitored very, very carefully. Now, tranexamic acid, again discussed by Dr. Mrityunjay, post crash to trial, we have started using this if there are oozing, right? Diffuse ooze, it helps. And fortunately, AIMS was also a part of that trial, crash to trial. So this is used very frequently at the dose of 1 gram. Surgeons are not that intelligent to remember all the difficult dosing regimes. use 1 gram stat followed by 500 milligram. And the key thing is the resuscitation should go on, and the decision for re-exploration is very dicey, very important, at times life-saving for the patient. So we should not think that I have operated, the patient will be all right. No. And we always emphasize that the operating team should come for re-exploration because they know that where was the problematic area. So they go back to that area. And so future directions, we can have different types of blood substitutes and tissue handling. We will have more advanced energy sources in the future, because as of now 7M can be coagulated. We can go for larger vessels with minimum collateral damage, right? So this is the future, and all of us are working hard towards this. So just to conclude, this is an area wherein we should always predict as a surgeon that we can have major blood loss, and we should preempt. Preempt is knowing yourself, knowing your patient, knowing the OT and your health. And goal is to prevent significant bleeding and transfusion requirement. If you do this, you save some money, save a life. Right? Thank you.
When we go to the discussion, the first speaker.
Yes, he's here.
Well, firstly, very good, excellent presentation. And the first vote, for example, I would like to know how often you are checking when your patient is taking the care and that anesthetic, you are doing the re-anesthetic check that the patient red cell antibody screen is done or not. How often you are checking this?
What we're checking is whether there is indication of patient blood transfusion or not. Whether patient will be requiring it, what is the hemoglobin level of the patient, what is the blood group of the patient, and whether the cross match has been done or not.
Well, my question was whether antibody screening done or not.
We talk about the blood group cross match.
No, there is two things, because basically, since this is the patient blood money, and we have the search status and every person. Because why I am talking this? Because when we do, as we call it type and screen, we also do the blood grouping, we screen for the any atypical antibody. What happens? Because basically there are some surgeries what we type and say we don't, because you don't practically need the blood. For example, doing cholecystectomy, appendectomy, or anything, where you just do the blood grouping and do antibody screening. Because once you take the patient data, you do a laparoscopy. And there is a possibility once the laparoscope is just inserted, well, it hits some of the major vessels and it can take the land into a pool of blood. At that time, you send a request to the blood center, well, they come out, well, the antibody screen turns out to be positive and you are not in a position to find a compatible blood. Because this happened in a scenario at ours, and we had to cut the sorry figure and we lost the patient. So these are basically our motto is to have the introductory type of the thing. What should be done at various stages?
Usual normal.
Every patient should go by.
Yeah. So if it is blood, meaning under the blood bank.
No, it is not, because you have asked for it. Because basically you cannot do anything unless the clinician asks. And you have to maintain it.
What you're saying is you should be doing for all.
Should be good for all patients, irrespective of what.
Whether he goes for type and screen or you go for a transplant, every patient, so that you know it beforehand and it should be maintained in the file for the subsequent. Maybe tomorrow he goes for a surgery, you find that this particular patient had any atypical antibodies. At that time, you can. I had another patient where we called the patient for a liver transplant. We had not done it. We find an atypical atyp. The patient came for a all normal surgeries. Well, it should be done. It should be done. Because basically, when I said Well, we just inserted the patient surgeon, inserted the laparoscope, he hit an hepatic artery, patient went to a pool of the blood, asked about the blood, and so these things are the number two. Well, you said very rightly, vitamin K. Vitamin K, well, it will take, under those circumstances, it is better. Well, we give FFP because it will take a lot of time for the vitamin K to take, because it generates what we call vitamin K dependent factors. That is factor 2, 7, and 10. Because they will take time. So it is best to infuse the fresh frozen plasma or a cryoprecipitate that will help the patient. Well, any questions from the audience?
Sir, before that, can I add something to the first question?
Yeah.
Actually, the same thing has been discussed again in your transfusion committee meetings, because what you're saying is correct. Any patient can have bleeding, and that time you don't know the antibody status of that patient. You don't know the group only. So in trauma, we used to do saline cross matching to take any of the blood group or antibodies, right? So here, what we have decided, because pre-operatively we write so many investigations like LFT, RFT, ECG, CSR, everything. Why not blood?
Yeah.
It should be part of the pre-anesthesia checkup. So this is what we have decided and suggested by our transfusion medicine colleagues. So soon we'll have that routinely for all patients.
Thank you.
Dr. Mrityunjay, I also have a small question. How do you decide which patient would require hemodilution before surgery? You said you did more than 100. How do you choose your patients?
They don't choose. We give them the opportunity.
First thing is patient should be not any respiratory element that is affecting the respiratory function. Okay. And age is not a even in neonate it has been done. ANH has been done. Okay. Yeah, and 12 plus. Recommendation says 11 plus, we can go for it. But what practice was that 12 plus hemoglobin? That should be and dark hemoglobin. How we calculate it was the problem.
Suppose you withdrew 2 units of blood before surgery, and for some reason you didn't require one. What happens with the one which does not get it?
From the
So it never happens that one of the units goes on.
It never happens. When we are doing ANH, it goes to the patient.
Even if the patient does not require it.
Yeah, because that was a basal hematocrit that was there.
And like how do
you okay. So can we give it as a maintenance?
Yeah, absolutely.
Yeah, okay.
And how do you decide which patient would require salvage?
Expecting more blood loss. So
out of 100, how many would have ANH, and out of 100, how many would have salvage? Just to have a perspective for all of us.
so if it is and it again depends on the center also. I'm more comfortable with the cell salvage.
At your center.
This center where cell salvage is there in the CN center. ANH in some cardiac surgeries are being done. Personally, I've stopped doing it because I'm in the general side now. Previous center where I was there at Jodhpur AIMS, where I was doing cardiac surgery and other surgery. We use in cardiac surgery, neurosurgery, orthopedic surgery also we have used ANH because people saw the advantage of it. So other surgeons also got involved into it. So that was that. I wish I can do the same thing. I tried it in scoliosis surgery at my center here, but my surgeon is so good. There's not much of blood loss happening. So there's no use of ANH there.
Thank you.
Okay, thank you.
Hi, good afternoon, Dr. Mrityunjay. Very nice presentation. It's very heartening to know that you were following these PBM practices back at Jodhpur. I think Dr. Archana Bajpayee was there. Yeah. So I have one query. So right now at TMH Varanasi, we are doing a clinical trial on for ANH in uro-oncological patients. Yeah. So for him only we are doing it. So what is your experience like? Not in that sense at Jodhpur, of course, doing those surgeries on oncological setting. Like do these patients who are undergoing oncological surgeries?
Resistance as expected.
Yes.
Surgery we cannot do, but I'll show one evidence in the urological
Yes.
only. It is feasible in them. Okay, but obviously with a pinch of salt, we have to.
Yeah, so we have just started with Pandey sir there. So
Surgery, malignancy which has got hematological stem. We should in those surgeries.
yeah, only what we are doing is we are doing it on the concealed surgeries like yeah, prosthetic surgeries or complete prostatectomy, like those for only for urological. We are starting with that. So would you recommend these ANH in patient, let's say for colorectal surgeries, for surgeries with metastasis overall in the like something?
Colorectal surgery will be anemic as.
Yeah. So fine.
7, 8 these things so it can't be treated like that.
Okay.
The criteria could be met. You can do it very well. Do it.
Fine. Now, my second question is for both of you, Dr. Ranjan also and you. So we frequently face problems while calculating the blood loss intraoperatively. The surgeon's take and the transfer medicine's take and the anesthetist take. These all three values differ when we calculate.
Best way is to go for the gravimetric method.
Okay.
We can just buy a weighing machine in that thing and we can.
You go by the gravimetric method?
Yeah, but I wish to introduce it someday.
Okay.
So,
what about that volume which comes in the suction pump? Many times that OT speaking, it is not the resident or the consultant who calculates that, but the OT technician just calculate the volume of the fluid which is coming in that suction pump. Many times it is highly diluted, but still the value that they give us is far too high. What the even surgeon accepts that it is a loss.
The things college London for 1 month there, and what we saw is that all the liver transplant patients they practice this gravimetric method.
Okay.
They were able to calculate.
Fairly accurate comment. Sir, Dr. Ranjan, what is your two?
The anesthesiologist calculation is bit on the higher side, surgeons is bit on the lower side. This is practical, right? But the overall management, because the difference is not that much. So overall management, the post-operative management or the intraoperative management for that quantum of blood loss is not very different. So obviously we should measure the correct amount for documentation's sake, but the management that giving fluids or starting inotropes, this is a combined decision. So that's not a problem usually.
So it happens usually, rightly you have said that it usually doesn't happen many times, but it can happen. There is massive blood loss or something like that, then the amount of calculation done by both these teams.
So if you think it's a massive blood loss, we have set criteria for management of the same. It is immaterial what the surgeon is saying. Is the number of sponges and the drain fluid amount will dictate the management.
Okay. In case the market blood loss is happening, which was a serial calculation. Serial blood gas, okay, that will give you hematocrit value. That is a good guide to give actually. So that will give you an immediate what is happening. So along and your lactate level will also give you whether you are going right in the right direction or not. Yeah.
Thank you.
The other systemic markers will dictate the management after a certain point of time, after certain blood loss.
Okay, anything else? Thank you very much. It was a very good interactive session and we enjoyed it to be discussing the conditions, the problems, what we face in the transfusion medicine. Thank you very much.
Thank you, Dr. Mrityunjay. Thank you, Dr. Piyush. That was excellent. Thank you very much.
That was a very informative treat. We request Dr. Makru sir and Dr. Asim Tiwari sir to present a token of appreciation to Dr. Mrityunjay sir. And to present token of appreciation to Dr. Piyush Ranjan sir. Now we request Dr. Sulekha ma'am, CMO of Blood Center, Jayaprakash Narayan Apex Trauma Center, AIMS New Delhi, to share our token of gratitude to Dr. Makru sir and Dr. Asim sir. We now will break for lunch. All delegates enjoy the lunch and be sure to travel back after 45 minutes.
डॉक्टर पीयूष का किसने लगा
उनका तो ऐसे ही कोई नहीं मैं देखा मैं 17 से 19 था हाँ इनको हेलो बोलिएगा
मैं देख लेता हूँ मैंने जेब में तो नहीं डाल लिया
यू हैव मेनी थिंग्स टू वरी फॉर
नहीं मैं देखता हूँ कि सर की कोई पेन ड्राइव तो नहीं मिली
दिया इधर इधर क्या
being organized by AIMS itself in a very beautiful body. I didn't know that NAMS, which I cross every day, has such a beautiful auditorium. And thanks to Dr. Hemchand, thanks to Dr. Anjali, thanks to Dr. Gopal Patidar, people whom I've seen in and around the blood banks of CN Center, giving us unlimited supply of blood, unlimited products, and unlimited cooperation in the cardiac center at AIMS. Very indebted to them, and indebted that we all can work together in harmony and learn from each other. And that's what the aim of the CME is, so that you have more and more patients under scrutiny for point of care tests. Is it a part and parcel and a cornerstone in treatment? And that would be my intention in the next 15 to 20 minutes that I'm here with you. Why do my patients bleed? Well, this is Dr. Claus himself, and a mentor of mine for PVM, from whom I did research with and learned a lot. When we initiate cardiopulmonary bypass, we not only have hypothermia and hemodilution, but both the contact factor pathway as well as the platelet activation and dysfunction brings about thrombocytopenia. Platelet dysfunction is also worsened by the use of heparin, which is the gold standard anticoagulation on CPB, and the inflammatory response of bradykinin pathway and the complement activation makes it even worse. So what is happening? We are happening and seeing on a prolonged CPB thrombin activation and thrombin storm-like situation. And that is what you want to avoid. You want to avoid the use of these non-pulsatile centrifugal pump-like situations. You want to avoid the thrombin storm formation. The risk of hemolysis is even worsened by the use of large cannulae size. We have decrease in hemoglobin, increase in plasma-free hemoglobin with bilirubin. The urine color becomes blood-tinged, very often the first to be seen, and of course your creatinines and your renal function test, urea and uremia sets in. The moment heparin is responsible for platelet aggregation and the thrombocytopenia that you see, and therefore the moment you give heparin and initiate post 480 seconds ACT CPB, there is thrombocytopenia at the initiation of CPB itself. Now, this is where my common pathway, this is a phasic circle, and this I don't need to teach to the hematologist, but yes, thrombin activation from prothrombin to thrombin takes care by a fibrinolytic pathway, and that was my thing. We ignored the fibrinolytic pathway when we are in a cardiac center or any bleeding center anywhere. So since my talk is more on cardiac surgery, because I'm a cardiac critical care intensivist, I will talk more about what we've been doing with our point of care testing and what we've been doing by trying to prevent hemolysis, trying to prevent this bleeding, and the routine use of ACT, APTT, never to be done anti-10A, and so far, 5-6 years back, never to be done a point of care test beyond ACT was what we were taught. And patient safety is first and foremost, and a lot of literature coming up. Again, hematologists and transfusion medicine people need not be told about the use of more, less is more kind of a situation for transfusion as well, because we are in an era of less liberal blood transfusion. So going on to various associations coming up and NABH accreditation coming up and JCCI recommendations telling us what are your transfusion protocols. This paper from Stefan et al., that less is more, was probably the best paper that I could see to say that the use of preoperative standardized hemostasis questionnaire, which he formed, that my patients should have a questionnaire, which is an independent predictor to decide my postoperative PRBC transfusion. And therefore, this in this setting is a very, very niche thing that besides the algorithm setting in your local institutes, every institution who's doing bleeding protocol management should have a questionnaire formed. Now, how to weigh the thrombosis in an era of precision medicine, in an era of evidence belief mismatch and risk awareness deficit? It is important that you have factors which influence plasma transfusion practices, reflect the beliefs about indications of the efficacy of transfusion in the prevention and management of bleeding, as well as have effects on coagulation tests. And educational and other initiatives like this one, CMEs, multiple ones of them, These initiatives should target these beliefs and should be the focus of more research to come up. And this paper by Karam et al. Was also bringing home the point that we need our own local standing, that patients who had this main paper brought about from a Cochrane database, that patients who had FFP received more blood transfusions, suggesting that FFP may not be effective in this setting, and this had a moderate level of evidence as well. 3BC is what they gave it. And from another department came up this paper that patients presented with abnormal conventional coagulation tests both before and after FFP transfusion. However, if on them we did rotum and thrombin generation parameters within the reference interval and try to keep it within the reference interval both before and after FFP transfusion, then there was an improvement on the coagulation measurements as judged by coagulation tests and as well as by rotum and thrombin generation tests. So a lot of studies coming up said that even not just FFP, but patients who received prophylactic platelets had significantly higher red cell blood transfusions and less improvement in their SOFA scores in the subsequent 24 hours that they saw it. And therefore, platelet transfusion versus standard care after acute stroke in spontaneous cerebral hemorrhage associated with antiplatelet therapy, the patch trial, as it is famously called by the Bahar-Laglu group in the Lancet, said that from the interpretation of all the available evidence, platelet transfusion seems inferior to standard care after acute intracerebral hemorrhage in people taking antiplatelet therapy, and therefore we cannot recommend platelet transfusion for this indication pending the results of other similar trials after the patch trial. So transfusion doesn't stop bleeding and may improve outcomes in severe trauma and cardiac surgery, and therefore how to stop this bleed. So that's why I said from the Lancet Neurology Commission itself, precision medicine said that the knowledge network and the knowledge base with more scientific research is the need of the hour. And therefore this hemolytic, intrinsic, extrinsic and common pathway to the average intensivist is a part and parcel which I forgot, but I did it again in 2014 when I started to research first on sonoclot. And therefore, if I can have a point, I just want to say that it is this part of the fibrinolytic pathway, which is most important, and very importantly, when fibrinogen is being broken into fibrin from 1 to 1A, it is this factor 13 which is being depleted when we have a consumptive coagulopathy, and we overlook this consumptive coagulopathy factor pathway very, very often. We just look at this pathway is the important pathway that is neglected. So fibrinolysis is the primary as well as the secondary fibrinolysis. Whereas it's normal to have a primary fibrinolysis, the secondary fibrinolysis is the breakdown of clots due to a medicine like an antiplatelet or a medical disorder or some organogenesis anomaly, which may be the cause of hyper or hypofibrinolysis, which is very often the cause of bleeding. With that in mind, I'll just come to the rotum, the TEG, and the sonoclot. These are additional options with faster turnaround times, which include the point of care testings. And what you get in 4 to 5 hours when you send your sample in the morning for a fibrinogen or an APTT report, just the ACT is what you have at your machine. These give you within half an hour or within 10 to 15 minutes all the tests of the intrinsic, the extrinsic, as well as the fibrinolytic pathway. We kept doing many series from 2014 to 2024. I think this year we've ended about 22 such conferences, big and small, at different parts, national and international levels. While we were doing it, we were learning on our sonoclot machine, which gave us one chamber and one channel for ACT and the other channel for a heparinase. We use heparin in all our CPB and ECMO patients. So heparinase coated cuvets were given to assess the platelet function, to control the blood product usage and differentiate the difference between mechanical and hemostatic bleeders. And also in those who are resistant to heparin or have a hit-like situation, we got very, very good results. So that's the normal sono clot signature. Rise telling us the clot formation, the peaking telling us the platelet function, and the lysis telling us the clot rate. So this is the normal function before heparin. Once heparin is given, you have a long, prolonged clotting time, and this prolonged clotting time after 10 minutes has a small secondary, small peak, which is actually a hump, and this is the heparinase cuvette that we've used. Now, this is an example of a normal clot. It could be a single peak, it could be a double peak, but you get three parameters, the ACT, the CR, the clot rate, which is around 20, and the platelet function, which should be more than 3, ideally more than 2.5. And this in 30 minutes is a good marker of your clot lysis as well. Now, a hypercoagulable patient, let's say an ACT of 161, a clot rate of 44, with a platelet function of just 4.8, would have a hypercoagulability because of one factor, because these two are normal. Therefore, you will see that the clot signals are growing and have peaks. They have multiple peaks, and there is a general tendency for the blood to clot more. As against this, where the tendency is to clot less, here my clot rate is high and my ACT is also high and my platelet function is low. So therefore, the clot signals will not have a peak. It will not go up during the testing time of 30 minutes, and it will not lyse also very easily. Vis-a-vis this will be a typical hypofibrinolysis clot with an ACT which is normal. The clot rate which has come down, it is decreased. So my clot is not forming and peaking, and my platelet function here is normal, but the lysis is fast. And when I go on to this is a hypofibrinolysis. Here, the fibrin gel has quickly dissolved back into a liquid. This is a hyperfibrinolysis state. You will see liquid into the entire blood sample of the patient within 30 minutes, and confirmation of hyperfibrinolysis, therefore seen once you discard the clot, you'll see the liquid all around, and therefore it's easy. So let's see an example. A 22-year-old patient undergoes a post-tetralogy of fallow ECMO. In our center, we do an integrated ECMO where we feel the patient's having a redo surgery or is in a poor state or the complex congenital is there. We put all our pediatric patients onto an integrated ECMO system. This is a teamwork which has been developed by since 2010 with less mortality on ECMO. The patient developed low cardiac output, came out on a VA ECMO, and when on CPB, 1100 was the chest drainage. This patient on CPB or coming out on VA ECMO was having a very oozy low cardiac output state. Though the heart rate and the BP were within normal limits, the CVP you can see is dipping on the third day. And when we saw the clot signal on this patient in the ICU, this was a typical signal of acute dilutional coagulopathy with a clot rate of 6.1, much above the normal, the platelet function totally less. So I suspected that the fibrinolytic pathway is at play with the thrombocytopenia that one would expect with the heparin infusion still going on VA ECMO. Therefore, I ordered 3 units of platelets and about 4 units of cryo, which has a high concentration of fibrinogen. I suspected hypofibrinogenemia with thrombocytopenia. This was at that time in 2015 a hit and trial way of doing it with the signature clot. And after giving nearly over 12 hours, 15 units of cryo and platelets, this was the peak that I got. So at 24 hours, we had a normal hemostasis in this patient. Another patient, a 5-year-old Fontan patient with a platelet dysfunction at the baseline itself. Here, there's no time to peak and there's no lysis. So this was the patient at the baseline, sonoclot was done, came off on an ECMO, and this ECMO also showed a low, towards the lower side, a platelet count. So she had 2 units of platelet, single donor platelets given over 12 hours. We don't give it fast, and the patient did very well. Coming on to the difference between TEG versus Rotem, it's very easy. One moves, the cup moves into the pin and the pin moves into the cup. In the other one, the two have the same basic physiology. It's just that the nomenclature is different and the two graphs are different. To take this is the R time in TEG, this is the CT in Rotem. The 10 laboratories and now the Werfen holds it, and the Steranko in India, as well as the Hemonetics does it for TEG in India. So all very great companies companies, all doing good work. Having worked with all of them, I would give full marks that in an era when we were not aware, they made us aware with their technology. The liver transplant people got more of TEG and the cardiac transplant people took more of Rotem. That's the only difference that we see. A lot of publications came up from our center on the use of Sonoclot, about 8 of them, the use of Rotem, the use of TEG, and we were learning from each other. We were learning from the company men. We were learning from other intensivists all around. While we were learning, we realized that on-VV ECMO TEG looks very great, but it is very driven protocol, a TEG-driven protocol allowed the administration of less heparin doses without an increase in thrombotic complications. And TEG, therefore, previously called ROTEG or rotational thromboelastography, is another version of TEG in which the sensor and the shaft move rather than the cup itself that rotates. So this is a normal Rotem, and this has 4 channels. TEG has 2 channels. The extem is the extrinsic pathway. The intem is the intrinsic pathway. The fiptum is the fibrinolytic pathway, and the heptum is when we use any reagent like the heparin as an anticoagulant. You can have an aptem, you can have an ecatem, you can have, depending on the reagent that you're using, you could have the 4th. Remember, intem and heptum act together, and extem and fiptum act even better. So calcium chloride with tissue factor and polybrine are the reagents used for extem. It is a electronic pipette in which you move it. The extem with cytocalicin D is the piptum. You can have aptem, which is extem plus aprotenin. You can have traptum, which is extem plus tranexamic acid. Calcium chloride with ellagic acid is intem, and intem plus heparinase as the reagent is heptin. So ecatem is when you use icarin. Now, concept for bivalirudin, which has come up in a big way as an alternative to heparin. So the concept of Rotem-guided PBM is administering the right hemostatic drug with the right intervention in the right dose at the right time and in the right sequence. So which one to give first, and which is what the science and art of doing viscoelastic tests is all about. Rotem parameters like clotting time in extem and intem, clot strength MCF in extem and intem, fibrinogen activity MCF in fiptum, and fibrinolysis in extem and intem is what is taught. The Rotem platelet tests are also there in the new Rotem Sigma machines. Aratem is arachidonic acid pathway. The ADP10 is the adenosine diphosphate pathway, and the thrombin activated peptide is the traptan pathway, and platelet actrometry is excluded if your platelet count is very, very low. So in Rotem platelet analyzer, you have these various reagents and receptors which can evaluate the function of ADP10, aratem, and traptan, as I just told you. Platelet parameters with amplitude at 6, A6 is A6. It describes how well the platelets aggregate. You have a maximum slope. You have the area under the curve. Now, what came up in recent cardiac anesthesia and surgery textbooks were these algorithms, first given by Gorlinger, Claus, and Weber. Weber is a big name in algorithms with Dr. Claus. Working from Germany, they brought their way up in trauma and cardiac surgery and got out these algorithms to tell us what to use when. In this short time given to me, I won't be able to go through all the algorithms, but I would say that in today's point of care bleeding management algorithms, it's wise to rule out hyperfibrinolysis, to give tranexamic acid first and see the A10. So you have a A5 algorithm or a A10 algorithm. See whether at 10 minutes your ATEM extem is less than 45 minutes, or if your CT fiptum is more than 600 seconds, or if your ML, the lysis, is more than 15%. If that is so, it's a hyperfibrinolysis. Use that first because it's the fibrinolytic pathway which is being attacked. If it is not so, then it rule out the effect of heparin and neutralize the heparin effect by protamine in a 1:0.8 sequence or ratio. If it is not so, then after the fibrinolytic pathway, rule out with a cryoprecipitate or a fibrinogen concentrate, very nicely available thanks to the CCL Behringer company, along with the Indian company at Bangalore, bringing out the concentrates to be marketed this summer itself. I have seen the products in Bangalore and I'm very impressed by them. A10 extem less than 40 or A10 fiptum less than 10. It's a hypofibrinogemia. Give cryoprecipitate without any adherence. If still not so, then you give platelets. If still not so, the CT extem remains very high, more than 80 seconds. last should be FFP, because as I just said at the beginning, the more you give FFP, the more you need to give PRBCs. If there's still ongoing bleeding, recheck, rule out hypothermia, rule out other causes of bleeding, and see whether it's a surgical bleed or not. So we also brought about our cyanotic baby algorithms, and this paved the way from 2017 to present date with 4 algorithms nicely patented with us from AIMS on cyanotic cardiac surgery. And we saw something similar in our algorithms, but at that time we copied and we learned from Dr. Claus. They had not come up with theirs, but we did ours on 450 patients and we reached here. While we were doing this and we were seeing in an evidence-based situation, we were first ruling out clot firmness. But no, from Weber's and Claus studies on multiple things, we saw that bleeding, CT stem more than 250, and in heptim and intim, you should keep seeing the CT there. So therefore, only 2 channels can be run. You could save costs in this case. Well, the low fibrin MCF of Rotem at 10 minutes after protamine indicated low fibrinogen concentrate in this study by Yamamoto et al. And they said a prolonged ACT after heparin neutralization 1:1 protamine does not necessarily indicate residual heparin, but also indicates low concentrations of all the factors. And this patient could go into a consumptive coagulopathy or DIC kind of a picture. So therefore, when your extem is less and your fibrin is less, give fibrinogen. And this is the chart to calculate your fibrinogen dose. If I want to reach 8 millimeters or 12 millimeters, I would have to give 75 milligrams per kg body weight of the fibrinogen dose, and I can calculate it. So bleeding and extem less than 30 and A5 fibrin less than 9, administer fibrinogen. And this is what this chart shows. I'll move on to some examples. This was a platelet function thing, and this is the algorithm I would like to show. That when you have, this was when we started to do platelet function in 2019, just before COVID, we started to use Aratem, ADP-TEM, and TRAP-TEM, and I'll show you in a couple of examples how we used it. This is what we've just formed, our algorithm from AIMS, that Rotem is very accurate a tool. Administration of fibrinogen optimizes, but should not be routinely given as prophylaxis. Protamine should be used first in 1:1 and then in 0.8:1. You can give more protamine than heparin, unlike what we believe for. And in an era when everyone wants to control bleeding with recombinant factor 7A, which was very nicely marketed by the company, one should be very cautious. It should only be considered in cases of uncontrolled bleeding as a last resort with no therapeutic options remaining when you've done all other options. So that is the place. And this is something that we formulated from our studies on TEG as well as on Rotem. Rule out first the residual heparin. For that, you keep seeing the intim CT is more and the heptim intim ratio is less than 0.9. This is the normal. If this is so and this is abnormal, then check with TEG. If you have TEG, we have both, so we cross-check. When you check with TEG, then you can see the TEG, the rapid TEG more than 1.25 times, you give first protamine. If still you have to restore the platelets, then you see the fibrin as well as the extem and atem. You see the MA in TEG, and you give platelet, and this is the role for desmopressin. We use vasopressin at our center, 0.3 milligrams per kg. If still the platelets are not given, restore the fibrinogen by seeing these parameters, as I told you before, by a cryoprecipitate or a fibrinogen concentrate. Replace individual factors like 1 Willebrand factor, factor 12, factor 13. These could be in a consumptive coagulopathy state. And for this, you can just see the R time more than 12 minutes. Give FFP or PCC at this time. Restore the fibrinolysis by giving and ruling out hyperfibrinolysis. When a lysis 30 is more than 7.5%, or maximum lysis on Rotem is more than 15% at 60 minutes, in 1 hour, you can give your tranexamic acid high dose, 15 to 25 milligram per kg body weight, or an ECA of 1 gram before, after bypass. So patient blood management, the Indian scenario in 2021 was an editorial that came up, and we involved the 3 pillars of PBM, saying that preoperatively, if you can see the anemia, rule out the anemia and give to your cardiac patients coming for a redo. an erythropoietin and maintain the anemia with good iron levels, then this patient does well. And anticoagulation in ECMO with anticoagulants and monitoring methods of point of care rules the roost today. And the new dynamic parameters of doing sound intensity or by doing optical studies of adherence on scatter diagrams or fluorescence studies or electrical myography studies are all on real-time dynamic parameters in the market available today. But seeing factor 10A inhibitors come up like danaparoid and fondaparinux, seeing the oral anticoagulants come up like your zimalagatrans and dabigatrans, and seeing direct thrombin inhibitors come up in a very, very big way to as a marked thing. You have DTIs like bivalirudin and argatroban available. We use argatroban a lot as group 2B, 3A inhibitors in the cath lab. It's important that we see and we rule out from our patient statistics. If I have time, I'll do these couple of examples and then end. Patient's vital statistics when on VA ECMO, and the patient continues to bleed. This was a post-arterial switch operation. A small child, 3-year-old, less than 3-year-old, about 5 kg, bleeding more than 3 liters in cardiac tamponade over 8 hours. This was my FIPTEM, right? And my platelet function TEM of TRAPTEM and ADP TEM showed a good area under the curve with a good slope. But here you can see in XTEM and FIPTEM, and these were the 4 channels that I ran with my on my rotum. And I saw that this is less of XTEM, less of FIPTEM. So without doubt, this is hypofibrinogenemia. Give to your patient, your platelet functions are normal. Give to your patient a good 50 milligrams total per kg body weight. And we gave 2.5, which is 4 grams per 80 kg, 2.5 of the fibrinogen concentrate. We didn't have it then, so I gave 4 units of cryoprecipitate, and this is what I got. Another patient showed hyperfibrinolysis. This was a patient post-Bental. Here you can see the platelet function area under the curve is less on ATP TEM. This patient was on antiplatelet drugs earlier. The FIPTEM is less, and there is hypofibrinolysis. The lysis coming on very, very fast. Low cardiac output, patient unable to sustain pressures, and also a flat output there. Needing a lot of volume. So increase ml in both XTEM as well as FIPTEM. The case of hyperfibrinolysis, give high dose, 25 milligram per kg, single bolus, tranexamic acid, and we saw the patient doing well. Another patient post-Bental continued to ooze, prolonged CT here. EPTEM CT close to normal, better than INTEM. Flat line in the platelet function test. There's no area under the curve here. Heparin effect seems to continue. Well, this is a patient who has very, very low platelets and dysfunctional platelets. Therefore, prolonged CT is heparin influence. Give protamine. And therefore, when you give protamine in high doses up to 1:1.5 we gave, the bleeding was due to residual heparin, and this was what we got after giving protamine itself. So important A5 markers are there. After giving platelet concentrates in this patient, our patient improved. I could go on and on. I have many such presentations, but I want to say in heparin resistance, antithrombin 3 and anti-10A assays, which I would request my hematologist friends and transfusion friends to bring up in a big, big way. We are not having anti-10A being done in many laboratories. It's even difficult to do the same at AIIMS on a routine basis. So when you have these patients with decrease, especially children, where we are giving heparin and antithrombin is less, then to detect heparin resistance, ROTEM is an accurate and rapid tool for analysis of the coagulation pathways. There is a qualitative and quantitative platelet dysfunction on CPB and on ECMO, and platelet aggregometry, we said, is a very good tool. And in our study, we found ROTEM parameters, CT, XTEM, INTEM, as well as MCF and FIPTEM to be very, very good factors, particularly FIPTEM. Now, on 72 VA ECMO patients without anticoagulation, there was no absent anticoagulation during VA ECMO support. Of our 450 series, we've not given heparin to about 72 patients in the last 4 hours. And therefore, death due to a large dose of heparin on VA ECMO had higher mortality, pump failure, oxygenator failure, and thrombotic complications. And we saw this in our post-COVID-19 patients. Therefore, we are in an era of heparin-free ECMO, but not for VV, but for VA, or a decreased heparin dosage for VV ECMO. And therefore, that is something that should be a cornerstone to take home. Heparin with antithrombin 3 is the cornerstone of anticoagulation. Classical tests may not be accurate enough for heparin effect monitoring on CPB and ECMO. Point of care tests may probably lead to better anticoagulation management, and urgent need conducted research is the need of the hour with their right interpretation in experienced hands during all these time. We do from TSS very honorary fellowships for our AIMS students on ECHO, on ECMO, on cardiodiabetes and cardiac nutrition and patient blood management. This was a recent book which we just released on 24th, just a month back on 24 Jan itself in the boardroom of AIMS. And while we are researching and we are writing our books, it's a pleasure to be with the intensivists and the transfusion medicine people. I would love to write and read and write and learn more from all of you. These are some of the books we've written on ECMO and cardiac critical care in recent times. And these books with various societies, having a small society of our own at AIMS, we are not for benefit, we are just for academia and research. Therefore, I urge all the students, you have a platform where you have point of care tests available in plenty. Ask your leaders and your administrators to give it to you so that in your hands, we'll be able to move into another era of patient blood management, which is dynamic, which is real time, and which gives answers much faster than what we thought in our learning curve when we were coming up. So that's the journal, and those are some books written on cardiac critical care. Thank you all. So I think I have one more talk. Questions at the end? Yeah.
Now we are inviting Dr. B. Abhishek and Dr. Mukul Agarwal. I think they're going to have a debate. Restrictive versus liberal transfusion. So, Dr. B. Abhishek. He's an additional professor in Jipmer, Puducherry, and his career highlights are he was the Young Scientist Award of 2019 and the H.D. Shawley Award of ISBTI in 2021. Welcome. And Dr. Mukul Agarwal, Associate Professor of Clinical Hematology, Department of Hematology, AIMS. He's the Associate Editor of ISBHPT, Section Editor of Hematology of Indian Pediatrics, Hematology expert with NADA and APMU Tokyo, and has received the ESH Travel Grant in 2015 and 2024. So we are looking forward to a very interesting debate from both of you. There are some conditions where people liberal, so one of you has a chance. The other is in a strong wicket with the patient blood management.
Thank you, organizers, for this opportunity. So, as it's a debate. So, why restrictive transfusion policy at all? If you see at the word restrictive or restriction, it's a Latin word which means to bind or confine somebody. And we all know that when COVID restrictions were there, nobody liked it, isn't it? But much before this, we transfusionists or blood bankers were disliked due to the restrictions that we imposed on the physicians and the surgeons and the anesthesiologists for a totally different reason. So, what is restriction transfusion policy? It's basically an evidence-based policies made so as to harness the physiological reserve that we talk about in the PBM pillars, so as to keep the allogenic blood transfusion to the minimum, thereby also making sure that the patient does not suffer in that effort towards the restriction. So we'll just see how these things came and what is the evidence behind what various people talk about as the restrictive policy. So first of all, the thing that I was talking about, physiological reserve harnessing, of course, the preclinical, most of these studies on the liberal or the restrictive, it's very difficult to do a randomized study in humans because of lot of various ethical issues and other things. So few of the studies, the preclinical ones, gives us an idea as what is the minimum HB that is tolerable. And this particular study actually came from, it was done on baboons, where they saw what is the minimum HB that can they can adapt to or live with without getting into cardiac compromise and other things. So what they saw is whenever the HP was less than 3 gram percentage, there was lactate production, depressed ventricular function, and ultimately led to death. But it was when between 3 to 5 grams, there was ischemia, but however, it was still tolerable. And when it was about or around 5 gram percent, they saw that it was absolutely tolerable in these baboons with a hemodilution effect. So then, after this clinical, there came the human studies. This is one which came in Lancet. The effect of anemia and cardiovascular disease on surgical mortality and morbidity. So if you can see here, it was a huge study done on 1,958 patients, and this is the preoperative hemoglobin. So once you see beyond a hemoglobin of 9.5 or so, there is no much difference in the there is not much difference with cardiovascular disease morbidity or mortality. That means to say the difference almost nullifies beyond HB of 9.5, and the adjusted odd ratio is almost similar. So that gives us an idea that probably beyond say 9 or 9.5, there is no much difference how we use the HB as a preoperative marker for transfusion. So this is another one which an update on mortality and morbidity in patients with very low postoperative hemoglobin, basically who declined to blood transfusion. We heard about people talking about Jehovah's Witness, and these were actually the guys who gave a certainty or an ample opportunity to actually go into this aspect and dig out the evidence. Okay, so what they did is, you can again note here that between 7 and 8 gram percentage, the mortality was very low. It was around 0.9%. So if you can see here, once the lowest post-operative HB level beyond 6 or so, the probability of survival almost merged together. There is no difference at all to see over there. So the important clinical effects are detected with hemoglobins between 5 to 7. And beyond that, there is hardly much to choose them between them. And they also concluded by saying, even reiterating what Chowdhury sir was telling, anemia is a marker of underlying disease and it should not be used as a marker or a proponent for transfusion itself. So whenever somebody is having an anemia, probably they have some other conditions which needs to be evaluated properly and treated, and that would be more helpful in the survival or whatever the morbidity and reducing them in these patients. Okay, so this is another Cochrane database of systematic reviews, which was on transfusion thresholds for guiding red cell transfusion. So here they noticed that in most of the studies, the restrictive is around 7 and the liberal is around 9, though there are little variations based on the patient group they are using. And what they saw here is the restriction group actually received 41% lesser transfusions and 1.21 fewer units than the group in the liberal transfusion. And the 30-day mortality relative risk was 0.99, that is almost I equivalent to 1. That means to say at the 30-day, the mortality relative risk between these two was almost nil. It did not exist at all. So what they concluded by saying hemoglobin concentration may not be the most informative marker of the need for transfusion in individuals with patients with degrees of physiological adaptation to anemia. Overall findings provided a good evidence that transfusion with allogenic RBCs can be avoided in most patients with hemoglobin threshold between the range 7 and 8. So what is the problem? So they also said that the risk of the adverse events, both the infectious and non-infectious, has a lot of impact in transfusion. We all know that. And when we talk about the non-infectious, we have the ones with very high mortality like the trallies and the tacos. And of course, the infectious, the silent killer, which takes time, but of course, it poses a huge burden on the healthcare economy. And of course, the limited supply of the rare commodity, except few countries in the world which boast of surplus, most of the countries are suffering from the deficit of blood units. Even in India, it's proposed that more than 30 million units are deficit every year. So this is another systematic review where they compared the restrictive versus liberal transfusion, and the results show that the restrictive is these are non-inferiority trials just to show that by maintaining a HB lower than the other one, this is actually from the, okay, it was done in the deaths and the occurrence of sepsis was compared in the groups between the liberal and the restrictive groups. This is another study, a huge one, included about 6,630 participants, and they found that there was no difference in the overall mortality between the restrictive and the liberal transfusion group. And even the secondary outcomes, including the reinfarction, stroke, the acute heart failure, did not differ significantly between the groups. This is the major cardiac event, the MACE study, with the study at 30 days, which included 26 centers in France and 9 centers in Spain. So 668 patients aged more than 18 years, with a median age of 77 years, with 58% being men, and 13% of them had active bleeding. What they saw was in the restrictive versus liberal group, all-cause death occurred in 5.6 versus 7.7% of the patient. And the recurrent myocardial infarction occurred in 2.1 versus 3.1%. And emergency revascularization prompted by ischemia occurred in 1.5%, whereas it was 1.9% in the liberal group. And the non-fatal ischemic stroke occurred in up to 0.6%. So this is the one study which, that's why when we talk about restrictive versus the liberal, we all tell the exception as the patients with the cardiac ailments. And this is the big, the one of the most cited study, which is called the TRIC trial, the transfusion requirements in critical care investigations. They included about 838 critically ill patients who were volume resuscitated. The restrictive strategy, they transfused whenever the patient went below 7 grams and maintained it about 7 to 9 grams. And in the liberal strategy, they transfused at HB when they fall below 10, and they maintained it between 10 to 12 grams. So the results were amazing. In acutely ill patients, the mortality actually reduced almost to half of the one in the liberal group. And in patients who were less than 55 years old, still the mortality was 5.7% in contrast to about 13% in the liberal groups. And also they noticed that restrictive strategy on an average used only 2.6 units of blood, whereas those in the liberal strategy used 5.6. That is almost double the consumption of what in the other group. They compare overall mortality on day 30. And among patients with clinically significant cardiac disease, of course, the difference actually almost came closer. It was still the difference of around 1.5% there. And this is another study which is called the TWIST study, which was done in transfusion threshold in septic shock patients. And here they included around 998 patients. Again, the same strategy was used. And here the primary outcome was measured by death on day 90. And this was a randomized trial. And 43% of them were assigned to the lower threshold, and 45% were assigned to the higher threshold. They noticed, what they noticed is 43% those assigned to lower threshold had died, whereas 45% in the higher threshold had died. So this said that, again, even in patients who have sepsis, almost the difference blurred out between the liberal and the restrictive transfusion. Then coming to the studies on cardiac patients, this is again, these are all non-inferiority trial basically done to show that even at liberal or even at the restrictive strategy, there was no inferiority in the outcomes that were seen. This is one large study done on 5,243 patients, and this is called the Titer 2 trial done on 2,007 patients. The results are almost similar. I will not go into details. And this is one study which was done, what is called the reality randomized control trial. This was exclusively done on patients with acute MI. And again, that was a non-inferiority trial which showed that there is no much difference. And in the other study, again, they included about 3,500 patients, and they showed that the mortality was slightly higher, 16.9% compared to 14.5%. Then coming to the oncology patients, whether this holds good to oncology patients as well. Not many trials are there. This is one trial I could get, like liberal versus restrictive in patients with hematopoietic cell transplantation, and they also noted with the same strategy, there was no significant difference in the clinical outcome between the strategy 7 gram percentage or the 9 gram percentage. Then there are also papers on orthopedic study, lot of large patient size where they compared 8 gram percent versus 10 gram percent. Here also they showed that there is no much difference to choose, but they also said with caution that in especially patients with cardiac disease more than 65%, 65 years of age, you should be cautious and maintain a slightly higher level. Then do we have data in pediatrics and neonates, or does this hold good only to the adult patients? This is what is called as the PICU investigators from the Canadian Critical Care Trial Group. They did the study in pediatric patients, and the same, they used 7 gram percent versus 9.5 grams, and they noticed that 12% in each group had the multiple organ dysfunction, which they studied as the primary outcome. And in another trial done in African country, they transfused patients either with a 20 ml per kg or a 30 ml per kg transfusion in those who had less than 6 gram percent of HB. And they showed that the hazard ratio was 0.43 versus 1.91. They meant to say that in this study from African population, people who were transfused at 20 ml per kg had a higher survivability compared to those transfused at 30 ml per kg. And this was actually, the problem here was this way in patients who had malaria. Malaria is very severe in African countries. And that's why they said, in the patients who had fever, the ones who were transfused less actually survived better. So to conclude, the restrictive will minimize the use, minimize the risk, reduce the cost. People talked about cost in the morning. This is one paper, at least 5 years, more than 5 years old. It depicted that the annual unit cost of each component somewhere around 2,000 rupees. And 5 years later, it should be much more than that. And this is one from the US. They have a lot of different charging policies, whether it is government, local, and so like that. And you can see the charge of 1 unit as can be high as 20,000 USD. And when we talk about costing in blood bank, we should also not just the blood unit, we'll have to take into account the equipment, the salaries of the personnel who are there, the consumable that you use, and these are the costs that have been depicted in various studies. So to end, I would say blood transfusion is like marriage. It should not be entered upon lightly, unadvisedly, or wantonly, or more often than is not, is absolutely necessary. So we all know that nobody likes restriction, isn't it? We all like to be, that's why the word liberal comes from the word which means free. You are free to do whatever you want. So whenever we talk about restriction as transfusion physician, the usual department, the first question they ask is, do you have or you don't have? Should I send you more donors? Why don't you do more camps? These are the type of questions. We should make them understand. And also we should understand that not it is not the job is our job doesn't become difficult by organizing more camps. It is we have to put more effort to implement restrictive strategy rather than the liberal strategy. Thank you.
So thank you, organizers, for giving me this opportunity for the liberal debate. So one of the things which the user department also say, I will send second form tomorrow. Doesn't matter. आज आप भेज दो, कल मैं दूसरा भेज देंगे. So this is very common to occur. So debates are meant to be light-hearted for the audience, but ruthless for the opponent. I'll go with that persona only. My topic is to defend on liberal. Since I am speaking second, I have the opportunity to rebut some of his points therein. So there was a lot of stress on the word mortality. We have to understand morbidity comes before mortality, quality of life comes before mortality. This is something which I will highlight. Another thing which was very commonly said was non-inferior. So when we say non-inferior, we already are somehow committing to the gold standard, which is liberal. Things is non-inferior. Thing is non-inferior, none of the trials is on a superiority thing. Okay, so third thing, I'm an avid reviewer, so my job is easier nowadays. So whichever trial, many trials of our slides are common. In that regard, my job was easier to find flaws in those trials. And yes, there were plenty. We'll see subsequently. At the outset, I'd like to say that yes, I am underdog speaking on liberal transfusion in a PBM meeting, and myself being a proponent of it has been said that anemia is a symptom. Everyone agrees. Please do not transfuse blood before making a diagnosis. No doubts on that. Even if the patient comes with hemoglobin of 4 or 5, investigate, then transfuse. There's no doubt on that. But what to do after the patient has been diagnosed? Should you be just restricting transfusion in a patient for the sake of that hemoglobin only? No, perhaps no. I'd like to prove my point with many of the subsequent slides. Like this patients, two patients, aplastic anemia patients and leukemia patients. So I'm a hematologist, so there were a lot of questions, slides on hematology will like patients only. Cardiac, we have both agreed that cardiac patients do not require restricted transfusion. So I'll just, for the sake of completion, I'll skip on few of the slides on restricted transfusion, liberal transfusion in cardiac patients, after highlighting my points in those slides as well. So this patient, aplastic anemia patient, we know they have a miserable life, unfortunately. Or a leukemia patient who has been started on induction chemotherapy. On third or fourth day of chemotherapy, both of them have a hemoglobin of 5 or 6. What would you advise for these patients? Restrictive? I sent a demand for 3 units for the aplastic anemia patients. Let him be transfused with 6 hemoglobin with 3 units. Let him go home maybe with a hemoglobin of around 9 or 10. He will come back after around a month. And for the second patient of leukemia, he is third day into his chemotherapy. I know I'm expecting a myelosuppression for next around 3 weeks. I again advise for 3 unit transfusions. Hopefully, he will require transfusion after 4 days or 5 days. But unfortunately, what happens is blood bank just says ek hi milega. Anyone who supports me in this from the audience?
Yes.
Yes. Not with aplastic. He will come next day again with same hemoglobin, yeah. Anyways, so there are some proponents. Okay. So just skip on this. No, actually, most of the blood bank departments are very screwed to people, measly clinicians like us, and not so much to ma'am. And we also have a very good support. It's just pulling legs, nothing else. For the layout, this is the brief layout. As it's been said that when did this originate? When does this idea came into being? When was this inception done? So inception came from Jehovah Witnesses when again target 10, liberal target, they wanted to lower it. The idea came that these patients were able to survive a lower target very easily, very comfortably. Problems were occurring at a hemoglobin of around 4. But actually even the proponents of very restricted transfusion do not advise to go up to this level. Okay, so we don't want 4 to happen. But yes, this was where the problem, I should not say the problem, this was where the proponents of restricted transfusion started. This is about various case studies, scenarios, GI bleeding scenario. I just want to say that even though not significant, the curves for liberal transfusion are consistently higher than the restrictive ones, and a lot more procedures can be performed in patient with liberal transfusions, though the differences are not significant. Similar study in the burns, not much significant. Only thing was that RBC transfusions were more in the liberal group, which is expected kind of. But just look at this thing. Look at this thing. So patients on ventilator, length of stay, they were significantly more in the liberal group, and still the morbidity and the other outcomes were similar in both the groups. CBD, Dr. Abhishek has already agreed that this is one area where liberal transfusions are preferred over restrictive ones. Just goes on to highlight that certain patients, especially those with the percutaneous procedures, they have better outcomes. With the liberal transfusions, again liberal better, liberal better, liberal better. The last one is okay because that is for non-cardiac indications. This is interesting. Elderly patients undergoing cardiac surgery, the incidence of cardiac shock is lower in restricted transfusions, especially in patients who are more than 60 years old. So liberal transfusions are better in these patients. Mortality, one of the studies I could easily found, 90 days mortality, lower with restrictive transfusions. Sorry, lower with liberal transfusions. More proponents of liberal. Across the group in this NEGM article, the outcomes were better in the liberal transfusion group. Orthopedicians say that the proponents of liberal restricted transfusion included only frail patient. Transfusion data was incompletely reported. Threshold was 8. Baseline transfusion policy varied, and significantly more cardiovascular events and mortality occurred in the restrictive group. And infections other than pneumonia were not reported as per this meta-analysis in the orthopedic journal. What about pediatrics? PIN study, one of the earliest studies that shows that liberal RBC transfusions were beneficial to neurocognitive outcomes of premature infants at 18 to 12 months. Although subsequent studies were not so supportive of this. But even in US, the transfusion practices are not that uniform. This study just showed that 60% of centers, they were following a 8-gram cutoff and 25% were following 7-gram. What rest 15% was following is not known, probably a more higher cutoff than 8. Definitely not less than 7, which is kind of impractical only. Hematology patient, so non-inferior with respect to quality of life. Same, this has been already highlighted. Just look at the non-compliance in the restrictive arm, 12% versus 7%. This is interesting. When we see that the number of RBC transfusions were less in the restrictive arm, but the quality of life was uniformly better with the liberal arm. The fatigue was better in the liberal arm. This study has been already highlighted by Sir. I just want to point out to this thing that, the transfusion trigger non-adherence was seen in around 76 cases out of 224 in the restrictive category. Again, transfusion occurred above the assigned category in around 25% of the patients. So, when we are seeing these trials, we have to understand the nuances, certain things which are going behind the scene in these trials, that non-adherence is significant problem. Certain RCTs, I've not purposely not highlighted the ones with no difference. Just one last one. Per protocol, 30-day mortality was higher in the restrictive group. Again, restricted transfusion reduced the requirement during the ICU stay, but the composite endpoint of major complication of mortality was nearly twice, I again say nearly twice as common in patient managed with the restrictive approach. So, interesting things. This is surgical oncology patients, okay? Some established facts. Thalassemia, we all agree that the cutoff is not 7. It is pre-transfusion cutoff is above 9. So you are maintaining, there's no kind of restriction over here. In fact, if the patient has hemoglobin of 7 and 2, can you start regular transfusions for such patients? This is interesting aspect, although debatable, but this has been published that higher hematocrit is associated with lower bleeding rates in patients with low platelet counts. Some kind of mechanisms which occur with the laminar flow in the blood and better platelet and endothelial interactions, which lead to lesser bleeding episodes greater than 2A and greater than 3A. So with greater than 2A, the odds ratio is around 1. For grade 3 bleeding, the odds ratio is around 4. Things are happening. And this is very interesting. Most of the guidelines for restricted transfusions, they are likely to be deviated around 2 days before the discharge. That's the usual department which we do. Discharge se pehle patient ka hemoglobin, make it around 8, 9, 10, whatever you want. There are protocol deviations which are happening. And this is not only my practice, this has been published in European Journal of Anesthesiology as well, that these guidelines are more commonly deviated in the last 2 days. Whatever you're doing for the first maybe 10 days, 15 days, but during the last days, these kind of variations, they tend to happen. Anyways, we have said enough about RBCs. What about platelets? So for platelets, we all agree that higher trigger is beneficial. More than 10,000 is beneficial for most of the patients. This is my last slide. So there are different cutoffs for restricted transfusions. 6, no, 7, 7.5, even 8. Different disorders and so many exceptions. We saw there are high rates of non-adherence across the studies. There's a lot of selection bias in the trials, which even the authors of the trials have agreed upon. Differences in the surgical versus medical patients. Physician call versus availability versus real world issues, like in the case which I asked, which I told about earlier, like that aplastic anemia patients whom I can send home for around 3 to 4 weeks with around 3 units of transfusion preferably. But if I give him only 1 unit transfusion, he will be coming back again 3 to 4 days. Obviously, we are saving lots of RBCs with restricted transfusion. I totally agree with that. But that should not always be at cost of morbidity and mortality in certain situations. Just remember that most of these are non-inferior studies as compared to the liberal ones. I think I'm on time and I invite Dr. Abhishek for a bit.
So, few points that Dr. Agarwal made. One was why all the studies describe only mortality and morbidity, nothing about the quality of life. We all know that when we talk about research, we talk about hard outcomes, soft outcomes. Hard outcomes are something like organ dysfunction, morbidity, or mortality, and soft outcomes like length of hospital stay and quality of life and all this. But when do we go for soft outcomes? When we are not able to assess a hard outcome, either it is ethically not correct to do that, or we have no way to do that. Okay, it is soft outcomes are basically, we all know that when we talk about targets, when do we achieve soft targets? When we can't achieve the hard targets. So here, when we have the targets, morbidity and mortality, maybe we should not think about the soft target, is what I say. The second one, sir said about the.
She wants to revert.
Any morbidity it's all morbidity.
No, there are morbidity also. Organ dysfunction and all that is morbidity. Yes, yes, yes.
But it's not high.
Usually, it's not there. It's not there in my presentation.
It's not there in his presentation.
And the second one.
Really nicely presented all the trials is it really that somewhere it is 7 and then it is 9?
Yeah, so when we talk about liberal and restrictive, don't be under the impression most of the studies are done on 7 and 9, but it is not like that. For cardiac patient, there are studies which have described restrictive as 10.5 and liberal as 12.5. So it's for each condition. Yes. Yes. There is no hard and fast that all liberal is no, no, no. Please don't go away with that message that every liberal strategy is this and no. It has to be patient specific, the group specific. And other points I was making is about aplastic anemia. He also showed that enhanced trial, but I want to tell that this enhanced trial, I think it is just published ahead of publication in Transfusion. And this is just a pilot that they have published, that trial. And it's a huge trial. Maybe we will have maybe another 2 years or something to have a complete data. And with now the focus is on MDS, but I do think it is entirely on hematological disorders. So we should have patients on aplastic and other dual things like leukemia with MDS or something like that. So we can wait for that to see really these hematological patients differ in a big way from the other patients. The other one is said about point that is in premature. In fact, of course, the rider I did not put that. Premature again. When you say pediatrics, whole pediatric is not one population. Like in how we adults, we have patients with cardiac disability, we have one with hematological disorder. In the same way, in pediatric, there are premature is a totally different group. So we should not go with that. Okay, this holds good for everyone.
Discussing on pediatrics. So there were a few things that I actually wanted to comment on the way you defended your point.
Abhi, let us rebut each other. We'll come to the audience. Just wait.
Yes, sir, please.
Sir, thanks for giving so many exceptions to the restricted transferring yourself. I just go on to highlight something more. I've kept these things for a later thing. So liberal transfusions compared with restrictive improved survival in perioperative patients. The restrictive transfusion could decrease the quality of life, fatigue score. No,
he agreed.
This is interesting, So all the trials which we see the number of eligible patients and those who actually participated. This is here on the rightmost part, 40%, 50%, meager 12%. There is so much selection bias which happens in some of the trials.
So that is symptomatic cardiac disease. So they gave up the trial.
Maybe. What about other 5? This again. So various outcomes. They show that restrictive is not inferior, but there is imprecision, inconsistency, so many things which go on. At the end of the day, we should remember that my ward, my patient, my rules. No one is transfusing for chronic anemias. We all understand that. We need to treat the underlying cause. But for acute anemias, problems are different. There is heterogeneity of patients. Comorbidities are the major one of them. And obviously the underlying disorder is again vague approach of clinical judgment versus elevating symptoms. It's kind of very often practiced, essential also. This is something which is being decided in the ward. Unfortunately, not in the blood bank at present. You may kill me after this, sorry. You may treat the patient and or treat the lab number, but this is something which is to be left to the treating physician. Yes, if you have more science, educate us, make us believe in that science. Till that time, please let us treat. There are real problems which occur, like that in the aplastic anemia patients, which happen. I think, yeah, this is my favorite slide. Yes, liberal transfusion is going to be designated survivor. Now, many of us know. So, you're not always wrong, if you're doing the things liberally. Thanks. Now open for questions.
Yes, so it's not actually a question. First of all, I think everybody should clap for both the batsmen. They played so well. And I think it's very difficult to select the man of the match for the match which was played. So there were just 2 points which I wanted to highlight as far as pediatrics is concerned, because I'm managing a blood center in a standalone government pediatric center at Noida. And we started this blood center 5 years back. The hospital is 5, 6 years old. And a small blood center with a very limited stock of inventory with us. We always had a tussle with our clinicians. And when people ask me, what do you do different in a pediatric transfusion setup? So I say, I treat my pediatrician and neonatologist first and then the patient, because I need to connect my clinician, and pediatricians and neonatologists are often a very difficult batch of clinicians to convince, because they want to treat their kid the way they want to treat it. So
trust me, all of us are like that.
yes, yes. And that makes the match more interesting. So another thing was, as far as the restrictive one was concerned, Dr. Agarwal convinced that in pediatrics, the data which came out of the PINE trial, which you told, that was published in 2009. That trial laid actually a foundation that does going restrictive, did a neuro damage to those children. Following that trial, there were 2 parallel trials which were done in US and Europe. There were top trials and ECMO trials, and they enrolled more than 2,200 newborns over a period of 10 years. And, dividing them into restrictive versus liberal, followed them up for next 2 hours after birth. And not only the oxygen level, not only the hemoglobin level, even the oxygen level was the criteria to decide restrictive versus liberal. And they found out that there was no significant आ रहा है, उसके फादर का एक दिन का the earning has to be adjusted. So उसको 2 यूनिट दे दो, शायद 20 दिन में, 25 दिन में, 30 दिन में आ जाएगा. तो yes, feasibility is something I completely agree with you, that we as doctors, as clinicians, as healthcare providers need to look at in our patient profile, that what is the feasibility around. And I think the defense that you gave, one of the most convincing thing was the feasibility. So it's the feasibility and it's the comfort level of the clinician and the patient that he's treating. He's probably making his decision based on that and less based on science. But still, a commendable job for both of you. Thank you.
So great job. and quite enjoyed the debate because you brought about very pertinent points and very recent literature on the same. But just as a cardiac anesthesiologist seeing patients in the intra-op, pre-op, as well as post-op, we have moved. We have moved from liberal to restricted. And believe me, if you see our profile in the last 7-8 months, particularly, we do not ask for any blood. We do say 4 units of blood for an ASD. Maybe the child is hemoglobin less and we need that blood for our blood prime in the pump, but we may use 1 or 2. But unlike what we were doing earlier, even giving to a atrial septal defect, which is a surgery within 1 hour, 2 units of blood and 1 unit of PC and 1 unit of FFP, which was the norm. I think we were thinking, I want a good post-op hemoglobin. I want to come up on 10, 12 plus. Right? And you rightly said that was happiness for the intensivist, for the surgeon, and everyone to go home with thinking my patient is not going to need blood in the post-op unless or until he or she is tamponading. Now, if you see today, we don't use and ask for any plasma, any FFP, any PC, anywhere. The only thing that we've started to ask for is more of cryo. I think people in the Cardiac Blood Bank of AIIMS would agree. More of cryo use has come up in recent times, and I'm sure with the coming up of the concentrates, this era of 2 to 3 years, we would be with our European counterparts in using more concentrates and deciding what would be the, at least I'm talking for cardiac surgery, right? I'm not talking for ortho or anything else, but us being a tertiary care center with more pediatric cardiac surgery, 80% of it is pediatric, we see the babies need less. And wherever the cross-clamp times and the bypass times are faster, better, within the hands of more experienced surgeons, the oozing, the cardiac output is very, very good, needing less restricted transfusion. But the Indian mindset will take time. We would be in an era of liberal transfusion for all our redos, for all our redos, because they are coming up in plenty too. So blood cannot, I mean, blood is a drug you need most inside the OR, inside the ICU, and blood banks are going to be needed. So I think this fight between liberal versus restricted, to my mind, would be feasibility. You pointed it out very well. Would be availability. I post-pandemic do have an apprehension we would not have too much of blood in the, maybe we are a populous nation, we will have blood, but the right kind of blood in the right kind of hands would not be there with us in the years to come. So use it judiciously, go towards a restricted thing. Economy teaches us anything that is within bounds is always going to not overflow. That's all.
Ma'am, I kind of agree with you in all these aspects that it's more of a feasibility and availability kind of a thing. And when we say that, only 1 unit can be given, that should also not be a criteria. It should be in discussion with the patient condition. So that is essential because, for us, it is easier as a faculty to say that you can fill the form tomorrow again. But that should not happen, that if the patient is requiring transfusions on a daily basis for 3 days, that should not also be happening. Per se, I come to the rider that even in my unit, the transfusion threshold which we maintain is around 8 only. It's not 9 or 10. So, and if the patient counts are recovering or if he is recovering from the myelosuppression, we avoid transfusion at that point of time. So that is something which we have also come up over last few years now.
Pre-op optimization of the patient with a pillar in an Indian population, that should be very nicely worked on. Preventive medicine, how to prevent anemia, how to correct it. Surgeons are in a hurry to want to take the patient. In our center, everyone would agree, those who are from AIIMS, cardiac, sitting here, the patient comes at 2:30 in the night, we do the PAC, and the patient's taken up at 8 in the morning. Because of the volume that we have here, the waiting list is so big. So when you see that we are not able to pre-optimize the patient's hemoglobin, this patient is going to need more. So if you do the first pillar well, you don't need the third. The third.
Okay, so after a really great debate, I hope both of you convinced each other also. You a little for restrictive and a little more for liberal. And when you say
the transfusionists are not worried about the kitchen of people like you. We are more worried about the kitchens of other people. You are speaking for liberal, but there would be people who are actually going, too liberal. So it is those kitchens that we are worried for. We are actually not worried about your kitchen. Whenever you say we'll give you as much amount of blood that you want. So,
Thanks, ma'am. Point well taken. And
yeah.
our blood bank has been very supportive of us in
Yes,
that
yes.
regard.
Support is one thing. Liberal is another thing. So there are other kitchens that we are very, very worried about. Dr. Meenu, would you like to? One more? That was very interesting. So one thing I think we missed out, or maybe the aluminization part in the liberal transfusion. We cannot, because if we are transfusing in a restrictive strategy and transfusing in a liberal strategy, anyways in liberal strategy, we are aluminizing the patient in some. So when we keep, that patient keeps coming back later, so rather than getting into a problem of then finding the unit, the compatible unit, once is aluminized, it's better we go for restrictive rather than, for liberal to avoid that in future.
Good
So that
point.
was one thing.
Can you give me a cutoff when this aluminization occurs after how many transfusions?
So there is no cutoff. That's basically that's non-inferiority. That's the part that comes there. Even that is the non-inferiority. It doesn't say.
So this is difficult to say. Patient can be aluminized after maybe 3 transfusions and may not be aluminized even after 10 transfusions.
Yeah.
Yes, they can be aluminized.
Yeah.
Yes. The number of transmission does not define it.
And per se, for an ideal condition, we all agree that whenever you're giving transfusion to your patient, especially for those who are likely to be multiply transfusion, you should be doing complete typing for the patient at the outset. That is essential.
Yeah, I think I must congratulate both of you. Done your job very well. Actually, I just wanted to emphasize on the last word which he has said, that don't treat numbers, treat patients. I think that is a very, and don't treat the lab values. You see, you have to treat the patient. And I want to emphasize, besides what he has been showing, that in various trials, the problem is in the today's scientific literature is there are so many systemic reviews, meta-analysis. They are I mean, they don't know, the people who are reviewing them, they actually don't know, they have not seen those patients. So that is the basic fault in these studies. Although they are very well statistically, I mean, there is a difference. We are analyzing these results by statisticians. They are applying so many statistical rules, but actually, if you look into it, into the actual patient care, these rules sometimes don't apply. So I think what we need to do is in specific groups like thalassemia, chronic transfusions, I fully agree, give them 2-3 units, they will come back after a month or so. But like in critical care, when the patient is hospitalized, he can wait in ICU settings, we can bring down triggers and then look at those, his response in those situations. So yeah, I think so. It has to be individualized in patient-specific groups rather than we can generalize these rules. So that was my comment. Thank you very much. I think it was a very nice hearing both of you.
And like you say, you have to treat the patient, not numbers. So we have to look at the patient and also the clinician. So sometimes our policies are clinician-based also.
This is a very personal experience, but the amount of blood used in a transplant, I work in a liver transplant center, is directly dependent on the anesthetist who is looking after the transplant on that particular day, and it varies a lot. That having been said, over the years, the transfusions have definitely come down. Usually, if the post-op hemoglobin is high, there's a higher risk for portal-vein thrombosis in liver transplant patients. So, in the initial transplants, we used to go for a therapeutic phlebotomy. At the end of the transfusion, at the end of the surgery, they used to get the hemoglobin is high, we have to do a phlebotomy. Now, I think for years, we have not done a therapeutic phlebotomy. They have brought down the levels at which they transfuse. And there's a very particular good restrictive transfusion practices now.
Yes, transfusion specialists should have some role in for the restricted versus liberal criteria.
I think Rishma would say that we can give the guidelines. The final decision remains with the person whose kitchen it
We
is.
want to have some.
Things have to be individualized for a patient, for that particular patient on that particular day.
No, but diagnosing
There's so many exceptions.
Diagnosis, see, MDS is one diagnosis, but you have a range of patients whose HB is up to 11.5 till 5. So it's each one is different. So cardiac ailments, additional will be there, all these things. And the most important thing as like we have to respect the physician in that we all know that medicine is not just science. Yes. Medicine has a component of empathy and other things which no AI can replace. Okay. So he knows, for example, he was telling a patient has to come all the way from 300 kilometers. He doesn't have a transfusion facility in 100 odd kilometers from his house. Exactly. He knows that condition. We should be allowing him to make a decision on that patient. We should not just for the sake of number restrict him to go with the policy and other things.
You know, getting an admission, getting a good transfusion is so much essential. Safe transfusion is so much essential. If I'm able to give a safe and good transfusion to my patient and he requires a transfusion after 1 month, that is something which we all should strive for.
So maybe we need to restrict liberally or liberate restrictively.
Educate us more.
Restrictively.
Educate us more. Yes. Has to be a mix of things. Surgeon. Sir, surgeon will be there, शांत नहीं रह सकते.
So, try convincing the surgeon actually. So, thing is that I did my residency from AIMS itself in the Department of Pediatric Surgery. And that time also, we have this figure of 8 that we, even operating a child, doing a major surgery like pyeloplasty or kidney surgery, or maybe even removing a Wilms tumor, we would have this cutoff of 8. And after that, even if anesthetist or anybody says that transfuse blood, we would never do that. And regarding optimizing the patient, there's automatically a thing called waiting list at AIMS. So just get a hemogram done, start the patient on iron, and after 6 months, probably when he comes to, he's fine. So I believe that, and also with time, what has happened that the technology has advanced so much, the amount of blood we are losing right now, the energy devices we have. So the need of really transfusing patients right now has decreased, and we are very confident, and with experience, we are very sure that even with the 8 of hemoglobin, we can take the patient for a major surgery and still come out without much transfusions. So I think we can still limit, like Dr. Mukul also mentioned that he follows a figure of 8, we also do that. And definitely we do get educated, and somebody is too liberal, then you need to sit him also.
That number of 8 has come down from 10, which is in itself is a remarkable
Exactly. It will take some time, and people are very much sensitized regarding that.
So finally, we'll wind up the debate and over to the organizers. So that was a wonderful session. Dr. Poonam ma'am taught us the science and art of viscoelastic test. And after that, we had a neck-to-neck fight between liberal and restrictive. And finally, we came to the conclusion that it should be always patient-centered and tailored for each and every individual patient. So with this, I should say the session was a success. And I request Dr. Geeta Negi ma'am and Meenu Bajpayee ma'am to please come to the dais to felicitate our speakers. I request Dr. Poonam Malhotra Kapoor ma'am to please come out to the dais to receive a token of appreciation from us, ma'am. Thank you, ma'am. Now I request Dr. Abhishek Gowda sir and Dr. Mugul Agarwal sir both together onto the stage. Thank you for a wonderful debate, sir. A small token of appreciation from our side. Thank you, sir. I request chairpersons to please kindly stay on the stage itself. Dr. Richard, sir, please come onto the stage to felicitate the chairpersons. Sir is a medical director of One Blood from Florida and keynote speaker of today's CME. A small token of appreciation from our side, ma'am. Minu, ma'am. Thank you, ma'am. And next to Dr. Geeta, ma'am. Thank you so much, sir. So, we'll proceed to the most awaited session, the panel discussion. And we have a good array of experts with us. And to conduct this, I invite Dr. Hemchandra Pandey, sir, who needs no introduction by now, and in whose hands I know this session will be at its epitome. Over to you, sir.
Thank you, GP. So I would like to call upon the panelist. The first panelist is Dr. Ma'am, Dr. Ma'am. I would like to call the also to the dais for the panel discussion. Dr. Ma'am. I would have a little introduction later. I'll just call them first. Then Dr. Moses and Dr. Satyam. So we have a very diverse group. There are more blood bankers, I think, and obstetrician and pediatric surgeon. So the main aim of this panel discussion, what I would say is we always read about patient blood management in surgical patients or adult patients. We never consider that it can be applied to different populations also, or other patient populations. So we would go through the different situations where this patient blood management might help by their examples. So the first question I would like to ask from ma'am. My name is head of functional medicine from IMS, and the very good point of care testing and so, ma'am, what are the day-to-day challenges in blood availability and safety? Because everything comes down to availability and safety.
Yes.
Yeah. So,
First of all, I just wanted to say that when we are thinking, we should go into the minutes of what we are working on. So when we are working day to day in the blood bank, first comes the safety, and the safety is built by the systems we build. There are many errors which occur, and they are systemic errors. They are part of the system. So whenever an error occurs, and there is a what you call it, a breach in the safety of blood, the first thing is, why did this error occur? And over here, it's very important not to be punitive towards any staff. It's very important to focus on why the error occurred. Why did the staff commit this error? And over time, when we've been working on this, we have improved our systems to a great extent, and the number of errors have decreased. The small steps which we have taken is like the unique identification number, never identify a patient by their name. The other is the barcode system, which has definitely improved the safety at each point. And then how the checking and rechecking will go. Initially, when we started our work, we were giving plasma based on the blood group written by on the requisition form. So once I came to know that we had given away 8 units of FFP of a different group to a patient. Then we had a system set in place where either a blood group report has to be attached to it, or you have to send a sample. Otherwise, we will not issue plasma. Now for the plasma units, we get plasma units from a number of places because our plasma is never complete. We once found that the plasma was written as O, but it was actually A. That second problem, when it occurred, we made another policy that from the tubing, you have to do reverse group of every unit before issuing. So these are small things. So when we are thinking of safety, we have to go back. Every time an error occurs, it should always be a learning opportunity. I don't want to go by the rote and what is written in the books. I'm talking from pure experience that as you go along, you learn, and every error teaches you a lot. So would you like to say something about this?
I mean, I fully agree. I mean, really, it has to do with, having the appropriate doing corrective action and preventive action when these events occur, and it shouldn't be punitive. Fully agree with that.
The other part is the availability. The first is the safety, now the availability. The availability of blood, it is very important that we
making the patient run around for donors. So we should have an adequate amount of blood in the blood bank, and that can only happen when we promote the voluntary blood donation. And if we have a voluntary blood donation program in place, we can tide over the emergency periods, and we can afterwards ask the patient that if you have donors, please come along. You have used a lot of blood in our blood. If it's possible, please do donate. There is no pressure at that point of time, so there is no propensity to take up unsafe practices to get donors. So that is also a safety point, that the patient is already received blood. And if you ask for blood after that, if it is possible, please donate. It's not the patient is already being taken care of. So when we are working in difficult circumstances where camps are not always possible, the amount of blood is not always okay with us. It is I think it's a good practice to ask after the event rather than before. It makes blood, definitely makes blood safe.
So I think what you want to say, ma'am, is that blood transfusion has certain safety related issues, which although we take care and other things, but still there are safety related issues. And there are certain challenges in blood availability also. My clinical counterparts also will agree that blood availability is sometimes a challenge. Certain situations or in general also. And as you rightly said, sometimes you get affected from other institutions. So blood availability always remain a problem. So yes.
So from a student's perspective, although I mentioned that we transfuse very less, but we only give dates to patients once we make them donate blood. For us, it is also a sense of commitment, because if a patient, we won't agree that, you will not believe that many of the parents will deny the child surgery just because you ask them to donate blood. For us, this is again a test that how committed they are. Then only we'll make efforts to accommodate a patient in our OT list if they are ready to donate blood. So the clinicians also are very much sensitized regarding the need of blood. And I feel our department has always been in the green regarding the blood donations.
So these challenges bring us to the question of program. So what we were doing is we were giving to blood rationally. Now we have started saying that you manage the patient at your side and don't ask for me. That is what we are now saying. So I would like to ask Richard that how this rational blood use differs from patient blood management. There are two different terminologies. Earlier we used to say use blood rationally, rational blood use should be there. Now we are saying do patient blood management. So how these two things are different? I think a lot of us are getting confused about these two terminologies.
Well, I mean, there's the rational use of blood, that's evidence based, and then and that's only part of patient blood management. Patient blood management really takes into account other things too. We talked about it. There were some good discussions this morning about cell salvage, acute normovolemic hemodilution, minimizing wastage, making sure that some of these shortages arise because too much blood is used at the hospitals, and so if the hospitals are buying into it, you're getting opportunities, or you're recruiting, bringing in additional donors. That certainly is all part of patient blood management. We just put an article together, and I forgot the name of the journal right off the top of my head, but it tied into patient blood management and blood donors. And the whole idea behind that is that if you don't have enough donors, then you can't do patient blood management. So the two go hand in hand.
Okay, anyone else would like to come?
Just like to add, that is, I think rational use of blood started when we were shifting from whole blood to components. So I think the main aim was to, convince our clinicians and our blood centers that you provide components, and when there is thrombocytopenia, don't give whole blood. When there is anemia, just treat with PRBCs. And I think with the availability of components in this era, now we have moved ahead with the patient blood management, asking them to use it more judicially. So I think that is probably broadly the difference of era from rational use of blood to PBM.
Probably at that time the blood was more scarce. Now that is more available. So I say we have blood, but still you manage the patient. So that
Well, the only thing I will add one additional comment though. There's one group that there's three groups that you can never have enough blood for. O negatives, those with multiple antibodies, and platelets.
So those ones we're always struggling for.
Yeah, yeah. I would like to ask Madam, Dr. Abdul, since Professor Obstetrics and Gynecology, so we have interacted and I think also we are managing one patient for some particular problem. So, ma'am, what are the challenges in obstetrics and gynecology, specifically related to blood transfusion?
So I think I would like to, I can safely say that we have one of the most interesting relationships with the blood bank. Obstetrics and gynecology, right? Obstetrics elective, obstetric emergency, obstetrics semi-emergency. So we at AIMS also run a fetal therapy unit, which is actually one of the largest fetal therapy unit, and that is thanks to the blood bank. And I would say that, you know, in the last 2 years, we have managed more than 200 transfusions, intrauterine fetal transfusions, and of which 2 cases, one case we have managed to get blood from the Japanese blood bank, anti-RH17, and we are sitting on another case like that. But having said that, obstetrics, we all know the challenge of patient blood management. When we talk about, you know, blood management in a patient of obstetrics, we feel that, okay, she's pregnant, we have to optimize her. And the entire country has not been able to manage anemia in pregnancy for the last 50 years, right? The whole national programs are trying to manage anemia in pregnancy. By the end of it, we are trying to optimize hemoglobin, but essentially we are not able to handle it. And we don't know which patient is going to have PPH. So we do try. So ideally, when we are trying to do patient blood management, we want to try and identify, okay, this patient is going to have PPH. This patient should have, you know, get the blood arranged in this, be prepared for PPH, do active management of 3rd stage of labor so that the chances of PPH are less. We all try and do that. Use good surgical techniques, you know, avoid the angle closure should be good, and good use of tranexamic acid, uterotonics, and all of that should be done. But the problem with PPH is that 60 to 70% of PPH happens when you are not expecting it. So though that is the challenge of obstetrics, that it is emergency. If you are planning something elective like gynae, what happens in gynecology is the main problem comes in gynae oncology. The benign gynecology is okay. But what happens in gynae oncology is the extent of surgery is not predictable. So that is where the problem comes, that you have arranged for 2 units of blood, but essentially what happens is that the disease extent is much more, and there is what the problem is. But one of the most dangerous issues that has come up now, and that what we are facing, is the placenta accreta syndromes, which is like, you know, the mother bleeds almost 2.5 times her own volume of blood. And for that, we do have a protocol in place where we are using interventional radiology. We use all that is possible to reduce blood. So we do use interventional radiology. We use all of the techniques which are possible. And yet we do arrange, you know, the blood, which is around 10 to 12 units and all of the components. So that is the challenge of obstetrics, that it is completely unpredictable. We do prepare. We do try and use all of the principles of patient blood management, and yet we do land up in problems. And so that is why it is to be done in all of these cases at tertiary levels. That is where the problem is, that all of this cannot handle. So we are at AIMS very fortunate that we have the most top level blood bank and we get support at all times. But that may not be possible to percolate at all levels. And one more thing that I would like to talk about is the fetal therapy part, that at one day, just 1 to 2 weeks back, I did 6 transfusions in a day. And I was tired and I exclaimed कि blood bank ही मना कर देते blood देने से, वो भी मना नहीं करते. मतलब, and I was like, you know, that is the level of commitment of the blood bank, that if we have arranged, we've requested for a blood for a hydrops who came yesterday, we get the blood. But that is the requirement of the blood which is coming from the patients who are getting referred here. That is the commitment of the blood bank, and that is being supplied. So that is the third issue, and the interaction. That is why I'm saying that is, I think we have the maximum range of interactions with the blood bank that we have.
Yes, ma'am. So, ma'am,
I just wanted to add one thing. When we are talking about obstetric hemorrhage, and in places where you don't have tag-rotan targeted therapy, if you are doing a MPP protocol, the MPP protocol is a modified MPP protocol, so 10 units of cryo added to the single unit. So if you start with that targeted NPT and then follow up with targeted therapy, you will definitely be using less components in the end.
Yes, so, ma'am, you told us one scenario, placenta accreta. So I mean, actually, going to ask you about how do you not use so many blood units, because we get almost, so that is what is different.
We have set up a protocol in place with the interventional radiology in place. So what we actually do is that we have intrauterine balloons placed on the day of surgery, and the moment we do a classical cesarean, so we localize the placenta, we don't touch the placenta, we deliver the baby and we put the intrauterine balloon. And then we do the entire hysterectomy without touching the bladder and the lower uterine segment. It is only last 10 minutes that we are actually touching the vascular field, so that the usual requirement for transfusion is usually 2 units.
So this is kind of a tool of premium, what actually is.
This is where, yes. So this is where we are, but sometimes it just very rarely that it goes out of hand, but this is what we try to do.
Even without this CME, I was going to ask you something.
Yes.
Because we had almost every week on placenta accreta or placenta pracreta.
But we try to minimize that.
We never use blood. So I think this is one great example of PBM. So are there any other scenarios where you?
So we can intraoperative cell salvage is something that I think some of the equipment is in process. I know that we are in the process of operating, and of course, pre-operative optimization, and post-operative also we give IV iron. I think that is something that we are, unless the patient is hemodynamically unstable, we don't give blood. We have definite cutoffs for giving blood transfusion in pregnancy, and IV iron is a huge tool which has come in, that we will not give blood transfusion unless the patient is hemodynamically unstable. So we have completely shifted in from blood under those circumstances.
And what about gynecology?
In gynecology, definitely the patient has to be optimized, like Dr. Vishesh was saying, that unless it's a malignancy, we don't operate at all unless the patient. So we have methods to control bleeding, build up the hemoglobin, and then only operate. So there is not an emergency. So we will not give blood. In most of the cases, give progesterone, give IV iron, build up the patient, then only operate. So we have techniques to do that unless it's a malignancy where we don't want to wait. So we build up and then we operate.
Yes,
so those are the standard techniques.
These are some of the great examples where we can see that in other branches of medicine and surgery, we can apply this particular tool. So it is not only that medicine and have to apply PBM or surgery people have to apply PBM. But see, we can see the example of activa where ballooning under radiological conditions can prevent bleeding. So I am I have witnessed it firsthand that almost everyone this year would have got more than 50% accreta, and hardly one of them would have required blood. So this is how PBM may help reducing the blood transfusions. So now anyone else would like to comment on the reduces the ma'am. So now let us go to another patient group, pediatric patient group. So as some of our discussions before actually touched upon that pediatric transfusions and other aspects, but PBM was not covered in pediatric patients. So I would like to ask Dr. Vishesh, he's a pediatric surgeon in our hospital, and he does a lot of pediatric surgery, I would say. So how these transfusion practices differ in pediatric patients? Before we understand that, we won't be able to say that PBM can be applied. We should understand these aspects. So can you just elaborate upon them?
So the patient blood management and pediatrics is definitely different, because you are the specialist, you must be knowing everything. Because if you talk about the most vulnerable age group, that is premature infants, and Dr. Satyen would agree, this is a very group which is very susceptible to everything, like the blood volume, the calculations, the cutoffs. Many factors go into that, especially as a surgeon, because it's important for me to point out, like we were talking about this cutoff of 8. But you must agree, we have years of experience behind it. We have a very well-oiled machinery, where there's a blood bank where we can get blood immediately. We have a very trained pediatric anesthetist who can give us support in the meantime during that bleeding is happening. That's why we can say that we are very comfortable at 8. You must agree that seeing from a neonate to an adolescent who's 60 kgs of weight, the amount of blood loss is assessment is experience. because just calculating a maximum allowable blood loss is not enough. You have to see how much volume has been used, how much dissection is left, what is the color of the blood, and what is the status of the patient. So these calculations, which are not there in a system which is not very well oiled. So the stress is that even in a center in which this machinery or mechanism is not well oiled, give some leeway to your surgeon, allow him to transfuse blood more liberally, because ultimately a mortality should not happen. So we should not compromise on patient safety ultimately, and we should definitely give that leeway if the institute or if the situation demands to that particular person. Regarding the practices of avoidance of blood transfusion, many things are limited because the interventions, a lot of patient blood management interventions would depend upon the size of the child. Like if we talk about a very common intervention, angioembolization, maybe feasible in an older child, but in a neonate, not possible to do angioembolization. Most of the studies that are available, they are not suitable or cannot be definitely directly applied to neonates because that's a different subgroup. But we do try, like if we remove spleen, there have been practice always that we always close the artery first so that there's enough time for the blood to drain from the spleen. So these kind of techniques we do apply, and definitely with time, we are now fortunate enough to have so many energy sources so that bleeding and is very reduced in such subgroup of patients. One another very susceptible group is a patient who's bleeding, although we don't have ECMO, patients of CDs on ECMO, but these are the patients whom probably if you give drugs beforehand, like ACA or transexamic acid, probably the bleeding will be less.
Okay, so you meant to say that pediatric patients are different as compared to the patient. So are there any scenarios you can think of where you can apply this patient blood management? When you said that some waiting time was longer days, so start them on either hand, and till the time the number comes for surgery, they are already so are there any other scenarios where you can think about you can apply PBB practices?
Like I mentioned, most of the interventions preoperatively to optimize the patient. That is one intervention that we do. So we'll definitely get the hemoglobin of the child up. And if, for example, the child can be stabilized further, like the requirement of blood won't only depend upon the hemoglobin, it will depend upon the gestational age of the child, the cardiopulmonary status of the child. So that is also important. Not getting the hemoglobin alone is not good enough. We can optimize the respiratory state of the patient, because the cutoffs are higher in patients who are on oxygen or ventilator. So if you can optimize that condition better, you can wait and probably have a more safer outcome.
Okay. Are there any surgical techniques you use to reduce the requirements?
Yes. So as I mentioned, preoperatively, we can do angioembolization to decrease the blood loss. We can take the control of the artery first, and especially because we operate a lot of EHPVO, and we also do splectomy for patients of thalassemia in which they require frequent transfusion. So there's a common practice that we close the artery first and allow that the size of the spleen to decrease in size, the spleen to decrease, and so that there's some degree of auto transfusion that is happening in the patient, which is very safe for the patient. Regarding the techniques like cell salvage, etc., in pediatrics, it's difficult. The smaller the baby, the more difficult it becomes to use these techniques of cell salvage in such group. And point of care tests like TEG, etc. I think the experience currently is more limited to liver transplant centers like MAMS, but we don't have much experience with those techniques right now in pediatric surgery.
Okay, so next to
Yeah, I'll just make some additional comments here. I do, one of my roles is the medical director of the Children's Hospital in Orlando, the blood center there. And a few additional comments, all excellent points. Other things that can be done is, because of the small blood volume, too many blood draws can lead to hospital-acquired anemia. So, collecting baseline labs, and then only if it's going to affect the clinical condition of the patient, get additional labs. And you can use microtubes too, as well. Another thing is to have a transfusion committee with individuals involved, like surgeons, individuals that anesthesiologists that use the blood products, because it's really important that it's important to have a transfusion committee with active members that are part of the blood users as well, because they're keys to making decisions as new literature becomes available. You want to make sure that there's buy-in as far as that goes. A couple other things, one of the things we do monitor at the Children's Hospital is multiple unit transfusions. And these are not in the OR, stable hospitalized patients. Again, non-bleeding patients. I'm not talking about neonates, but pediatric patients. You can give 1 unit and then check a post-transfusion, either hemoglobin or platelet count, shortly afterwards, and see if the second unit is needed. So again, I think, there's less known about patient blood management in pediatric patients. Some of it's extrapolated from the adult literature, which is never a good thing to do. I think just having the open communication, there was a good comment was made about the gynecologic surgeries that happen. And those are cases where I've been involved with. If it's somebody with multiple antibodies, it's always good to get both sides, the blood center and the hospital laboratory and the surgeon together to make sure that there's going to be ready to go with blood products on operating day. Thank you.
I just wanted to add one thing for small volume patients. We have added one more thing to our armamentarium. Well, that is sharing of samples among the labs. If it's a small volume patient and we have a small amount of sample, we usually call up the hematology, biochemistry, and the virology labs that if you have excess sample, kindly give us after you have taken the amount you need. So that, that saves multiple phlebotomy, especially if blood is requested more than once in the same day. So sometimes the blood bank becomes short if there's an allo antibody. Now you need more blood for a small volume patient to test it up. So it's a good practice to go through the hospital transfusion committee with some basically idea of how we are going to share samples if required. Once in a while.
So I think PVM can be applied to any of the fields, although the strategies may differ. We have to actually choose which strategy to apply to which population. So it is an open question. In obstetrics and in pediatrics, what strategies do you think would work more? Like ma'am said, the obstetricians are already giving iron before during the whole pregnancy gestational period, but still anemia cannot be managed. We have still the problem of anemia. So what strategies can help in managing this iron deficiency in patients?
So if I talk about obstetrics, I think if I need to summarize, I feel that, we should talk about three basic things. One is the antenatal period, when we need to optimize the mother. So the optimization of mother really starts with a prophylactic iron. And if I just give you an example, a mother who has a hemoglobin of 5 gram in the first or the second trimester, I don't need blood for her. Right. So I will, and these guidelines, we are very clear on it. And there is something called the Anemia Mukt Bharat guidelines, which talk about that we don't want to give blood for her, and we will manage her with IV iron. So we need to build her up in the first and the second trimester. Once she goes beyond 34 weeks and she's still less than 6 gram%, then only I will think of giving her blood. So the first thing is optimizing during the antenatal period, her general condition, treat her infection, and overall, so that during her pregnancy, she is a healthy patient going towards her delivery period. So that is my first pillar of patient blood management. The second pillar would be her intrapartum management, where we assess her risk for PPH, keep her ready, that okay, is she at high risk for PPH, and arrange her blood accordingly. During her delivery, once she has delivered, we should offer her active management of third stage of labor and assess. The most important part is actually the visual assessment of blood loss, which is the key problem with all the obstetricians. We are never ready to accept that she has lost blood, but increasingly we do accept now and institute fluid management early rather than late. Because, by the time we institute that fluid management, it is too late and she has gone into, shock, those problems. So that is the second pillar, that intrapartum assessment of blood loss, early institution of oxytocic measures going beyond just AMTSL. That is the most important second pillar of management. Yes, so antenatal antibody screening, the RCOG says that even if she's a blood group positive, everybody should have an ICT. For us, right now, we are not doing a blanket ICT for everybody, but we do screen for blood group for everybody, and blood group and of course type. But if she is negative, then we do the ICT screening, but routinely in an ideal setting.
Sorry? HTL, I mean, see, basically AB incompatibility is protective for the negative, D negative. So that way it is not very high, but generally negative is around 4%. So that provides D negative is around 4%, right? So that is your intrapartum part is the second pillar. And the third, of course, is the postpartum, because postpartum anemia is also huge, which is actually more than the antepartum. So in the postpartum period, now we propose that you do a hemoglobin in the postpartum period. And if she is actually moderate anemia, give IV iron and send. In the postpartum, again, unless the hemoglobin is less than 5 gram percent, we don't transfuse. So overall, we look at the patient as a whole, and we, at every point in time, we should try and manage hemoglobin in that particular manner so that we avoid blood transfusion at all levels.
I just want to add one additional comment to that is that the going even further back than the scenario you mentioned is the laboratory testing at the beginning. And so we set up at one of our hospitals, when the hemoglobin is less than 11, it automatically reflexes to a ferritin level. And then if the ferritin level is low, then we go ahead and give iron. The problem we have in the US, it's a little bit different than here, is because it's private insurance, you have to give a course of oral iron and then move on to IV iron. IV iron is really the best.
So I think so very, very nicely mentioned. So in our program, the government program says we have to have hemoglobin at 4 points. So that is 14 weeks, 20 weeks, 28 weeks, and 36 weeks. So that is something which is mandatory, but we do not have a ferritin in the system from the government. So if the hemoglobin is less than 11, we give a trial of oral iron. And if she does not respond to oral iron, then we institute the other further testing, and then she goes accordingly what is the cause, and then she goes for IV iron. So that's a system which is there.
I just wanted, this is slightly out of context, but I wanted to that when we are talking about patient blood management, I think it starts even before the antenatal period. Most of the girls, I think I remember my PGI times that we used to go to the girls' college for a camp, and there used to be sometimes 70% referral. So the hemoglobins are very low. And during my time in PGI, I went to various schools and talked to schoolgirls regarding good nutrition and iron and how to have a good diet. I think it should start even before that, because, the situation is very dire. That's why we are, when we come to the antenatal point, most of them are anemic at the point they get pregnant.
So ma'am has used to population. Dr. Moses, do you want to add something in the population? What strategies would be?
The same thing, like the main thing is, that the incidence of iron deficiency anemia is pretty high. So what we usually do practically is that once the patient comes, we definitely get a hemogram done. If the hemoglobin is less, we send the patient on oral hematomix. If he does not improve, then to Mukul for treatment and management, and to find the reason why his hemoglobin is not coming up. And we try to optimize the patient, because a lot of patients that we get are also patients who have cardiac problems, or they're referred by the pulmonology unit. So definitely we'll ensure that once we are taking this patient, this is optimized in total way. So that is our pre-operative preparation for the patient. And during surgery, definitely that visual, like Dr. Aparna mentioned, that visual assessment of blood loss and very critical decision when to give blood, when not to give blood is important. And definitely again, because most of these patients are patients who will require a staged procedure and a plan for another surgery. So these patients will remain on iron for pretty much even after the last stage is done, for 6 months after that. And similar for oncology, the patient, the day we get a pediatric solid tumor, because we give chemo for pediatric solid tumors also, that day we'll start the patient on some multivitamin and iron, and that will remain throughout till the chemo is finished 6 months after that, because the patient will undergo a lot of procedure in between. So we are very liberal with our iron management to the patient.
So I think pre-operative management or the first pillar is one which can be targeted for hemoglobin. I think most of our surgeons are doing the surgical interventions very although we don't call them under the banner of PVM, but they are already practicing what I can say. Although this was not included in the panel, I just want to assert him. We will see a role of transfusion medicine in PVM. See, they are already giving oral iron before surgery. They are already considering anemia, looking for ferritin if the patient does not respond to oral iron. So, what role do you see for a transfusion medicine?
So, one of the areas where we can definitely work is asking for a limited sample. to begin with, so that we don't ask them for repeated sampling. If we have one sample, it happens if the kid is admitted for a long time, has gone for surgery. I have a 3-day-old, 4-day-old sample. It's a newborn. I could use that sample to give another unit of blood instead of asking another sample, which I know a 3-day-old baby won't be making any new antibodies. I'm sure of the blood group that I have done. Another area is obviously working with the evidence which is available with us on defining the cutoff of use of various blood components. When you can go for intraoperative, for support of surgical patients, both pediatric surgery, adults, cardiac surgery, and liver surgeries, is adaptation of the POCTs, that is the point of care testing. If that is not available with the other departments in the institute, the blood center or the transfusion medicine person can actually initiate that service for the clinical sites, that you have the coagulation profile, you could run the TEG in your center, and that is something that you can offer, and you can help working with the anesthetist, that what kind of blood component that can be offered to these patients. Yeah, and I think in pediatrics specifically, even availability of the aliquots, of PRBC aliquots, even we have attempted to use volume reduced RDPs, because 2-day-old preterm may not be able to take a 60-70 ml of complete RDP unit. So we volume reduced the RDP with a spin, and we offered them a concentrated 20 ml, 30 ml of that product. So even all these things, and some of the special scenarios that have come up is the cyanotic heart disease. So in cases of TOF, you never get enough sample. You keep on asking to them, you never get enough plasma in the sample, and there is repeated phlebotomy for more units that are required. So yes, in different clinical scenarios, our involvement and our participation and the scope of participation is definitely there.
Okay, so I am a lot of transfusion specialist, and I think a lot of practices have already been practiced. So I think Dr. Mukherjee has something to add. Yes, ma'am, any massive transfusion. We also have.
So the pediatric patient, Dr. Bishes has told, like he has already told in the second this thing, that what is the practices for elective surgery when they're coming to they're very well practicing it. They're sent back on the hemodynamic sarin and folic acid, they're drawn back again. And about the intraoperative use in the of the PBM in pediatric age group, one example that I have seen is juvenile nasopharyngeal angiofibroma, though they are not coming to that. But ENT pediatric population, we do practice intraoperative management of PBM. And one more thing I wanted to ask you, actually. He has already told that why we are getting 100 ml of blood in 2 kg coming from the blood bank. So how it can be tackled? He has acted. I want your answer in that. What are you going to do for that?
It is expensive cost.
I think, sir, aliquoting is something that was one of the first thing that we had to work upon. And I'm sure there's some must.
Everything comes down to cost, I think. Yes. See, you need to have resources to practice aliquoting, and then those aliquots should be used judiciously. So we aliquoted 1 unit into 3 halves, and rest 2 halves are getting wasted. So that is something was happening at our place.
Actually, just to add on it, we have recently submitted our experience of aliquoting, and I have also done an international survey of how aliquoting is being done for neonatal transfusion across the world. And what we found, and it's published as an international forum, and what we found out was there were 3 types of aliquoting practices that are being done. One is you give what is asked, means you've asked 10 ml per kg and it's a 2 kg child, we'll give you 20 ml. So that is one practice. Another practice is, which is practiced in UK, is they keep fixed volume aliquots. They have an inventory of 45 to 50 ml aliquots available with them in their hospital for neonatal use. The third policy is something that we practiced in our institute, and I think maybe AIMS is also following that, is we make 3 equal aliquots of our all PRBCs. So the volume ranges from 80 ml to 110 ml, depending on the bag's primary volume. And that gives us more control on the inventory. Plus, the blood doesn't get wasted. So we have this aliquot going to some patient. He may need 110 or he may need, 60 ml. But there is a fixed aliquot, and even the prescribing surgeon or the pediatrician knows if I order one pedi bag, I'll get 80 to 100 ml. So we can even do a quality control of that bag. We can ensure what is the amount of RBCs that you're getting. And we have submitted that experience. And last 1 year, our discard rate and following the strategy 3 has been less than 2%. And we have used more than 525 aliquots in a span of 1 year in variety of indications, more in surgical and NICU and emergency, pediatric emergency.
Actually, that may be possible in pediatric only.
Yes. So this is what has concluded that, a blood center may use all three type of strategies.
Yes.
In a center like AIMS, you may use all three types.
We actually aliquot based on demand. Whenever it is asked, we aliquot and give. We don't keep aliquot in inventory because most of the time it gets wasted for us. Yeah. So, Dr. Mukul has something to add. Yeah, the mic reaches him. So we have utilized this PVM for a lot of patients where blood is not available. Like I remember there was one patient with very rare phenotype, PP1 PK. So P-null phenotype. So we don't have facilities to actually at that time we didn't have antibodies. Now I have. So to get to know the diagnosis, the sample has to be sent to UK. To get to know the result, it would take around 1 month. Minimum 1 month. So in that 1 month, I requested my gynecologist. The patient was a bicornuate uterus. So I requested them to do iron and you won't require blood. So till the time we got to know the antibody, the patient was operated and gone home without blood. So that is one very good example of PVM and one scenario where we can actually utilize these practices.
It's really heartening to see so much discussion, and we all agree that iron deficiency anemia is very common. But please remember that its prevalence is still around 50-60% of our population. Anemia is not equal to iron deficiency unless you prove it. So please try to incorporate ferritin in your initial workup for patients who are going to be there or for chronic, hospitalization and surgeries. Beyond that, if it is not iron deficiency, we hematologists are more than eager to help you in finding the cause.
So actually, when we were discussing PVM, we realized that we don't have any data on preoperative anemia in India.
So there is no data. I didn't find any published data, and when I was looking for pediatrics, there was null. So this is an ongoing project that we are doing with our pediatric anesthesia team. Is we are screening and we are collecting the data of all the PSA that they are doing, and what is the incidence of operative anemia that we are seeing in our patients in the pediatric age group. And we've just started it this year. We hope by end of next year or by this time next year, we'll be having some data of last 1 year experience or more than around 1,000 pediatric PSAs that has been done.
Yeah, so we lack a lot of data, but we are already practicing PVM. Anyone else would like to have some comments?
Thank you, sir. Actually, I came to an idea like if there is a pack testing, the pre-anesthetic checkup is there before surgery, there could be a pre-operative transfusion checkup for the patient. Like in some cases, we are not doing any ICT of the patient.
I think we used to practice this before, I think quite a long time back. The patient would come to the blood bank and a surgeon will tell this many units are required, blood grouping would be done, but the practice has gone away, I think now. Earlier it used to be done, and PVC is usually done just before the day of surgery in our institute.
Done from the OPD itself, and one PSA is done after admission.
Departments where the patient is and operating in morning. So,
Elective surgery, so it happen both ways.
So, as Dr. Vishes rightly pointed out that strategy that when the patient gets a date, at that time only it should be iron profiling and other things. So, yes, so that is the most visible strategy which could be.
All patients are supposed to come. So we had time to talk to them and arrange for you. Are already
But that practice has gone with the volumes increasing. So yes. Yes.
So, more important, I would like to highlight that you said that we do not do ICT in all the patients in antenatal. But what, yeah, it is not a general practice in all the hospitals, but I think it should be practiced. It should be practiced because as you say, we don't know which patient will be for PPH or APH, and we do not know which patient will be having antibodies. If you doing only type on grouping will be done, and at the time of patient is referred from the periphery.
SOGC international guidelines.
I'm sorry.
It is the lack of resources that we are not able to do. But
So-
just to add that we are doing blood group and antibody for everybody. It is that we are not routinely screening for ICT. It is a standard recommendation, but government of India does not say do ICT for everybody. Just do blood group.
So at least in our institute, we are doing them. Whenever you are sending someone for a blood group, no, whenever you are sending a blood group request also, we are doing ICT in our patients. And report also, you have never checked actually. See, no. There are a lot of RH positive patients where there are antibodies. So if a blood group request is received in blood bank for a preoperative patient or PNC, we are doing blood grouping for all of them, ma'am. So if you look at the report, you will find it, ma'am. So this we are doing from last 3 years.
Actually, there was an interesting case of IVF case actually.
All.
And there was an IVF case at all. I received a request from the private nursing home. Egg was also donor. There was donor egg and sperm. Both incompatibility for the mother was there from both sides. And she had a multiple antibodies which I could not discern at that time. I had a antibody screen identification panel. I ran that panel, but there were multiple antibodies. I had to do around 30 cross matches to get 2 units compatible for the child who was suffering from ADHD.
So
Something that we are doing right now.
we are doing every day. So I think ma'am, this ICT, what you mean to say is if you are doing ICT, that would add to one of the PBM strategies. That is what you are saying. Okay. So I think we would close this discussion now. I would conclude that PBM is considering almost all scenarios. Okay, sir.
No, I
Yes, sir.
just wanted to add one incident. I think we regularly hold an antenatal clinic in our institute. So where from our Department of Transfusion Medicine resident goes and collect the antenatal samples, even positive and negative both. And I mean, the ones who have suspected of then we work up them for these antibodies and all. But once upon a time, yeah, is it okay now? Once upon a time, what the patient and her husband used to come, and we used to make a point that the husband also donates. Because if he doesn't donate, then we say, "Bhai, ये गलत बात है, आपको donation करना है इसके लिए." So sometimes then, I mean, that was a strategy at those point. The voluntary blood donation was not that optimum, but now we have quite a few voluntary donors, around more than 90%. So at that point of time, and some husbands used to refuse, nahi bhai, iske liye nahi karna, main nahi do. I mean, for donating her, it is better to I can have another wife. So I mean, that is, that sort of a belief was there. I mean, this is just on a lighter note I wanted to add here. So yeah, I mean, these kind of strategies, yeah, wonderfully. I think all of you did a great job. Sorry. Yeah.
I think we have one more hand, sir.
Because I want to ask your view. So among those 3 pillars that we have discussed in the PBM, as per you, what is the most important one which you focus? Like
So
suppose
we are already focusing, but we are not giving it the name of PBM, what I feel. So we are, as Dr. Vishay said, I think he has not into the PBM before this. but he was already practicing. He was doing pre-operative iron profiling and all. So, ma'am, I think obstetricians are practicing PVM from very long.
No, so all
Yes, we don't call it PVM, but we are already practicing the first pillar.
yeah. So
And second pillar also. Yes.
Call it that I jumped to transfusion.
Yes.
That would be called PVM. For me, it is that.
So
It's like-
this is for the panel. So I would believe that all these three pillars are not
No pillars are important. I think based on patient, what is the best that you have to decide.
Okay, that pillar you have to choose.
So that decision has to be a team approach. That is what we is, I think. The team has to be the surgeon, the anesthetist, the blood banker, the nursing staff who is involved, the patient himself, as the morning lectures were telling. So it's a team approach, and when all of us are discussing the patient blood needs and how we can improve upon the patient condition himself, that blood is not required or required in a very minimum amount. So that is what is premium. So that approach would change from patient to patient. Like I said, in the patient where only an antibody is there and blood could not be arranged, where
first pillar will become important.
First pillar became more important. So
Likewise,
even
surgical technique.
See, the first pillar would not only be the pillar which has to be optimized in that case, because if despite having high hemoglobin, if the patient bleeds, then it has no use. So the second pillar also would come into use, that bleeding has risk has to be assessed. It has to be minimized. The drugs and medication have to be optimized. So you cannot say that this is more important, this is not important. All of them are important, but it has to be optimized to the patient, and discussion has a very important role in that optimization.
Item note, just to paraphrase what Abhishek sir has just told, like deciding transfusion is just like marriage. So I would say that PBM is just like after marriage. So we have to sit together, decide upon the clinicians and all those things. So I just thought this is. Thank you.
So,
Prem, can I add?
yes, yes, definitely.
Okay, so since we are winding up the session, so what I felt was I am closely following up obstetric PBM for past 2-3 years. So my comment, since we had this discussion that we are facing a lot of cases with antenatal anemia. So far in India, we are so populous that now we have to go backwards as well. So what I was missing here, not per se for the team, what I was missing here was community involvement. So now even we did a study where we found that more than 63% of the women, antenatal women were anemic, and moderately anemic. So that means something has to go backwards. So that means somebody should be educating them right when anemia, there is onset of anemia. So that happens in India with the onset of puberty as well. So it has to come, during, you can say college time or something, something like that. And then as a marital, this thing also testing. So it should be tested there and then. And when you are expecting that you would get gravida 4, 5, 6, 7 and with 5 hemoglobin, then that has to percolate. So community involvement should also be there. This
So another
just observation.
Okay.
And also, as ma'am said, something for upon. Yeah, exactly.
Yes,
Because
yes.
this is evidence. We have evidence at our homes as well.
It's not only female
Yeah.
population, but our male population is also anemic.
Exactly, because we are those,
Yes,
at
ma'am.
height and everything.
Recently, I think even Director General Health Services, ma'am, and I was meeting him for some other purpose. So he called us that I went to a blood donation camp recently. It is a college camp, all 19, 20-year-old students. And he said, I was surprised 50 to 60% of them are anemic, less than 12.5 gram per DL. So it is a common problem. It is not a problem of only female.
No, that is the root cause and we have to act on that. So
Yes.
there comes the role of ministry and government.
Yes.
Another thing, as Aparna ma'am was discussing about PPH. Yes, ma'am, studies say that, when women are anemic, there is a risk of, and then they thought that keeping the cutoff at 10, you can just, so that again tells the story of our country. We have many women. Yeah.
That is the worst thing.
So beyond that, so you're
Not change the level of problem. Decrease the level of anemia. They say to change the definition of
anemia. Yeah.
That they could have. But I think that, anemia is something that is really prevalent and
Correct.
we've not been able
Yes,
to
yes,
understand
yeah.
And
factors,
also,
cultural factors,
yeah.
dietary factors.
And also adding on to Mukul sir, as he said, we have to diagnose the basically, we have to diagnose the cause of this anemia. So unless we are identifying it,
So
unnecessarily giving iron and.
that is what I'm saying. The team has to include all the relevant partners. They have to decide this is our protocol, this is how we should approach. And it is possible in any population, any of the patient population, not be only surgical patients or hematology patients. So it is possible in all patient groups, but it has to be a team approach. Everyone who is involved should be part of the team. A protocol should be devised and optimized for patients. That is what I would
Thank
say.
you so much.
So I would like to thank all the panelists for this very good discussion and even the audience who became part of the panel itself. So I would now hand over the mic to my hosts, जो भी है. Yes, Master.
So that was a very energetic session with the participation of both panelists as well as the audience. I don't know who is the panelist here and who is the audience here. All were actively participating with a lot of queries and all were sharing their experiences knowingly or without knowingly. Everybody is doing PBM at one point of their time. And with their experiences, we can know that DC is also part of PBM and we can also establish in our institute, depending on our facilities, resources, manpower, everything that is available. And thank you for this session. And now may I request Dr. Gopal Patida sir and Rahul sir to please come onto the stage to felicitate this panelist. I request Dr. Satyam Arora sir to please come forward. Thank you so much, sir. I now request Dr. Vishesh Jain sir to please come forward. I request Dr. Gopal sir also to join Dr. Rahul sir in presenting the. Thank you, Vishesh sir. Now I request Dr. Aparna ma'am to please come forward. Now I request Dr. Hem sir to felicitate Aparna ma'am. I should say both Hem sir and Aparna ma'am have actually implemented a lot of practices to establish PBM in our institute.
Yeah, sir.
Thus, we have come to the culmination of today's CME. We hope we are able to do justice to the theme. I request Dr. Rahul Chaurasi sir to deliver the vote of thanks.
Thank you. This session cannot come to the end without the sense of gratitude to all the speakers, to all the delegates who have traveled so far to attend this session. We also like to thank our supporters, International Society of Blood Transfusion, Steranco Healthcare, and Qualis Diagnostics for supporting us in organizing this event. I would also like to thank the organizing team members who have worked so hard for making this a resounding success. Thank you all.
So thank you, sir. Okay, so it's goodbye from us until we meet again. And before that, we have arranged some refreshments for you. So kindly enjoy it. And we'll meet in the next CME session. Thank you.